And usually when we extract it, then we inject it into tendon. This is a case of ankle ATFL tear and also CFL. And this patient actually responded quite well post-procedure. So Guna is this tissue collagen supplementation that is actually now currently present. I use it quite a lot for my patients, sports athletes who actually develop muscle tears and all that. And this basically is a triple helix structure of collagen. It's a tropocollagen which has a basic unit of mature collagen. And so it causes healing via anisotropic and tensile force transmission with healing essentials leading up to a collagen buildup and resolution of the patient's injury. And it replaces, supports, and reinforces as well as protects the connective tissue as well and increases conditions of anisotropy. Works quite well for patients who develop tendon tears, especially footballers. And I do that quite a lot for my National Footballing Association in my hospital. And functional tissue engineering of ligament healing. These are some of the recent articles that have, that highlighted the use of Guna for a lot of our patients. So treatment protocol usually for acute pain is one treatment, one injection twice a week. And if symptoms continue, you do it one treatment a week after that. And for chronic pain, you can go up to one a week for about 3 to 5 weeks. So a lot of these patients usually only require about 2, maximum 3 injections, rarely more than that. So moving on, again, secretomes. I do a lot of secretome injections also. So secretomes are bioactive signalers derived from healthy MSC cells that stimulate repair and tissue regeneration of the human body. And they are actually a powerful cocktail of bioactive molecules. And usually what it does, it stimulates tissue repair, protecting cells, and promotes healing via angiogenesis promotion, reducing inflammation and natural pluripotent. So the difference between MSC of multipotent mesenchymal stem cells and secretome is important. Mesenchymal stem cells have live, healthy cells within it, but secretome has no cellular component. In Malaysia, we at least in my country, we cannot inject any cellular component into patients. So that's why, because secretome has no cellular component, it is a collection of substances like protein released by MSCs. We can usually safely administer it for a lot of our patients, and it works quite well with good outcomes that I see. So again, the difference, you may ask, what is the difference between PRP and secretome therapy? So this is derived from the donor, whereas this is derived, the PRP is from the patient's own blood. The secretome therapy has an additional property of reducing inflammation in higher properties, and also it's consistent regardless of age, whereas the PRP, actually the quality of PRP depends on the patient's age because you're harvesting it from the patient's own inherent bloodstream. And the chemical nature is neutral, whereas in PRP is acidic. And preparation time is actually quite immediate. When you just bring it, it is all frozen. You just need to thaw it before you actually administer it to the patient. And it has an anti-inflammatory function and protecting cell as well as promotion of healing. So again, the other comparison that you would like to know is what's the difference between secretome and exosomes. So exosomes has tiny bubble-like structures that carry specific material, whereas this one is a broader mix of substances released by cells, including exosomes. So secretome does compose of exosomes, but exosomes do not have any secretomes within it. So in summary, exosomes are specific, tiny delivery packages with targeted content, while secretomes are full array of substances released by cells, including exosomes and other materials, serving a wider range of functions in healing and communications. So in summary, shoulder intervention can be carried out by ultrasound or fluoroscopy guidance. Careful physical examination and scrutinizing the history and imaging is essential on selecting the course of treatment. Steroid PRP injections were the mainstay of treatment, but have been largely replaced by newer injectables such as secretome and stem cells. Thank you. That's the end of my presentation.
Thank you, Dr. Naveen, for that very comprehensive talk. Are there any questions from the floor? Yeah, please. You have a mic in front of you. Please go ahead.
Last 2 minutes.
Thank you for a wonderful lecture. My question is in hemiplegics. I am a physical medicine and rehabilitation physician, or physiatrist we call this. So what is the role of injection in shoulder restriction movements in hemiplegics?
In pardon, in hemiplegic.
Yeah, hemiplegic, long term. I used to rehabilitate such patients, and they find it very difficult because of the restricted movement of the shoulder for ADL, activities of daily living. Could you please explain if this injection is going to be helpful? Then we can improve the activities of daily living, particularly right-handed individuals.
Okay, so I think at the end of the day, it depends on the cause of the pain of the patient's restriction of movement. If it's osteoarthritis or
No, it is because of spasticity.
spasticity, I see.
Yeah.
So spasticity is something that has very limited role on my side. I've never treated patients with spasticity in regards to shoulder restriction. So that I have.
So my question is,
sorry, I cannot
it will
contribute
go
to
to
it.
shoulder hand syndrome, the pain, very severe pain. Yeah, the shoulder hand syndrome we call it as, and it is very painful condition. That is one thing. And some of the patients in the acute stage of stroke, there will be a subluxation of shoulder, and that will also can produce a pain. In such patients, what is the role of this, your suggestion and medication?
I mean, have you tried? Did you try giving them intra-articular injections and all that for these patients?
In my experience, very few, not so much.
Not so much.
Yeah.
And
But because now this is a recent trend now, PRP and all those things that you explained. So will it be helpful for that?
I mean, I have no experience, but if the cause of the pain is actually, because usually PRP, if we talk about guna and we talk about giving a secretome and all that, it is basically an anti-inflammatory into space. So I do it quite a lot together with my hyaluronic acid injections for patients with osteoarthritis, and works quite well for patients in the knee and in the shoulder as well as in the hip. Because even for patients in the hip, also those who are unsuitable to undergo surgery, usually if you go and see orthopedic surgeons, usually will say the patient needs to go for a total hip replacement. And I've treated quite a lot of patients with this secretome and hyaluronic acid injections under fluoroscopy into the hip, and a lot of those patients have actually very good healing outcomes after that. I wouldn't see any contradictions of actually trying to do something like that for your patients for the shoulder side, as long as the cause of the pain is intra-articular. If it's outside if it's not the intra-articular cause of the patient's pain, then we need to actually try and treat what is the source of the patient's pain.
Yeah, thank you. Thank you.
Time is up.
So for the next talk, it's my pleasure to invite Dr. Nishit Kumar. Dr. Nishit Kumar is a professor of radiology working at Sports Injury Center, VMMC and Safdarjung Hospital. And he has vast experience in musculoskeletal interventions. So Dr. Nishit, over to you.
Yeah, thank you, Dr. Anku, for the kind words. And so we move to the one very specific condition, and that's the frozen shoulder and the adhesive capsulitis. So the first thing is that the patient has a generalized restriction in the movement, but it is not the muscle that is causing the pain. So it is a difficult disease to define. It is a difficult condition to understand, and the interest in the disease has increased after the COVID pandemic. So we'll see over the next 10 minutes what we can understand from this disease. So I wish I had something to disclose, and I have no conflict of interest. So I'm going to talk about the pathophysiology and what is the rationale for the interventions that we do, ultrasound guided, the techniques of the interventions, and what is the evidence to support these interventions. So pathophysiologically, it is a condition which is not involving the muscle. The muscle is getting involved secondarily in adhesive capsulitis. It is primarily a capsulo-ligamentous disorder, and the first structure that is getting involved is the rotator interval. To be more precise, the coracohumeral ligament, and that is what we see over here, the coracohumeral ligament and the superior glenohumeral ligament complex. So the primary pathology lies in the rotator interval. If we do the ultrasound, what we see is that this is the normal thickness of the coracohumeral ligament over here, there's a significant increase in the thickness if we do the ultrasound. And remember that imaging is not done to diagnose adhesive capsulitis. Adhesive capsulitis is diagnosed clinically. So the rotator interval involvement, there is a restriction of the external rotation, and because of the secondary involvement of the joint capsule, which is a facilitator of the movement, there is a mechanical block to the global movement of the shoulder. The LHBT, that is the long head of the biceps tendon, is getting involved, and that leads to a painful restricted motion. And secondly, there is involvement of the muscles. There is the shoulder dyskinesia, and that leads in an incoordinated shoulder movement and a scapular dyskinesia. So what we get in the imaging, we have already seen there is thickening of the coracohumeral ligament. If we see the axillary recess, that is the capsule part, that is the inferior glenohumeral ligament, that is getting affected and involved. Basically, the imaging is done to rule out secondary causes of the adhesive capsulitis. So the rationale is that we are targeting the rotator interval, and that is why we prefer doing an anterior interventions. So we widen the stenotic rotator interval, and at the same time we are trying to increase the capsular compliance, and we prefer doing an anterior hydrodilatation to the posterior hydrodilatation, and also increase the elasticity of the fibrotic and stiff coracohumeral ligament. And how do we do that? We do a facial hydro release for the coracohumeral ligament. And when we're coming back, there is also a fibrotic reaction in the bursa that is happening. So we do a hydrodissection of the fibrotic subacromium subdeltoid bursa. So the indications, usually the first, when the patient comes to the orthopods, it is treated conservatively. The patient is put on the rehab. The patient is not responding to the conservative measures, and despite 3 months of bout treatment, there is a significant reduction in the movement. That is the time when the patient is being referred to us for the interventions. And also, if the patient is having a painful physiotherapy and there is a contraindication to the analgesics, we need to understand that one of the common disease where there is the adhesive capsulitis is diabetes, and diabetes is also known to cause nephropathy. So the patients, they are usually not put, the orthopedic surgeons do not want to keep them on a long-term analgesics as well. So the contraindications for any of the musculoskeletal disorders, active infection around the local site, allergic to the injectables, uncontrolled diabetes. We need to control the diabetes before we can do it and do the hydrodilatation procedures, because most of these have steroid, and there is a concomitant severe osteoarthritis of the shoulder joint. That is the time we do not do that. So when we talk about the intervention that we are going to do, so it is usually an anterior hydrodilatation. So we are increasing the compliance of this capsule. We are stretching the capsule, and this is the usual tray that we use. We use about 40 ml of the solution. We use 80 mg of the triamcinolone. So 30 ml into the joint through the anterior root, and then 10 ml into the bursa. So we do the facial hydro release of the coracohumeral ligament, and we do the bursa. So it's a personal preference. We can do from the lateral to the medial, or from the medial to the lateral. The important thing is the target. It is a very precise target that we are targeting into the roof of the interval, and as well as onto the floor of the interval. And we can use a color Doppler to make the patient see the flow of the injectant into the joint, because that is the colors that they are more understandable for them. And the medial to lateral, we go into the from the medial subscapularis root. So it is thought that the medial root has a larger area. We do not cross the supraspinatus, and the patient has a less of the pain. So when we talk about a capsule rupturing versus a capsule preserving procedures, what we prefer to do is a capsule preserving. We started doing with the capsule rupturing, and now we have moved to the capsule preserving, because more of the injected will remain into the joint, and that is it will act into the joint for a longer duration of the time. When we talk about the facial hydro release, when we are taking the needle out, this is the needle out here, and this is the coracohumeral ligament. So we do a slow high resistance injection into the coracohumeral ligament, and that will soften the ligament. And it has been seen that if we do a post intervention elastograms, we'll have a better elasticity or a decreased stiffness of the coracohumeral ligament. So there is evidence to support all of this, and the capsular preserving is better than the capsular capsular rupturing. There's this article in the Skeletal Radiology 2024. You can go through the article. Anterior hydrodilatation is preferred than the posterior hydrodilatation because most of the disease starts anteriorly. The coracohumeral ligament is the usual culprit. So what we do is that we go and do injection hydrodilatation. We can tackle the capsule. We can also treat the ligament. And when we're taking it out, there's a fibrotic response in the bursa. There's subacromial impingement. So we inject into the bursa as well. And recent studies have shown that they combine the hydrodilatation and the suprascapular nerve block with the rehabilitation, and the idea is that they are tackling the muscle spasm that is happening secondarily. So once they do a suprascapular nerve block and the patient becomes more compliant for the physiotherapy, the hydrodilatation procedure becomes less painful. So the physiotherapy can be started immediately on the same day when the patient is visiting for the hydrodilatation, though we usually combine the hydrodilatation with the facial hydrolase, ask the patient to come after 48 hours and then start with the rehab procedures. Post ultrasound interventions, we usually do a VAS and the range of the motion we see, and also we can do a rotator interval thickness, the coracohumeral ligament to the SGHL ratio thickness, and that we see. And this is the post intervention. We can see that the range of the motion has improved significantly. So to conclude, adhesive capsulitis is, I know, this is a very interesting hooter that we have.
Last 2 minutes.
Yeah, of course. So adhesive capsulitis is a disease not of the muscle. It is a rotator interval centric capsular disease. Ultrasound guided interventions will restore the capsular compliance and it will allow the muscles to function normally, and it is not going to replace the rehabilitation. Basically, it enables the patient to undertake the rehabilitation. The rehabilitation becomes more painless and the patient becomes more compliant for these rehabilitation. And thank you all for your patient hearing, and any of the questions I am most welcome. And these are the two of the interesting conferences that is going to happen in the coming time. We have the European Society of the Skeletal Radiology 2026 happening at Manchester. A very dear friend of us, Dr. Radesh, is the chairperson for the conference. And then we have the Asian Musculoskeletal combined with the Musculoskeletal Society of India conference happening in August 7 to 9 in Ahmedabad. So if you're more interested into the spine or to the all parts of the musculoskeletal system, and you are most welcome to register for the same. Thank you so much. Any of the questions from the audience, most welcome.
Thank you, Prof. Nitid, for that engaging lecture. And I would like to now invite any of the audience, if they have any questions, to pose to Prof. Nishit. Anyone?
No questions means.
Nobody? Okay, all right. Thank you, Prof. Nishit, for that wonderful lecture. And please give him a round of applause.
Oh, thank you.
And we'll definitely look forward to coming for your AMS and also for the
sure.
for the meeting in Manchester as well. Thank you. Thank you.
Thank you so much.
Thank you. All right. So again, I invite you all to give a round of applause to Prof. Nishit, and we will now move to our next speaker for this morning session, cracking the tunnel, image-guided interventions in CTS. We now invite Dr. Raghav Seth to deliver his talk. He is a consultant at the Department of Interventional Radiology of Sir Gangaram Hospital in New Delhi, and I'm sure he has a very exhilarating lecture to deliver to us today. So without further ado, we invite Dr. Raghav.
Thank you, sir. So good morning, everyone. So I'll be discussing about the interventions in carpal tunnel syndrome. So first of all, before discussing about the interventions, we all know that it is compression neuropathy of the median nerve at the level of the wrist because of the increased pressure at the fibroosseous carpal tunnel, and resulting in pain, numbness, tingling, mainly in the distribution of the median nerve. So it is a fairly common, 1 to 5% is the estimated prevalence, and it is the most common entrapment neuropathy, more common in females. The main point here is that it is affecting the working population as well, so leading to the loss of their work and earning loss. That is why the clinical impact is important, and that is why we need to treat these cases. So this is just for the anatomical foundation. We all know that the median nerve is superficial to the flexor tendons and the roof of the tunnel is formed by the transverse carpal tunnel, ulnar nerve and artery medially in the Guyon's canal or Guyon's tunnel. So this picture is a gross picture that I have just included here to show the anatomy. So this is the median nerve, these are the flexor tendons, and the transverse carpal ligament here with the ulnar artery on the medial side. Sorry. So I'll just play this video. Basically, this is now transition to the ultrasound anatomy. So similarly, the flexor tendons and the median now highlighted in green, the transverse carpal ligament and the ulnar artery medially. So yeah. So pathophysiology of median nerve compression is the increased tunnel pressure leading to nerve compression, nerve edema, swelling and structural damage. So basically summarizing this in this image, you can see here that the proximal part of the median nerve is swelled up with increased cross-sectional area and because of the venous congestion and edema, and that is leading to the structural damage and the symptoms. So how do we diagnose it? Clinical examination, of course, is the first line, nerve conduction studies and imaging. So imaging wise, ultrasound is the modality of choice, and the diagnostic threshold that is commonly followed is 10 millimeter square. That is for the cross-sectional area of the median nerve at the level of the carpal tunnel. Whereas if we compare the cross-sectional area between the carpal tunnel inlet and the pronator quadratus level, 2 millimeter square difference between them is actually an indicator, good indicator for the nerve compression. So in this image we can see that at the level of the carpal tunnel inlet it is 14.5 and 9 at the level of the pronator quadratus, so difference is more than 2. So one of the cases done by me here, the cross sectional area, we can see that the median nerve is thickened. We will look at the treatment in the subsequent slides. The grading is again on the basis of ultrasound cross sectional area as well as on the nerve conduction studies, so mild, moderate and severe. Just finally discussing all this, coming to the treatment, that is the main part. So conservative management is of course always the first line. If it fails, then only if it fails, patient is not responding to NSAIDs, activity modification, risk splinting, then we move on to the interventions. In interventions, we have ultrasound guided carpal tunnel release or hydrodissection, steroid injections, and also the other regenerative treatment options. Surgical option is of course the last. Now, how do we decide whether we have to go for carpal tunnel release or whether we should go for the injection or hydrodissection only? So if it is mild to moderate depending on the cross-sectional area and patient is having only sensory symptoms mostly, the ultrasound guided injections are preferred, whereas directly if patient has presented to us with a significantly thickened nerve and atrophy, even motor symptoms, we can directly consider ultrasound guided carpal tunnel release. So mild to moderate carpal tunnel syndrome, sensory symptoms, failed conservative, even many pregnancy related CTS are usually coming to the OPD, are for the steroid injection. Contraindications for these include, for steroid especially, local infection, steroid allergy, uncontrolled diabetes. So these are rather the indications for hydrodissection using other agents like 5% dextrose. So patients, same thing, diabetic or steroid failure. So studies have proven that the 5% dextrose injections have a longer lasting effect. I'll show that in the literature review. Whereas for carpal tunnel release, as I mentioned earlier, the more severe symptoms, persistent symptoms or higher grades can directly move on to carpal tunnel release. For the injections, ultrasound guided, either the ulnar or lateral, both approaches are preferable. Gold standard is the transverse ulnar approach. So we have to protect the ulnar artery and nerve, and this is the three-dimensional diagram. So we have to come through the transverse carpal ligament and we have to hydrodissect or inject the injectate around the median nerve, that is 360 degrees. So circumferential spread should be there so that the nerve is peeled away from the TCL. Apart from the axial, we should also do it in a sagittal longitudinal way to just see the spread of the injectate all along the distribution of the nerve. These are two important parameters, the transverse safe zone and longitudinal safe zone, which are more relevant for carpal tunnel release, but we should be knowing about them. At least distance between the danger, that is ulnar artery, should be 1 mm in transverse safe zone, whereas for longitudinal 2 mm between the palmar arch and the median nerve. When we are using corticosteroids, usual dose is usually triamcinolone 40 milligram. You can combine 1% lidocaine. Whereas if you're using 5% dextrose, then the amount usually is required more than the steroid. So 10 ml of amount. Of course, we have to prevent intraneural injection. Mechanism, apart from pharmacological or pharmaceutical, I mean the mechanical separation is the most important. That is the restored nerve gliding and adhesolysis. But of course, anti-inflammatory effects are also there, and downregulation of receptors, as we know in the dextrose injections. So this is again one of the recently done cases by me, bilateral median nerve thickening. And so basically when we are tracing the median nerve from proximal to distal, so when we come at the level of the carpal tunnel inlet, we can see that the median nerve becomes thickened, more hypoechoic, palmar bowing of the flexor retinaculum. These are the signs. After giving local anesthesia, what you need to do is just hydrodissect the nerve 360 degrees. So it is not only anteriorly, posteriorly, both ways. And of course, intraneural injection is avoided. Latest studies also indicate microfenestration of the transverse carpal ligament also helps. So that helps in preventing the recurrence and for a long-term response. So again, another case. So the main idea is that the injected should come 360 degrees around the nerve. That is the main idea. This is just a fast forwarded video, both anteriorly and posteriorly. Coming to the next part, that is the carpal tunnel release. So devices are available like one of these, which have cutting blade and balloon to separate the median nerve and ulnar artery. Again, under ultrasound guidance, this can be done. And then this can lead to, then the blade part can be used for retrograde transaction, and it can be confirmed on the ultrasound that the TCL gap is visible. But more affordable, more easy, and a basic intervention if the injection fails is the thread carpal tunnel release, which is very easy, and all of us can do that as interventional radiologists. So just a superficial and a deep thread. I'll just show you the schematic video also. So below and above the transverse carpal ligament, under ultrasound guidance, we can pass a suture, non-absorbable simple suture through one of these. Then again the second injection. So this is the curved needle which is used for that, and when it is done, we can just fix it there, and we can just sever the suture so that we are basically cutting that part of the transverse carpal ligament. So this is the deep part. This is the after the deep part, the suture is passed. This is the superficial part, and then we can. So this is the severing movement too. How you can see how beautifully we can see the TCL cutting here. Very briefly about the results, meta-analysis have indicated dextrose to be superior than steroid, and ultrasound guided injections far superior to the landmark based techniques of blind injections. Good functional improvement rates, and even up to for carpal tunnel release or even third carpal tunnel release, latest publications, they show that even 2 to 6 years of a good outcome with 91% patient satisfaction is there. Complications very rare, intraneural injection, transient paresthesia, that are also minimized if we are doing under the ultrasound guidance. Just last part, which many patients I'm seeing in the OPD, they have been operated. So just wanted to show this case. You can see the surgical scar here. So this patient was operated already for median nerve compression with carpal tunnel release and neurotomy. After 9 to 10 months, again, he had median nerve symptoms, so carpal tunnel syndrome symptoms. So in the same way, instead of going for repeat surgery, if we can see some fibrotic scar or adhesion which is again trapping the median nerve, so similarly the same type of injection or hydrodissection can be done in these cases also with good results. So just wanted to convey that message that in post-op cases can also be done if there is recurrence. So these are my references, and this is our team at Gangaram Hospital, the IR team. And any questions? Thank you for your patient hearing.
Time is up.
Okay, thank you, Dr. Raghav, for your insightful lecture. Do we have any questions from the floor for Dr. Raghav? Anyone? If not, then we'd like to thank him again and please give him a big round of applause. Okay, we will move on to our next speaker. We now invite Dr. Ankur Goyal to give his talk on ankle joint and Achilles tendon interventions. Dr. Ankur is from the AIMS University in New Delhi, and his topic on ankle interventions is highly looked after. So please, without any further ado, Dr. Ankur.
Thank you, sir. So in the next 10 minutes, let's go through the commonly done ankle interventions. So what we are going to do is to focus on interventions regarding the Achilles tendon, plantar fasciitis, and ankle joint injections. And if we are left with some time, we'll see few more cases. So just to begin the talk, just few terminologies which will be used in the next 10 minutes. As has already been talked about, that steroids can be given, of course, intra-articular into a space, but never into a structure. They are never to be given within a tendon. So if steroids are to be used, they are to be used peritendinous. And we know that there's ample evidence that steroids give rise to immediate and short-term relief, but the long-term reliefs usually do not occur and the repeat injection is required. Tenotomy refers to multiple excursions in the disease structure, also known as dry needling, and it is supposed to have a longer term relief because it will lead to healing of that fibrosed structure. Fenestration refers to that repeated excursions puncturing the holes in the wall of a ganglion cyst to reduce the chances of recurrence. Various orthobiologics are available like platelet-rich plasma, and recently we have shifted to growth factor concentrate, which is the acellular component released by the platelets, so is not associated with any side effects which were there with PRP. HVIGI or high volume image guided injection, brisement, hydrodissection, paratenon stripping, all are same things. This just means separating the Achilles tendon from the underlying Kager's fat pad, and the vessels which are giving rise to pain, the nerve endings which are giving rise to pain in that area, those are disrupted, and this is essentially for short-term relief. So straight away, starting with the manifestations and the management. So we know that Achilles tendinopathy is associated with a bulky tendon with loss of fascicular pattern. The insertional tendinopathy is associated with bony irregularity, bony projections, and there may be increased vascularity as well. Of course, there can be a Haglund deformity, like in this particular case, there can be retrocalcaneal bursitis, and all these are parts of the same disease spectrum. This is an example where we can see that there is minimal fluid in the retrocalcaneal bursa, and in addition, there is a lot of increased vascularity going from the Kager's fat pad to the Achilles tendon. So this is a very good candidate where we can do intervention at the insertion, target the hypoechoic area, intervene in the bursa, target this bursal area, and intervene in the proximal part to disrupt the nerves and vessels in this particular place. So what are the IR options? Tenotomy of the insertional hypoechoic areas, as is seen in this first image. Second, steroid injection into the retrocalcaneal bursa. And as I said, paratenon hydrodissection can also be added, especially for the non-insertional pain. So when we are doing any MSK interventions, it is important to visualize the small structures which are present here and there, right? All of them can be very easily avoided, but we need to look for them and we need to intentionally avoid them. So for example, when we are doing Achilles tendon interventions, on the medial side, we have the posterior tibial neurovascular bundle, the medial calcaneal nerve. On the lateral side, we have the sural nerve and the SSV. But using adequate gel pad, visualizing these structures, we can avoid, and depending on the operator comfort, both the approaches are fine, medial to lateral as well as lateral to medial. Let's see a few examples. So this is an example where we went into the retrocalcaneal bursa from the medial aspect. See that we have used a lot of gel pad so that we are entering very close to the affected site. The injectate is spreading away from the needle tip, which tells us that we are in the right spot. The bursa is distending, and this is the result after the steroid injection in the bursa. The same thing can be achieved by a lateral to medial approach as well. We can see we go deep to the Achilles tendon at the superior most part of the calcaneum, and then we do the injection, and we can see that there is good dispersion of the injected into the bursal space. If we go a little proximal to the calcaneum, so that is the area where paratenon hydrodissection is to be done. So again, we go deep to the tendon. We do the injection. So usually we use 5% dextrose mixed with a little bit of lignocaine in this case. And then we do the stripping of the tendon from the underlying Kager's fat pad. So this is the result. This is the fluid collection which we see after a steroid injection in the retrocalcaneal bursa, whereas this is the fluid clefts which we see due to separation of the Kager's fat pad and the Achilles tendon. Then the third procedure in Achilles tendinopathy, which is the tenotomy, essentially done for the insertional tendinopathy. So we can see, first we can go superficial to the tendon, to the affected part, inject local anesthesia, then go within these hypoechoic areas. They may also show dystrophic calcification, do multiple excursions. In addition to this dry needling, one can go ahead, inject GFC or PRP as well, and then we come out. So tenotomy can be done in both axial as well as in the longitudinal planes, depending on what is the area which we want to target. Is it better targeted from a single puncture in one plane or in the other plane? So here we can see this is the superficial local anesthesia being injected. This is the multiple excursions happening into the hypoechoic area, and it's important to go up to this bony irregularity to achieve better results. Moving on to the next spectrum of diseases, which is plantar fasciitis. We all know bulky hypoechoic plantar fascia commonly occurs at the insertion point. So this will qualify for plantar fasciitis. Again, what are the options available to us? The options available are that we go into the thick, because these are all chronic inflammation, chronic fibrotic cases. This is not acute inflammation. So we need to go inside, do tenotomy with or without orthobiologics, and very little amount of steroid, 0.5 ml, may be injected superficial or deep to the inflamed part. More volume of steroid is not to be injected because steroids can cause fat atrophy. So heel pad fat atrophy can occur. We usually inject only up to 0.5 ml of steroid, if at all, if the patient is in very severe pain. Prior to the procedure, one can target the intermuscular area on the posterior medial aspect of the ankle to give rise to a relatively painless procedure by giving Baxter's nerve block. So this is the procedure as we can see. So we give a little bit of local anesthesia, superficial to the inflamed part. Then we go into the inflamed part, we do multiple excursions. And of course, as I said, this can be combined with a GFC injection as well. Important to note that any injection in these structures is very slow. It's very difficult to inject because it's a closed space. So we create a space by doing the tenotomy and then inject. So this is the GFC injection being done in this particular case. Moving on to the third spectrum which we need to target in this 10-minute topic, which is the ankle joint injection. So commonly performed ankle joint injection is the tibio-talar joint injection. So it can be very easily accessed anteriorly. What we need to avoid is the dorsalis pedis artery. So anatomically, the traditional teaching was don't go between the EHL and the EDL. Palpate those tendons, but on ultrasound we can actually visualize the artery and we can intentionally avoid that, right? Another important concept is that we don't have to target this particular
Last
space.
2 minutes.
The joint capsule actually extends beyond this space over the dome of the talus as well. So what we actually need to target is the dome of the talus. So this is an example where axial plane approach was adopted. We can see we have avoided the dorsalis pedis, avoided the tendons, gone into the joint space and did the injection, and this is the longitudinal approach where the injection was done. If we approach from the anterolateral aspect, then sinus tarsi injection can also be done, and this is an example. So this is the space between the neck of the talus and the anterior part of the calcaneum, this space which shows increased vascularity in cases of inflammation in the sinus tarsi. And this is the out of plane approach where you can see that the injectate is being, getting distributed in the area of the sinus tarsi. Just a quick glimpse about few other interventions. So this is the dorsum foot ganglion talonavicular joint, aspirated, steroid was injected, and fenestration of the wall was done. So all these things can be done. This is an example of posterior tibial tendon dysfunction where there was a lot of effusion around the tendon in addition to the insertional tendinopathy and a split tear. So initially we injected steroid around the tendon to reduce the inflammation. Then we did the tenotomy for the insertional tendinopathy along with GFC injection. And this is how we targeted both the insertional as well as the non-insertional areas. So to conclude, we need to know the anatomy. For that, we need to read the anatomy again and again. Look for the structures which need to be protected, intentionally protect them, target the abnormal areas. That is the beauty of ultrasound. And all injecteds work. People may be using dextrose, people may be using steroids, everything will work. But the main thing now is that steroids are only short-term relief, so agents like dextrose 5% are gaining more attention, and a strict no to intratendinous steroids. And there's a lot of evidence to all these interventions. So all these interventions work. They are actually very gratifying to do and very gratifying for the patient because they lead to immediate pain relief. Thank you.
Thank you, Dr. Ankur, for that wonderful lecture. So do we have any questions from the floor for Dr. Ankur?
So usually we use the majority of the procedures using 23 gauge needle. It's only when ganglion cyst aspiration is to be done, then you require wider gauge needles. We start with a minimum 18 gauge if ganglion cyst aspiration is to be done. But for majority of the other procedures, 23 gauge needle works well.
So for the tenotomy where you showed for the plantar fasciitis, can we use 5% dextrose for the tenotomy or only GFCs to be used?
No, so the thing is, when you are doing tenotomy, you don't need any agent. Tenotomy refers to dry needling, multiple excursions in that structure. Now that will give rise to bleeding in that area, and some good growth factors and healing factors will come, and that will give rise to healing. So how to augment that? So one can inject PRP because they will give a concentrated mix of platelets, and or you can do a GFC because again concentrated growth factors are being delivered there. There are literature also says you can inject irritants like hyperosmolar dextrose and everything because they will also cause inflammation and give rise to inflammatory agents being secreted, which will take care of the fibrotic tissue there. So using 23 gauge needle, we have never encountered any risk of tendon rupture. Whenever there is a weight bearing structure like in Achilles tendon, that is very important, and even for plantar fasciitis, what is recommended is an air cast. So you can use, ask the patient to use an air cast for about 4 weeks and tell them to wear sports shoes so that the stress on that part is less. And we tell our patients to avoid any strenuous activity for 4 to 6 weeks. So that much of rehab period is to be given.
Hello. Thank you for a very wonderful and nice lecture. And my question is in two places. One in pediatric rehabilitation for cerebral palsy kids, those who are walking with with the toe gait, we call the gait is different thing, and another one is in same thing for paraplegics, spastic paraplegics who are working on the gait pattern. Ankle injection would be helpful to release the spasticity around the ankle.
I think to release the spasticity, these interventions won't work, but what will work would be a Botox injection into the muscle belly, which is actually spastic.
That has also failed sometime, or it is recurrent after 6 months. Giving Botox.
Because there the abnormality does not lie in the tendon insertion or in the joint. It's the muscle which is in spasm.
Is there any role for that?
I haven't encountered any such patient. So I don't think there will be role for these interventions in those cases.
Thank you.
Thank you.
Okay, thank you, Dr. Ankur. So we will now move to our final speaker of this session. We invite Dr. Pushpa to give her talk on intervention for ACL ganglion cysts. Dr. Pushpa is the head of department and course director of the MSK fellowship in Ganga Medical Center, and we are eagerly awaiting her lecture. So please, Dr. Pushpa.
Mucoid degeneration of anterior cruciate ligament. So this entity is actually newly described by Kumar et al. In 1999. So it's quite a new thing to be realized by most of the people. Like we still get few outside reports telling that this is an ACL tear, but actually it will be a mucoid degeneration. So it is nothing but the infiltration of mucoid-like substances, primarily glycosaminoglycan within the ACL fibers. And there are multiple theories for the occurrence of mucoid degeneration, like synovial, that is the synovial proliferation which happens in ACL. It could be traumatic, degenerative, or it could be due to altered biomechanics in the joint. All these theories have been put forward for mucoid degeneration, but we really don't know what exactly causes it. Mainly the patients who are affected are more than 40 years of age, and incidence is around 1.8%. Again, it could be more, much more than what it is told in one of the literature. So all these patients come to us with restricted flexion. The main problem is they can't flex the knee joint, mainly because it is all filled up. The intercondylar notch is all filled up with the mucoid degeneration. So that's why they can't flex the knee joint. That is their main complaint. The other main complaint is they can't stand for a long time and they can't climb the stairs. So these are the three important symptoms by which the patient come with. And very rarely they say that when they do complete extension, at the terminal most aspect of the extension, they do complain of pain. So these are the main pain symptoms of the patient. And diagnosis is basically by MRI. Here you can see there are three types of ACL mucoid degeneration. One is diffusely thickened ACL with hyperintensity, where the fibers are quite continuous, and it can also be associated with mucoid degeneration of the anterior horn of lateral meniscus. So again, this should not be called as tear because there is decussation of anterior fibers with the anterior root of the lateral meniscus. This is actually continuation of the mucoid degeneration. Next, there can be diffusely thickened anterior cruciate ligament as seen here with lot of mucinous material, the cystic areas within the ligament. So intraligamentous cystic structures, lesions can be seen within the ligament. So this is the second type of ACL mucoid degeneration. As you can see, it entirely occupies the intercondylar notch and it is pushing the PCL on the side. So there is lot of impingement on PCL. That is why the patient is not able to do complete flexion. Now there is one more type of mucoid degeneration. You can see the ACL is significantly thickened and there is a cystic areas, that is a ganglion cyst at the sides of the ligament. So that is called periligamentous ganglion cyst at the femoral attachment. This patient can also be associated with the tractional cyst at the attachment, either it is in the tibial attachment or the femoral attachment. So all these three types of mucoid degeneration are known. Arthroscopically, as you can see, it is again completely filling the intercondylar notch. It is seen quite thickened, as in here you can see. And one important thing they usually describe is there is no synovial lining or ligamentum mucosum is not seen in arthroscopy. That's when they think of mucoid degeneration. Here again in the lower down you can see there is a large periligamentous ganglion cyst. So you can see a nice bulge along with the thickened ACL. So this is how it looks like. So there are many treatment options available for mucoid ACL degeneration. The first thing is they can either completely remove the ACL, so problem is solved. But there is a slight chance of instability. So that's why they don't prefer to completely remove the ACL. Rather they do partial debridement where they remove the part of ACL, and so even sometimes they actually shave the part of the intercondylar notch to make the intercondylar notch little bit roomy so that the ACL can glide easily. So these are the three surgical treatment options available. Again, with surgery, there is a lot of non-weight bearing, there is a lot of rest required, and there is a lot of preparation and expenses involved with the surgery. So what is the best option? We can just do a ultrasound guided intervention for this mucoid degeneration. In literature, there is only one largest study which is published, but there are multiple case reports, case series regarding this this intervention, and we have done over 100 cases now, and we have seen good results in at least 85% of the patients. Now coming to the what exactly we should not do. We should not do patient who is having other areas of involvement except for mucoid degeneration. So if the patient is having isolated mucoid degeneration and the patient is having exact symptoms related to mucoid degeneration, that is the time you do ultrasound guided decompression. Okay, so most of these patients will be associated with anterior compartment knee arthrosis. You should not do it unless the patient is having specific complaints for the mucoid degeneration. And second thing is, this is always associated, almost many times associated with posterior root tear of medial meniscus. So you can see there is posterior root tear, there is degenerative changes, the cartilage is lost, and there is extrusion of the body of the medial meniscus. So in all these scenarios, it is better to avoid doing decompression of the mucoid ACL, which will be of no use. Coming to the steps of intervention, so you can see this is the patient here. You can see she is hardly able to flex the knee completely. So this is how they present with. They will not be able to flex the knee properly. So what we do is make the patient lie down in the prone position, and then you can see the intercondylar notch, medial and lateral. This is how the normal structures look like. But if there is a mucoid degeneration, you can see a large hypointense area there, hypoechoic area there, which is pushing the PCL on the sides. So the entire intercondylar area is filled up with the mucoid ACL. And here you can see that what are the things required. The things required are very minimal. One is to do a sterile precautions, and another one is you need a local anesthetic with 23G needle, and another one is a pink LP needle, that is 18 gauge LP needle. So these are the only things required for this wonderful procedure. Now this is how we place the patient, and it is better to do it in the seated position because it takes a while to finish this procedure. So what we do is we identify the intercondylar notch, we identify the femoral condyles on either side, identify the neurovascular bundle, that is popliteal artery and tibial nerve, and you have to infiltrate the skin and the needle tract, and this is the capsule here. You have to, let me take the pointer. Okay, that's the capsule. So infiltrate the capsule, the tract and the skin, and then you get into the mucoid ACL. So first you have to give local anesthetic using lignocaine from skin to the capsule and then into the ACL. So let me play the, okay, if the laser point is on, I think we'll not be able to. So that is how you
Last
go
2 minutes.
and you infiltrate the ACL. Once you infiltrate the ACL and the capsule and the tract, the next thing you have to do is insert a 18G needle, that is the LP needle, and then dry needle the ACL. So you dry needle the ACL continuously, maybe up to 20 times or more than 20 times until you stop feeling that gritty sensation. So whenever you are moving the needle inside the ACL, you get a gritty sensation initially, and the later it becomes smooth. So that is when you stop doing the procedure. So while doing this procedure, if the patient has pain, you can either give a little bit of local anesthetic or reassure the patient telling that it will take only a while, and then you can continue the patient. So, but it is better to give little bit of local anesthetic and then to continue to do it. While doing also, I slightly angulate the needle as well as the probe cranially and caudally so that we cover the entire length of the anterior cruciate ligament. Main thing is we have to avoid the popliteal artery and the tibial nerve. So that is the most important thing. And when you're doing the penetration, you should remember that you should always stop feeling the gritty sensation and needle should move very smoothly. Then you know that you have finished your procedure. Once you finish the procedure, you give triamcinolone just underneath the capsule, not into the tendon, just underneath the capsule you give 1 cc of 40 mg triamcinolone into the joint. So this is before procedure. You can see the mucoid degeneration, and it is filling the entire intercondylar region. And here you can see it is completely decompressed. So this was the another case. Again, we have done the same thing, continuous dry needling of the ACL. Remember, however big the cyst is, you will not be able to aspirate the ganglion
Time is up.
cyst. So this is how the patient in the pre-procedure, you can see she is struggling to fold, and you can also see that the fingers were pointing upwards because of the pain. This is in the prone position, not able to fold it, and you can see how she is struggling because the fingers are moving up and down while she is doing the flexion. And this is post procedure. You can see this is the result. So there are immediate results after the patient undergoes this procedure. Give adequate analgesics because it will be very painful immediately after the procedure. Always tell the patient, look for infection, swelling, discoloration, because if at all you injure any vessel, it can result in discoloration. So educate the patient about all these findings, and then knee strengthening exercises after 4 weeks. To conclude, it is very promising and very satisfying and very easy procedure to do. So please do it in your OPs, and also there is no need of weight restriction. So again, it is better than surgery in most of the patient, and it can also be repeated. Thank you very much. By this, again, I would like all of you to attend Asian Musculoskeletal Society as well as the MSS meeting happening this year in Ahmedabad. Thank you very much.
Thank you, Dr. Pushpa, for covering the topic very nicely and showing the clinical examination in addition to the procedure. Thank you. Are there any questions from the floor? Anyone? So, thank you.
Thank you.
With that, we conclude the session and we hand over the mic to the organizers. Thank you, everyone.
Sir, can you please come onto the stage for a photo? Yeah. So I request the speakers of the previous session to come onto the stage as well. Thank you, speakers, for the interesting talks. So next we'll head on to vertebral interventions. I request the chairpersons of this session onto the stage, Professor Nishit Kumar, sir, and Professor Devara Anil, sir. Thank you.
Okay, so we'll start the session, and the first speaker for the session is Dr. Devara Anil, and he's professor and lead consultant at the Medicover Hospitals, Vizag, Andhra Pradesh. Over to you, sir.
A very good afternoon to all. We are going to have a brief talk on vertebroplasty or kyphoplasty. We'll start with the vertebroplasty definition. It's a technique of percutaneous injection of vertebroplasty cement, which is a polymethyl methacrylate under fluoroscopic or CT guidance, which is injected into the fractured or a weakened vertebra to stabilize the bone, to relieve pain, and to restore mobility. So vertebral augmentation was first started in 1984 as an injection of the material, and kyphoplasty is the similar vertebral augmentation technique which was started in 1998. At this point, I would like to mention about my mentor, Dr. Rai Santosham, from whom I learned in 2008, and then I performed my first vertebroplasty independently in 2011 in the state of Andhra Pradesh. Coming to the indications of vertebroplasty, pain associated with compression vertebral fractures due to osteoporosis, neoplastic induced fractures, subacute traumatic collapse, vertebral hemangiomas, symptomatic microfractures, and lytic lesions without loss of vertebral height. Absolute contraindications, we need to be aware of them: asymptomatic compression fractures, active osteomyelitis of the target vertebra, uncorrectable coagulopathy, and allergy to the bone cement or a pacification agent. Relative contraindications can be radiculopathy, which is unrelated. There is a retropulsion of the fragment causing severe spinal canal compromise, tumor extension into the canal, systemic infection, improvement on medical therapy, no prophylaxis in osteoporosis, and myelopathy at the fracture level. Before we get onto the vertebroplasty, we need to understand the traditional management which usually goes on, where the side effects can be significant. But what we do is analgesics, bed rest, immobilization, and surgery. These are the things which used to happen, but there are complications associated with bed rest, which we know as deep venous thrombosis and pneumonia. So the objectives of vertebroplasty is to provide relief from painful vertebra, to provide stability, to prevent further vertebral collapse that would lead to further loss of height, result in kyphosis, and associated with fractures at adjacent levels. So why vertebroplasty? Vertebroplasty alleviates the pain due to stabilizing the fractures, which can be micro and macro fractures. It allows healing to occur and destruction of the sensitive nerve endings, and prevents further collapse. And the tumor at times can get better due to the thermal effect, toxic effect, or the mass effect. For vertebroplasty, the patient selection criteria is important, where a painful fracture which increases on loading, not responding to 4 weeks of medical treatment, acute or subacute compression fractures on plain radiographs or MRI is preferable, and pain corresponding to the level of the fracture. The key success of vertebroplasty: pain should be focal, intense, deep, local tenderness corresponding with the imaging findings, with no radiation to the legs. But even if there is a radiation, we can still go ahead. Pre-procedure evaluation for vertebroplasty: a proper OPD consultation with regard for the lifestyle, analgesic use, past medical history, past surgical history, medications, allergies, and the labs. And on imaging front, we need to do the plain radiographs, MRI, CT, and the scintigraphy. So the marrow edema on MRI will help us to localize the vertebra. The posterior vertebral body intactness can be certified on the CT, and other routine investigations which we do as a pre-procedure paraphernalia, that is a complete blood count, PT-NR, serum creatinine, viral markers, chest X-ray, and X-ray of the involved spine. Pre-operative bone scan can also be done. Most important aspect of pre-procedure evaluation of vertebroplasty is the intactness of the posterior vertebral margin. And then the word about the medical legal consent. This is the most important part of the procedure, where you have to obtain an informed consent with the patient and or the family, where you have to explain in detail regarding the risks, the benefits, and the possible complications. The complications have to be explained appropriately as minor and major complications, which can be transient, self-limiting, spinal cord injury, nerve root injury, cement leakage, increased pain, and death. These have to be very clearly explained in the language which the patient knows. And in the next pre-procedure setup, we need to have immediate access to CT and MRI, ICU or operating room in case of complications. This is the general instruments and the table setting. We use a 13G or a 14G, 11 centimeter or a 15 centimeter vertebral biopsy needles. The imaging equipment can be a biplane cath lab, can be single plane, C-arm, or a CT with fluoroscopy. Pre-procedure care, NPO from midnight. Antibiotics can be optional, but we usually give antibiotics. Patient positioning and draping. Pre-procedure care, usually the procedure is done under local anesthesia. At times we may go with IV sedation. By and large, general anesthesia we don't use. But the nursing, IV lines, continuous monitoring of the parameters is essential all throughout the procedure. The basic steps of the procedure: first is to localize the symptomatic vertebral body and prepping the skin. Position is supine for cervical vertebroplasty and prone for dorsal and lumbar vertebroplasties. You have to choose the approach, which can be transpedicular, parapedicular, or extrapedicular. Next comes the anesthetization of the skin, subcutaneous tissue, and deep up to the periosteum of the pedicle with a 22G or a 20G LP needle. The entry point and the pathway have to avoid the nerve root and visceral structures, which usually happens in CT but may not be possible in a cath lab. Then the needle is guided safely under CT or a biplane fluoroscopy. This is how the patient positioning happens, and the strict sterile technique has to be done. The 3 steps of vertebroplasty is placement of needle, insertion of a working cannula, and injection of a cement filler. Then the vertebroplasty approaches: cervical spine, as I mentioned, anterior. Dorsal and lumbar can be transpedicular, parapedicular, or extrapedicular. So this is how we do the cervical vertebroplasty, where the manual displacement of carotid jugular complex will guide the needle insertion into the vertebral body, which can be imaged under cath lab or CT. And this is how the vertebroplasty is done as far as the cervical vertebra are concerned. Then coming to dorsal and lumbar vertebra, you can have a transpedicular approach, parapedicular or extrapedicular, can be unilateral, unipedicular or bipedicular approach. So this is how the approaches look like. And then the most important thing in the procedure is the pedicle targeting. This is what will determine the accuracy of the procedure and the efficacy of the procedure. So the skin incision is 1 centimeter lateral to the entry point at L1 to L4 level and 2 centimeter lateral to the L5. So that is the projected territory along which a trajectory of needle insertion transpedicular approach. In cath lab probably it will be a little difficult in order to align the needle, but in CT is very easy. It's very precise as well. CT helps a lot. And then while doing the procedure, the stopping points are very important to ensure that your needle is traversing the appropriate track. First you stop at the tip of the pedicle where you are entering the bone, then at the center of the pedicle where you are making sure that you are not entering the canal. And then once you are at the junction of the anterior and the mid-third of the vertebral body, you can stop and start injecting. A word about the difficult cannulations where the pedicle thickness may be less, at least 3 to 4 mm is needed, but usual problem is with the dorsal spine. In the upper dorsal spine where the pedicles are small, there you can have a parapedicular approach. So this is how we do needle insertion, locate the bony landmarks, placement of the needle at the junction of the anterior and the mid-third of the vertebral body. You can do a venogram to understand as to how the contrast will behave, and it also gives you an idea about the extravasation where you can stop the injection. Next is the cement mixing. It has to be a cool environment where you are mixing the powder, the cement with the liquid. And the most important thing which my mentor taught me is the consistency should be like a toothpaste consistency, which happens after mixing and stirring for around 1.5 minutes. This is how we do the injection with the 1 ml syringe. Termination of injection is when the cement is reaching the posterior 1/3 of the vertebral body. Cement is extruding into the epidural or foraminal paraspinal veins, and there is significant disc space penetration. So volume of the cement 3 to 10 cc, but large volume doesn't ensure any perfection in the case. So volume depends, but your termination point is the most important thing here. This is an example of unilateral transpedicular vertebroplasty. This is a CT guided bilateral transpedicular vertebroplasty. Completed vertebroplasty when you have the cement has reached the posterior 1/3 of the vertebral body. Cement hardening can be assessed when you have a piece of cement in your hand, and that will help you to ensure that the similar amount of cement has hardened in the body of the vertebra to ensure that there is no instability or cement percolation. Post-vertebroplasty CT check is important. Complications and efficacy will be dealt in the next talk, but I will just breeze through the complications. Most important is the cord compression and the pulmonary embolism, extravasation. This is pulmonary embolism, which is a dangerous complication, which will be dealt later. Then the post-procedure care, dressing at the needle site, strict bed rest, monitor vital signs, monitor neurological examination. Patient is instructed to call for new back pain, chest pain, lower extremity weakness, fever more than 100 degrees, follow up after 24 hours, 1 week and 1 month. Efficacy again will be dealt in the next talk, but 75 to 90% relief in pain within 72 hours, neoplastic compression fracture 59 to 86% marked reduction, lower complication rate and very high success rate. A word about kyphoplasty. The steps are placement of a needle, working cannula, create a void, deflate the balloon and inject the cement. This is how the kyphoplasty is performed. The advantages of kyphoplasty is that the leakage, the extravasation risk is less, but it is costlier, increased procedure time. And my take-home message will be, it's a minimally invasive procedure, mostly done under local anesthesia, can be performed on OPD basis for quick relief of pain. With appropriate patient selection, vertebroplasty is a safe and efficacious procedure for the treatment of pain and disability associated with osteoporotic compression fracture, lower complication rate, high success rate, and these two are very important. Vertebroplasty is a palliative procedure and does not correct the underlying cause of vertebral fracture. And medical management of osteoporosis or malignancy must therefore be initiated and continued. These two are very important for us to understand and to counsel the patient as well, because they will think that you have done vertebroplasty and everything is going to be fine. So these things have to be very clearly explained during your consent taking and all throughout the procedure. Thank you.
Thank you, Professor Anil, for elaborately discussing on all the indications and the procedure of the vertebroplasty and the complications as well. So any question from the audience? It's okay. So we will, oh, sure.
Yeah. Correct. Correct. Yeah. While doing with pure CT without fluoroscopy, the extravasation you cannot assess. But we give gaps, we come out, we check, because the volume injected is never more than 2 or 3 cc. So that way we try to counteract the extravasation.
Okay, so basically you give 1 or 2 ml, then
come out, check, and then go in.
Extravasation, basically you need to see it is going outside.
Yeah, into the spinal canal. Basically the most important is the spinal canal.
Okay.
That risk always exists with CT, but then we try to curb it by repeatedly, we inject, come out and do.
Fine, that's great.
That's the only thing.
And what about the venogram part? You were telling, what is that?
You can do a venogram.
Okay, if you are in the cath lab.
In the cath lab, you do the venogram.
Okay, fine.
Yeah.
Thank you.
Yeah, that's the reason. I was trying to make a point stating that you need to maintain a cool temperature in order to give a increased working time. The fluidity of the cement has to be maintained at least 50. It will give you 15 minutes when you are doing in a proper cold environment.
And every time we have to put 2 ml, check, and then again 2 ml.
Not 2 ml. See, that total amount of vertebroplasty cement which we inject is around 2.5 to 3 cc max. You have bipedicular axis, 1.5 is the target. By and large, it doesn't happen. With 3 cc, extravasation is very rare unless you are in the vein.
Okay, so we now move to the next speaker, and it's my pleasure to welcome Professor Dr. Dharmendra Kumar Singh, who will be talking about the vertebroplasty results and the complication. And Professor Dharmendra Kumar Singh, he's a very dear friend, colleague, mentor, and a senior to me. We work together, and he needs no introduction, and he's a very passionate teacher. So over the next 10 minutes, we are going to hear about the results and complications of the vertebroplasty from him.
Thank you, Professor Nishit and Professor Devara for your excellent talk. And coming to the results and complication of vertebroplasty, I have no conflicts of interest and nothing to disclose. As told beautifully by Professor Devara, it's a minimally invasive procedure, bone cement injected into the vertebral body, and it's palliative treatment used for painful compression fracture. The most commonly the osteoporotic we do for the metastasis or myeloma. The main aim is the pain relief and stabilization, not the osteoporotic cure. This vertebroplasty is not cures the osteoporosis. It only gives the palliation for the pain related to the osteoporosis or neoplastic collapse. Like here in this case, this is index case, fine. Here is the collapse in the MRI, it's chronic one, fine. In the CT scans, and we did the vertebroplasty at the 2 levels. The results, yes, the results can be summarized in immediate, short-term, long-term. What is the radiological results and what's the success rate? The immediate results, yes, the patient gives it's a very gratifying procedure when the patient gives the immediate results within 24 to 48 hours. The VAS score comes from 7 out of 10 to 1 out of 10. And even the literature shows that within 48 hours, it dramatically reduced from the mean 8.9 to 1.2 in 48 to 72 hours. And what is called the clinical relief, when there is a reduction of the 2 points in 10-point scale, it's called clinical relief. But sometimes the variable response occurs, as we have seen in our practice, that might be due to the coexisting facet joint arthropathy or adjacent fractures. So in that cases, even after the vertebroplasty, the patient still complains of the pain after 72 hours. The short-term results, yes, 1 to 6 weeks, improved mobility, return to daily life, the patient is very fine, reduced pain medication, and independent life. The long-term, in the 1 to 2 years, that why I want to emphasize that the patient feels very good in the 5 to 6 months follow-up or 9 months follow-up. And patient feels that my disease had been cured. But the problem with the vertebroplasty, in our personal experience, it has the variable results after 1 to 2 years. The advantage of vertebroplasty over conservative management diminishes after 1 to 2 years. Let's look at the picture from the et al. Like here, the advantage of vertebroplasty over conservative treatment, it becomes very narrow after 1 to 2 years. And this happens because as an intervention radiologist, MSK radiologist, we do the vertebroplasty, we tell the patient you will find in 22 hours. But it is not a standalone treatment. Adjacent, simultaneous treatment of the osteoporosis should be done, and patients should be told that this is only a pain relief for long-term pain relief. Okay, so in osteoporotic collapse, what we have started doing the practice that in every after vertebroplasty, we do the orthopedician gives the bisphosphonate or hyaluronic acid simultaneously, and we do the DEXA scan in every follow-up, like 1 month, 3 months, 6 months, and 1 year, to check that the osteoporosis is being cured or not, osteoporosis is being controlled or not. So the long-term results depends upon the patient selection, proper patient selection, and management of the underlying disease. This is the radiological disease. This is one of the patients which we have done the follow-up for 1 year. The day 1, the patient was perfectly fine. 6 months, okay, the patient was very good. But after one almost, I have written 1 year, but it's almost 1.2 years, and the condition was same. The patient started feeling the same because the patient osteoporotic management was not done good. So what's the success rate? High success rate, 75 to 90% for reducing pain. Improved mobility and physical function, stabilizes vertebral body and preventing further collapse, definitely. But I will come on later on in the detail. But it cannot correct the severe kyphosis that is done by kyphoplasty. So what's the factor influencing success? Earlier intervention for acute fractures, like here the 2 fractures. Okay, acute fracture, chronic fracture. The better results are in the acute fracture. Chronic fractures, the results are less dramatic. Complications, most complications are minor and temporary. The severe complications are rare, like the pulmonary embolism or spinal cord compression, and that requires urgent attention. But the beauty of the vertebroplasty procedure is that all the serious complications can be prevented by a proper patient selection and by the proper technique. Most complications are preventable by preventive technique. Coming to one of the most common complications is cement leakage. There is one classification, that is Yom classification, very useful one. There are the three types of cement leakage. B for basic vertebral vein, type B basic vertebral vein, which drains the anterior 1/3 of vertebral body. It drains into the internal venous plexus, and here outside it drains into the external venous plexus. Second is the S, segmental veins. If the through sometimes there is the venous leakage through the segmental veins, that is called S type. And C type, when there is a cortical break, it is called C type of leakage, cement leakage. So, and the leakage site are epidural space, that's most concerning. Paravertebral tissue, yes, it's not less concerning. Intervertebral disc, it's a little bit of concerning. Why? I will tell you. A venous leakage, yes, if it go into the azygous vein, then it is concerning. Cement leakage, does cement leakage occurs in every VP, in every vertebroplasty? No. The bones where the osteoporotic or the fractures which have the complex fracture, there are the more chances of the cement leakage as compared to the persons who have a normal density of bone or a simple fracture. The cement leakage, low viscosity cement, increased leakage risk because you know, if not controlled properly, it the high volume injected with the high pressure, and that causes the leakage. The volume becoming over enthusiastic and injecting an excessive amount, more than 3 cc, with increased pressure within the vertebral body, and there are the chances of leakage and excessive injection pressure. So the slower injection is always better by the 2 ml syringe, but more controlled distribution. We do it under C-arm for the continuous real-time monitoring. The epidural and foraminal cement leakage compromise neurological status due to spinal cord or nerve root compression. That is most concerning, but that depends upon the volume of the leakage. A small leakage in the epidural space, it does not cause the it does not cause the cord compression or nerve compression. The large amount of cement leakage in the epidural space or neural foramen will cause the spinal cord compression. Most cases, even if there is a small epidural leakage, are clinically asymptomatic with negligible symptoms. Like here, we did this one, and there's a small leakage in the basic vertebral vein. What to do? Okay, there are two things: either terminate the procedure or pause the procedure. Pause the procedure. You put a 1 drop of cement on your gloves, okay, and wait that it become hardened or not. When it is become hardened, this vein will the cement in the vein will also harden, and the patient had no symptom, despite the patient have so much of cement leakage in the epidural space. But we should be cautious. Through the cortical defect, yes, in the complex fracture with this one, and through the cortical defect, the cement leaked into the epidural space. So, what is the prevention? Yes, low pressure injection, thicker cement, stopping the cement at the posterior third of vertebra. These are the 3 main features. How to know what is the thicker cement? When the cement has the consistency of a toothpaste, then it's perfect for the cement injection. And always start giving the injection at the anterior 1/3, okay, and when you see the cement is coming to the posterior 1/3, then little bit cautious. Stopping injection at the first sign of leakage. I have not even completed the 50%.
Last 2 minutes.
Using CT scan for precise confirmation and surgical decompression for the spinal cord for symptomatic leakage. Paravertebral soft to cement leakage, it is clinically insignificant and commonly occurs if there is a pre-existing complex fracture, like in this patient. So the same rule is stopping injection or pausing the injection at the first site of leakage is critical to prevent severe outcome. Intervertebral disc cement leakage, there are lots of literature which shows that it does not cause symptoms, okay, but or some many literatures which cause the increased risk of subsequent fractures in the neighboring vertebral body. So the recent classification has come that is called 3 types of cement leakage in the cement in the disc. One at the junction of the disc and vertebral body, one like this one into the disc, and one is the intradiscal extradural combined. The type 2 is related with the delayed pain relief. So sometimes even the patient at the 72 hours complains of, I have little pain of 5, to check that the cement have leaked into the leakage of cement to the intervertebral disc can be the one cause of pain. Like in the same case where we have done all the complications, basic vertebral vein, and also the cement leakage into the intervertebral disc. So position the needle. So what to do? Position the needle not in the center, slightly paramedian to avoid the vesivertebral vein, and position the needle laterally away from the vertebral central axis. And that's very important, very practical clue to avoid the vesivertebral vein cement leakage or intravenous leakage. The most common the most dangerous one, looking like dangerous, venous leakage of cement, where the factors here the vesivertebral vein which drains into the internal venous system. It also drains to the external venous system, and these two are communicated through the segmental vein through the neural foramen. So what are the factors which leads to the cement leakage? You can go through because less of time. One of the important practical thing, once you see that cement is going, I will take 45 seconds.
Time is up.
Yeah, thank you. Okay, fine. So when there's cement leakage in the veins, stop for some time. But when you are finding the cement is leaking into the azygous vein, terminate the procedure, because the cement leakage into the azygous vein or in inferior vena cava, there is a very high chance of pulmonary vein. But cement leakage into the epidural vein or small veins, not azygous, okay, not so worry. So stopping the cement, I am repeating again thing here, stopping the cement, the first site of leakage is the crucial to prevent any complication. The majority of the clinical symptoms of pulmonary central embolism are dyspnea, tachypnea, tachycardia, and lots of things. If respiratory symptoms emerge post vertebroplasty, the check CT scan should be done for the potential pulmonary cement leakage, like in this case here. There is cement leakage into the pulmonary vein. Infection, yes, vertebroplasty can occur in the pre-existing spondylitis. So, that particularly in India, the chronic tuberculosis or heel tuberculosis misdiagnosed as osteoporotic fracture, in my opinion, is one of the commonest thing where we have encountered. We have given the cement. Okay, it was misdiagnosed as osteoporotic fracture, and ultimately it leads to the flare of the partially healed tuberculosis and ultimately lead to the infection. So how to prevent this one? Okay, is it a fault of a diagnostic radiologist? No. The preoperative check, CBC, ESR and CRB, contrast MRI if inflammatory markers are raised. Delay the procedure until the infection improves or inflammatory markers are decreased. Immunocompromised patients, don't do vertebroplasty, in my opinion. Use of perioperative intravenous prophylactic antibiotic, yes, we do. And when the infection occurs due to vertebroplasty, surgical debridement can be done. So these are the measures to reduce, yes, root, transpedicular for lumbar or lower thoracic. In the upper and mid thoracic, we used to prefer the costo-transverse approach to so that to reach in the paramodian position. Opacification of cement, follow the manufacturer's recommendation. That is the simplest thing that we can do. Cement leakage, termination of the procedure.
Time is up.
And OPD follow-up for the 2 to 4 weeks post BP to assess signs for procedural complications, and always do a DEXA scan follow-up in the each visit. So take home message, immediate pain relief, immediate and short-term advantage of conservative management can diminish after 1 to 2 years. If you want to do the long-term, treat the osteoporosis at the same time. Majority of the complications are minor. Major complications are prevented by the patient selection and proper technique. Thank you. Thank you so much.
Fabulous talk, Dr. Dharmendra. Fantastic. Your thanks to the alarm was extremely good. So now can we go to the next talk by my very good friend of mine, Dr. Murthy Chamarthi, who will be speaking on spine jack. It's an absolute honor to call him on the dais.
Good afternoon, everyone. So we had a good session. We talked about the benefits of vertebral augmentation, right? We know that it decreases mortality and morbidity. Patient can mobilize early, thereby reducing all the subsequent complications. What if there is a way that we can get more benefit, more height restoration, more structural as well as functional benefit, but at the same time, less complications, right? We saw how cement can go to the wrong places. What if we can inject more cement, more uniform distribution, not just the quantity, but the quality of distribution is better? And what if we can prevent adjacent vertebral level fractures, additional fractures? So that's the holy grail. And there is progress or there is new developments in this area. Spine jack is one of such devices which we can have some advantages. And of course, there are some other additional implants like Kiva and so on, which are slightly different in the formation of the device and how we perform it. But today we're going to talk about spine jack. And we already looked at the data, like how vertebral augmentation is very beneficial compared to non-surgical treatment options. So I'll skip these trials and the results, but suffice to say that there is significant improved mortality risk when we perform vertebral augmentation as opposed to just conservative non-surgical measures. And spine jack, it's bipedicular approach. We have to go through the pedicle as opposed to standard vertebral augmentation. And we have some studies which have demonstrated superior structural measurements or structural outcomes, as well as superior functional outcomes in terms of improvement in pain scores, improvement in patient mobility, as well as superior vertebral height restoration measurements, and so on, without the additional risk of adjacent fractures. The pain scores are significantly higher compared to standard conventional vertebral augmentation. And this is one of the important studies, the SACOS clinical study, multi-center randomized study, which demonstrated there is very significant difference in the restoration of the vertebral body height, which I call a structural objective measurement, as opposed to an KIFEX expander, which is standard vertebral augmentation. In the same study, there is also significantly fewer adjacent fractures, which is 12.9% versus 27.3%, 12.9% with use of spine jack. And there is greater pain score reduction at 1 and 6 months. So this proves that there is improved pain score reduction, and there are less complications, there are less adjacent level fractures, and there is also a structural benefit, which is also important because when you restore the height of the superior end plate without breaking the superior end plate, right? That's also important. When you put a force, when you put an implant with heavy force, you don't want to break the superior end plate, but you want to extend it as much as you can. And when you do that, your spinal space actually will increase too. So there is an additional benefit to maintain the normal spinal curvature. So which may also benefit with patient mobility and maybe some improvement in pain because of the narrowing of the spinal space. Of course, again, there are certain indications and contraindications where you can offer. It may not be applicable to every patient that presents with a vertebral compression fracture, but we'll go through that in the subsequent slides. And when we talk about indications, typically, maybe we can talk about contraindications, and that way we can probably steer the patients towards spine jack more effectively. I do not offer this when there is involvement of the posterior elements, or I also do not offer when there is more than 75% fracture. It gets very tough. And pedicle size is another important thing, and anterior posterior measurements of the vertebral body are another important thing to accommodate the spine jack. And the rest of the contraindications are similar to standard kyphoplasty, like active infection and so on. But other than that, you can use it as long as you have pedicular access, that you can get into the vertebral body and you can expand the vertebral body. So let's say if there's a 50% fracture but no posterior involvement, you can definitely use it and get wonderful results. So we talked about this greater vertebral body height restoration. And again, the devices like spine jack versus Kiva, there is slight difference in where they get deployed and how they get deployed that leads to slightly different areas of vertebral body height restoration. Again, there is more functional to it. There is no head-on-head comparison, but is it midline, is it peripheral? Those are the differences between the newer spine vertebroplasty augmentation devices. And that we call that ligamentotaxis basically, based on where you restore the height within the vertebral body and how it changes the spinal curvature and how it changes the thecal sac or the spinal spaces. So it has up to 1,000 newtons of craniocaudal lift force, and there is a plastic deformity when it extends the superior end plate. So what that means is it exerts maximum pressure to restore the body height, but it doesn't cause a breakage of the superior end plate. And so there are a couple of different options in spine jack, 4.2, 5, and 5.8. They're color coded, and you always want to have a pedicle size that can accommodate this particular device, right? So you select the type or the size of the implant based on the pedicle size, and then you go and you approach it with the bipedicular approach. And it does exert 1000 newtons, as we mentioned, and there's slight difference in each size of the device and the newtons that it exerts, and it's bipedicular approach. You cannot do extrapedicular and other approaches with these devices. We talked about plasticity, which is very important for the superior end plate. And again, this is the pre-op workup. Of course, everybody gets an MRI so that we have evidence of fracture that's acute to subacute with edema changes. We look at the posterior elements. We measure both the pedicles. In this case, for example, we see a pedicle of 6.1 and 6.2. So it's usually the device that you select is 8 millimeters less than the pedicle size. That's how you select. So in this case, a 5 would be very good optimal choice of the device, not the spine jack device. The anteroposterior measurements, the pressure that it exerts, as well as the plate length, all these differ slightly between device to device.
Last 2 minutes.
Should I say thanks as well? I don't know where the message will go with the thanks, but so select the device based on the pedicle size, and the deployment methodology is the same across all the 3 device size types. Again, we'll see a couple of examples, but you'll get a very good cement distribution, which is rather very uniform. So that's a more qualitative injection. Maybe that's why we're seeing better results with cement injection post spine jack placement. We talked about these things, so I'm going to skip it. The steps are pretty straightforward. 11G access cannula through one pedicle, and of course you save your space with a guide wire. Then you have to create space, right? So you use a reamer to create the space. You have a template to make sure that it's standard, consistent. So you see number 4 step is the template. And once you have that, you again reserve the space with a cannula or plug, go to the opposite side, put the implant on the same side, go to the opposite side, repeat the steps. And once you have both the spine jacks in place, then you try to deploy the spine jack by counterclockwise movements and unscrew it. Fluoroscopic images pretty much showing the same. And it's very important to have, there are certain things to make sure that both the spine jacks, they have to deploy the correct way. So you have to have that parallel things which you see in number 6 image. You need to make sure that the devices are parallel to the vertebral bodies and parallel to each other, so that both the sides, left and right superior end plates, are expanded within the same pattern or within the same fashion. Otherwise, you may get asymmetry there. So not sure if this would play, but let's see. Okay, so you can see how the superior end plate is expanding, and you can see very significant restoration of the vertebral body height.
Time is up.
And then you can see the cement injection very consistent and uniform distribution. This is typical for all the cases, and you can clearly see how it restores the vertebral body height. So again, some steps of going into bipedicular approach, positioning the patient, which we went through in the last few cases. They're all on few talks, and it's the same approaches: reamer, implant, saving your place, spine jack implant, making sure parallel nature is maintained, deployed through unscrewing the spine jack implant itself, and then inject the cement, and that should be it. So in essence, it's safe, effective compared to standard procedures. If there is an indication, just know the methods and know the steps. Pretty easy to deploy, and we'll probably see more developments with other devices. Thank you.
Time is up.
Thank you, Dr. Murthy, for an excellent talk on the spine jack and showing all the procedures and the selection of the patient and the transparticular approach that we need to use for the same. So question answers we can take after the session. So now we move to the next speaker, and that's Dr. Tu Ju Phi. I hope I have pronounced it rightly. And he'll be speaking on ablation cementoplasty. He's from Singapore General Hospitals. Over to you.
Hi, everyone. I'll try and skip over those parts that already been covered. It is a slightly long talk with a slightly awkward title. So these are my disclosures. Now, much ink has been spilled about vertebroplasties, right? And many people do it, IR, auto, anesthesia, and we can do uniparticular, biparticular, CT, cone beam CT. Now, the first thing that we want to separate is actually the evidence. The evidence for the osteoporotic VCF versus the malignant one is different. The thought process is slightly different as well. Now, if there's one controversy, if you have heard earlier, any JM trials fail, isn't it? People tell us it doesn't work. Now, why after when we do a vertebroplasty, the patient next day just wakes up and start walking? And we will skip this one. Now, why does vertebral augmentation work? So at the end of the day, remember whether it's a cement or a spine jack, this is mostly a compressive force that you're protecting against. It consolidates fractures. The heat will burn off the nerve endings to get you the maximal pain relief as well. As we have previously stated, most of this can be done under LA and sedation. However, vertebral augmentation is not for everyone. Patient selection is crucial. Not all acute fractures need to be treated. Personally, I like the pain score to be more than 6, either 7, 8, and 9, that's great. And the typical picture of a patient that you see in the ward is this old lady, small size, they're motionless in the bed because every time they move, they get pain. If you press on their shoulders when they're sitting down, they get pain. Now, MRI is very helpful, and we like an MRI before. Simply because, number one, you can characterize the fracture. For example, in this slide here, you can see the fracture line. There's a subperiosteal fracture at the superior end plate. It is very important that we catch the fill later over there, and I'll demonstrate a bit. The other thing is, on the fat set T2, on the stir images, you can see other fractures that you may need to treat as well. Now, when to offer? Generally, if for osteoporotic fractures, when the clinician approached me, I actually offer already. When you think about it, the patient has been in pain for a few days. They come to the hospital, they stay in the ward for a few days. By the time the clinician contacts you, it's a couple more days. By the time you have a slot, it's a few more days. So really, it may be a week or two before the onset of pain comes around. So generally, when I'm approached, I will offer a day. Now, the next is vertebral compression fracture in malignancy. This is where we have level 1 evidence. It is very clear from the CAFE trial that balloon kyphoplasty works versus conservative treatment when it comes to compression fractures. This is a good trial, randomized control, functional scores at 1 month, crossover allowed. As you can see, the improvement in the kyphoplasty arm is so much better than the conservative arm itself. So being said, malignant vertebral body pain in SGH in my center, vertebroplasty is front and center depending on how well or unwell the patient is, or whether there are subsequent surgeries, or how the life expectancy. And again, not all vertebroplasty trials is the same. So in this table, we have given a snapshot of the most important randomized control trials in vertebroplasty. The lower two are the ones that appear in NEJR in 1995, saying that vertebroplasty has no difference when it comes to conservative treatment. The only positive trial is the vapor trial here, and that's at the top. Now, looking at it, it is quite easily due to the patient selection. Only the vapor trial selects patients who are acutely in pain. The rest of the trial actually have fractures that dated weeks to months after. And we do know that vertebroplasty works best in this acute period. So at the end of the day, if you want your vertebroplasty to have the most result, you start during the acute period. I think we have shown this before. So again, when to offer vertebroplasty, whether it's a malignant or osteoporotic compression fracture, when it's inpatient and the patient is unable to walk, please get an MRI if you can to see the variation of the fracture. And for malignancy, I think because of CAFE trial, we can treat the pain anytime. So again, vertebroplasty or kyphoplasty, really there's not much differences when you look at the efficacy. Kyphoplasty probably has better leak profiles. So this one is a single level vertebroplasty. You can do it under cone beam CT as well. So after cone beam CT, you can plan your trajectory as per the second video here. And after that, on a transpedicular approach, we guide our needle in. So this is another way that you can do vertebroplasty as well. So single level BP, in SGH, we like to drill it in. We find that when you are just drilling the needle in, it is less painful rather than the knots of the individual mallet. I think this, the other thing is, for us, we inject our cements under direct fluoroscopic vision. We don't do it under CT scan. We just want to see the leak at the end of the day. Always remember that survival after vertebroplasty is the same. So this is where, as we previously said, if there's osteoporosis, we treat the osteoporosis. If there's cancer, we should treat the cancer as well. A lot of people are quite worried about adjacent level fracture after vertebroplasty. I think the evidence is not very clear. And to me, this is no reason not to offer vertebroplasty. So don't be too worried about the adjacent level fracture. Cost effectiveness wise, both vertebroplasty and balloon kyphoplasty are cost effective because considering alternative treatments. But at the end of the day, if you don't have to do a balloon, I think it's really much cheaper to just do a unipedicular vertebroplasty. Some people ask, can you do vertebroplasty for chronic vertebral fractures? I think there is a role. I just warn the patient that the success rate may not be very high as well. Also remember that we're dealing with very hard bone. The pressures are going to be very high, and therefore you might not get a very good feel at the end of the day. I'm a big fan of the spine jack. Unfortunately, spine jack has exited Singapore. I'm not too sure about India, so we are looking for other alternatives at the end of the day, and these are the indications for spine jack. Between kyphoplasty as well as visual stenting, if I really need to maintain the height, I will reach for the spine jack. To me, it's really a no-brainer here. This is a fracture, a chronic fracture at the junctional area. And this one, spine jack in, and we see that as the spine jack opens, actually, even for a chronic fracture, you do get quite good height replacement at the end of the day. And after which, we started to inject cement in on constant fluoroscopy so that we can watch out for the leaks. Next, I move on to ablation. Still a little bit of time. There are many ways to ablate the tumors in the vertebral body. There's RF, microwave, cryoablation, embolization, and even ECT at the end of the day. This is probably the best evidence so far. This is a post-market analysis for OsteoCool. This is the Medtronic device. Prospective, multinational, 15 institutions, baseline pain, as well as other pain scores. There's rapid pain relief after you ablated the tumor on RFA, sustained relief as well, and it's quite safe. The OsteoCool is really very safe. It's only maxed out at 75 degrees. So most patients have no pain. You can leave it there for 12 minutes. It's fine. The only confounding factor is that in this study, almost all the patient has cementoplasty. So I'm not too sure whether you can attribute this pain improvement due to ablation or due to the cement. The take-home message here is RFA is effective. You can improve life. You can do it before or after radiation therapy as well, and there's a high safety profile. So this is the burn zone of the bipolar RFA, and this is our case here. This is a lesion, thyroid cancer, bipolar RFA, bipolar OsteoCool, and you can see that years later, the epidural component has gotten a bit better. So we can ablate patients with a non-intact posterior wall. You just have to be more careful. I think it's okay. For things outside the spine, perhaps cryo a little bit better. This is a cryoneurolysis with just a ice rod at the side to freeze off the intercostal nerve. I always tell people that inserting the needle into the spine is easy. What is difficult is actually the neural monitoring, how to make sure that your burn zone doesn't burn off the important things. So you can do a few things. You can do the patient awake. I'll show you later. You can use intraoperative monitoring, just like the orthopedics surgeons, local stimulation, and temperature monitoring. So thermal insulation, use saline, use dextro D5. You're using ablation. You can use carbon dioxide. The most important thing is get your needle into anterior epidural space. So go at the lower edge of the foramina, and you go in to get the lower edge of the epidural space, and you can inject air. This is a L3 or angiosarcoma. We did an ablation for this patient. It was quite an aggressive ablation, I must admit, and cementoplasty. Now, during the ablation here, we actually did the patient awake. So all the time she's moving her leg. And it can be quite scary. After a while, they'll start getting numb. They can't move. And that's when you stop your ablation and you actually reverse the patient. And then after inject cement. These vendors can be private, which means that you can hire them, come to the hospital. They will do the intra-procedure monitoring using the SSEP or the MEP at the end of the day. And this is the graphs that you get. So I tell the vendor, if there's a drop in 50%, you tell me, I'll stop the ablation. And this will happen here. The other question that we should ask is, do we need to ablate every cancer bone before putting in cement? We don't know whether it will increase the risk of metastases. Certainly, there's data to show that there's increased circulating free DNA after cementoplasty, but we don't know that. So I don't think it is a must. So in conclusion, MSK pain is a fast-growing service. We should provide it for our patients. And as the graphs have showed, if you have a thankful set of clinicians, your business can rise very fast. I really encourage you to start a cancer and bone pain MDT so you get a dedicated people to talk about the cases that you're concerned with. So have a robust discussion, get all the facts right before you offer anything to the patient. So in conclusion, vertebral augmentation is good. I think if you do your patient selection properly, especially for the osteoporotic group, is great. Junctional zones, I would prefer to stent. Let's see what replaces spine jack. And you have to treat the underlying disease, including osteoporosis and cancer. We're done.
Thank you, doctor, for beautifully explaining all the monitoring procedures and the role of the MDT. So may I request the speakers for the session to join us on the stage for a group photograph and before we end the session. So the questions for the queries would be taken after the photograph and conclusion of the session. Dr. Murthy is gone.
That ends the session. Thank you.
So like to keep this momentum of having people lose. So we want people to start discussing with us on every case. So I would like to make sure we have the mic going back around, and we would like to interact with everybody so that we are not the only one not speaking. So I would like to have Martin give a small summary of the guest experience, and then start.
Thank you again for the invitation. So we're going to celebrate our 20th anniversary. South of last year, it's number 7, and went around Europe with France, Europe, and the US. And we're doing once this last time in Sao Paulo in March. And the next prepared to get to the stage, which is the so I won't be long if we want to schedule these cases. So we have 30 days by the 30 experts. So each takes up to interact and ask questions. So let's start by so we can have the first sector. So you was one of my nice there coming over 3 weeks ago. So there's really 7-year-old woman, brother went to speak 23 in October. Not an emergency, she's in obese patients. She was considered high risk for anesthesia, for surgery, so which is why she went. So she went from 17 October to us, and then she comes back around 2 months later. Right small branch. Yeah, yeah, sure.
So you see that region. Who is quite short, who is for selective embolization, super selective embolization of that brand. Quite okay. Who would go for sacrificing that rice brand? No one. One person. That's a strong personality. I would tell you why that's actually not a bad idea. So the question I would like who would use liquid embolization these days? I promise you 10 years ago that's the majority of the people. So that's a very good change. Who would use coil embolization? Okay. So who would use a stent graft? All right. So just wanted to raise the.
I think it's a good introduction to what we actually did. So we tried, like you see, and you see these branches very, very, very simple. So we decided to go with the 1.7 micrometer there, with the low-function wire, and we failed. So I thought we see better if it's very good for the subjects here. We're giving it through that she said it's the same function. So what's next? Instead of us sending into sacrifice and organization, we can go to the whole slide with that culture. Personally, I try to avoid. I'm pretty sure that she has no question for mental their function, and she also has portrait which is fast. So certainly you can sacrifice something that it does. So
if you can't select a vessel, what other options we have? One, we can coil the right side cartridge. How many will do that? And the second option probably will be the stent graft in the right side cartridge, 22%. How many will do that?
Stent graft. We can't start after the case each selection. Who will do the stent graft? 1, 2, 3. Okay.
Who will do direct percutaneous stick to mechanism?
Wow, that's interesting. And then who will use Jeffo? Jeffo? You're the only one. No, actually, all of these are random choices. So that's the problem here. Okay, go ahead.
yeah, there is no right switch. I just want to show us the critique. So we figured out that we go to some three patterns. So we choose a small sand graft, which actually is a coronary sand graft, so structures from biotronic and what we have is here. Your cell joining scabbing, which is potentially half hand. So it's based on 0.14 wire. There are different sizes. The upper size will be 4.5 millimeters. And I'm just thinking this example where we have smaller sizes. So we'll decide to pick one 4 millimeter by 15 millimeter, and then we to a strong wire, which is the 0.5. And it was not easy because of this curve. So this is supposed to have a stand right, which takes this curve to navigate with this stand right, which is rigid. You're able to manage and go there, and we did this conclusion of the theater with maintenance of the patent parent artery and some spasm. So it's a pretty good. So I go back home. 5 of the data to go back.
Yeah, so I want to tell you because that's the experience I already had. And I want to make sure that I want to know the panel's opinion. When you select balloon expandable stent graft, there is one major problem, and especially in portrait system, is given by the straightforward shot. So I didn't expect anything natural. But your landing zone should be very low. If you say what the lesion is small, like half a centimeter each part, it's not enough. Because there is a risk
show you like what was briefly like the second session. So to your question, you're very right when you children aneurysm in the setting of acute pancreatitis resembles all the stimulation of pancreatic acids, which are all around the reproduction of the pancreatitis. But the thing is that it was not what happened here. The reason was from the other source. Because of a lot of local inflammation, potentially infection. So we bring back her to the CT unit. So this is the CT angio control of the fat graft, which is very nice. You can see here that there is no more spasm. There is no bleeding. So the bleeding is empty. The bleeding comes from very patchy areas around the gastrointestinal artery, and you can see here it's arrow. So you really cannot know where it's starting from. You assume it's starting from this bleeding. Here, at a later phase. So we go after the GPA. So I remind you that this anatomy is specific because we have both the right liver, which is taken care of by the right artery. So we have only one artery to the second floor, and the left liver, which is not a problem here. We have the GPA. So the thing is that you don't really see where the bleeding is. So it's a different measure. So we look at the countries starting in the second floor, and that's where we are. So we don't really see what is the cardiac branch. So the thing is that the patient is bleeding like crazy. It's in the middle of the night. So what can we do here? This is a different discussion. I won't show you what we did. We didn't find a single sphere that we would love to go after. So what are the options?
So, some people are not
I think gel foam is a reasonable option, or you can also use it to like create box.
Yeah, I think you can sacrifice GDA with gel or some combination. I mean, the other thing is, I hate to say it, but there's huge metabolites that happen. And it needs to probably be evacuated as well. So, surgical exploration is not.
Would any surgeon do that?
I think so. I think if you've done endovascular now twice, I think that's very reasonable.
And you're not afraid for a recurrent of bleeding because not compression or.
I don't think so. I mean, I think the risk of the income staying there is probably more harmful.
Any comment from the audience? Anybody will do something else? We have a microphone that we can ask other people's opinion. Don't be shy because if you don't do anything, I will name you. So anybody who wants to comment on that, raise your hand. You will use gel foam from the GTA. Okay.
Or you use liquid and volume to translate the study also. Then you liquid and volume.
Who is talking? This guy. Yeah, go ahead.
Then you liquid and volume is like move
In the GTA.
to translate the study also.
So, aren't you afraid of some So question mark, is there any possibility that it's bleeding from some other brand?
Well, I think there is, there are obviously, I think PCC now, which is the next thing you consider some buffering, which we thought was a leader. But we need also to understand that the timing of the CT angio, the timing of the rotation, is the angio leader, even at the liver because of pressure regimen, because of developmental status. So this patient is very important in the condition, and we cannot afford a repeat because of coagulation status. Reason why we said coagulation will not work because we are afraid that we can't just do a partial organization of the kidney stories, and we cannot go after that because we know that the risk of after we go into the small part of the layer which cannot be seen. So you can see, I think you can see here the written of the word of the place. For example, it was sweet 12, and we were happy because the blood pressure went up, but we were concerned about the secondary condition that would happen like necrosis and stuff. Fortunately, nothing like that happened, and the patient recovered after this stabilization. And that's the follow-up scan. You see all the low evidence of, and you can see the monitor what the case are from. So I think video would go also an option. Personally, I would use soil and use gel for, I think, weak writing and in that case of the functions. Thank you very much.
So a comment here, please.
The optimal patency of stenographs of small diameter is not great, but I don't have experience with apparatus that I've used Bathmaster.
So the question about the kind of city stenograph, I don't know, and I don't care.
So that's the thing. It's not very complicated. The one I had like answer of the stakeholder. What the thing is that you want to sacrifice anyway control, right? So instead of that, even if the facility stays in, even though we know that the opinion of the vascular artery in general, especially proximally, is not a big deal. But I am actually the partisan of saving this that.
What do you think would be the cause of the second trigger? Because we never went close to that area in the pathway. Would it be that the antiplatelets that we use during the trigger after setting the poison should have been to that?
I don't know about exactly what the question was. What is the cause of the second bleeding? I think sometimes, at least this is something I always say to fellows that post surgery or post trauma bleeding, you have to look at more than one vessel bleeding. It's very rare that there is one vessel. It's possible, but so maybe that there were the fact that this vessel, the hepatic artery was replaced. I know if you try to do a CPR check also at the time of the vessel, but very often you go directly to the artery and maybe close it and go away. But I would always recommend to do multiple vessel diagnostic angiogram. And then especially in trauma, the fact to have more than one vessel bleeding is not there. But in my experience, I think the same graph, I don't put anticoagulation for the first 48 hours anyway. Especially this
So you don't use fluoride or whatever. So here we discussed with the acid blood pools. We would recommend double of these center. Because of this situation, we wait for 10 days and then we start this second. That's something we say back to the watch. Maybe you go to the next place. So if you define the structure,
so I think we will not be able to go with all the cases, so we can do one case and then also one to take the room. We have that. Let's start your third case and we can check. So any last question or comment about the sample case?
Alright, so this is a 72-year-old man with a 2.2 centimeter left renal artery aneurysm. This is coronal. You can see here partially calcified the aneurysm in the axial. You can see that as well. Bart, tell me if you want me to stop or keep going.
So, just one question, maybe Sanjeeva. When will you embolize the renal
The standard recommendation across more than 2 centimeters, some people 2.5, and some people close to
we use specialists. If you have a young positive contractor, then we can avoid this.
So one thing is, for all the aneurysm, discovered aneurysm, 2 centimeter is the cutoff. But the problem is renal, and I think Dr. Morgan can talk about that, but the renal aneurysm, what we are afraid of is not the rupture, because the natural history actually shows 0% rupture. So more than the size and rupture, we want to make sure that it prevents from the thrombosis of the renal artery. So some key opinion leaders talk about actually treating them independent of the size. So what you see is, Rob, you have a comment on that. Can we give a microphone to Dr. Morgan? The microphone is here. Sorry to put you on the spot, but I couldn't believe your lecture. You are the expert.
No, that's the point. I was enjoying the show. It's a great pleasure to be actually asked the question that you posed. We use several things. Anybody who wants to have children, we then like any areas of plants, and then like cycling to the way that somebody highlights or other things. Otherwise, size, 20 millimeters, growing or systems, sort of thing. But somebody that's like calcified, you have this structure very low. So, you do this, you watch it, you do all the pressure, or wait till it's calcified. I don't know if you're interested, don't know what you have to say.
So that's a good point, and by the way, there is some debate about calcification and rupture. But in the renal, I think that's the most important.
I think there's another point to take into consideration is the psychological aspect of the patient. Because some are crazy about this of rupture, even if it's very small. Because everybody they will just scan 1 year, 2 years, 3 years, and then they get mad on that. So sometimes we push on treatment, even if you would not like to do this.
And what Rob said also is very important. In portal hypertension, especially with speed, I don't care about the size. In speed, all of them are very good. You have a comment?
So I may have misunderstood, but why are you assuming that this is going to begin with? Shouldn't it be a two-animal that has quite steady or? Yeah, no, sorry. It's not a surveillance, I'm just using that part under the word surveillance to sort of classify the standards. Like,
it is an aneurysm.
It's an aneurysm. It's a surveillance. So all two-animals need not be treated, all two-animals.
Absolutely, yeah. So we were talking about true aneurysm. So the aneurysm, in general, the recommendation is to treat them. Now there are some studies showing, for example, that so the aneurysm post-pancreatitis can shrink with time. I am very scared of giving those answers. So the aneurysm should be treated.
So in this case, if they are assuming it is a two animal, and now we are deciding whether to treat or not. Yes. Okay. Yeah, so I think all very good points. I think there's thought that calcium can be protective of aneurysms, but I think Mark also had a very good point that the psychology of patients and the threshold for treatment can change depending on that. So here, as I mentioned, we have a evacuated type of aneurysm with a slightly wide neck. And so our strategy here was to try to preserve the renal artery by coiling the sac itself. So just again, showing a cartoon graphic here. It's a pretty straightforward case, I would say, but you can see here we put in a 5-inch catheter into the renal artery, and then advance the microcatheter into the sac of the aneurysm itself. proceed with oiling that intercept with detachable electrodes. Before I ask questions.
Yeah, so can you go back and show the experiment diagram? Okay. Don't go back. All right. Next. So where is the angiogram for? That is. Okay. So who would do what Osman did in this situation? Just raise your hand. Okay. Who would do say that is assisted poisoning? Rob? Randy? John? All right. Who would do the stent graft? So the stent graft in this situation is going to cover the branch. Okay. So yeah, one other question, Osman. Did you show me the endpoint?
Here. Okay.
Would you did you do this patient on anticoagulation after that?
This patient, no.
Because I think the packing was good enough that there is no risk of thrombosis. Anybody who put anticoagulation on this patient? No one?
What do you have to do with that?
What do you do? Who? Anybody wants to talk about who on this case? No. I think there is it's not right or wrong. You can it's just a question of how can you keep it in this. So if you want to do that, you should follow the right. Yeah. What do you think about that? As I said this morning, the use of coil in addition to noise is much more common, especially in elderly. Would you do that, like one or two training coils and then see that?
No, you're much more brave than I am, for sure. But no, I mean, I definitely understand that that's a viable way to do this, but I feel much more comfortable with this.
So one question to the panel and the audience. We have all heard about cortex. Who cares? Do you care?
I don't. I used to when I first started. Yeah.
How about you guys?
I do care.
Do you calculate that?
Don't calculate that, but I act out.
Yeah. So that formula online that calculates how much, but you don't use that. How about you want?
But I don't try to find as much as I can, which is always a trick because I know less zones, the worse it's like can happen.
If it was a bit profitable, where it is the result? Maybe just nearby because of the what would I do the setting?
If the aneurysm was closer to the bifurcation,
a bit proximal to the bifurcation.
Oh, proximal. So proximal to the bifurcation.
Just kind of bifurcation.
Just at the time, just at the origin of the bifurcation.
Oh, I see.
Which means that you can probably have a coil block both sides.
I mean, I think it really depends on the neck. You know, with this neck, I feel comfortable putting just a micro catheter and being able to coil it. But if I had any concern, I would probably do that in this sense.
What would you do?
Say I have proximity. We have used flow diagram.
So you brought the flow diagram. That's very good.
We'd like to ask the audience, how many of you saw this case in your surgery?
How many surgeons?
How many?
Yes.
How many of you find a surgeon to do that kind of case? Because for us, in some case, we would prefer to refer to surgery because the anatomy is so complex. But when we try to find a vascular surgeon who would be confident to do this, it's not easy because there are very, very few guys skilled enough to do this kind of surgery, which is intrarenal surgery, like auto-consultation type of thing. So I just wanted to raise that point, that apparently here you can get that as well, right?
It would become even more complicated if it was to have this concept of solidity. And just now I was looking after was large area of the solidity. Similarly, if you have this solidity, then at any cost you have to try and preserve the solidity. Which also suggests that we may not be able to preserve, we may lose the ability during the procedure or that confidence.
So if there is aneurysm or the present and the bifurcation of the main renal artery, not about a brilliant with the best artery. So what would you consider at that time?
It may think of with the same as steroid or blue as steroid, but it is easier said than all these things.
Considering the aspect ratio of this aneurysm, or maybe the neck was a little narrower, couldn't we just get away with the push-up points while you detachment points?
How many would you push-up points in this case? Raise your hands. Push-up points. There are only 3 people. How many would you detachment points? Okay, no, you are not.
So I would like to just have a follow-up case on the renal immunization, because it's very interesting and it's totally by accident that I selected. So this patient was referred to me for splenic embolism. The patient had a splenic aneurysm and the patient didn't talk about what we saw, which was the renal aneurysm. And so you can see here the renal artery aneurysm. So we started the patient and we did the angiogram, showed the splenic aneurysm and the renal. And we discussed that the patient preferred to treat the renal first, then the splenic. And I think it's fair to see. So this is a little bit like the case you were talking about, more proximal. The neck is larger than what Osman was showing. So what did you use? Maybe Mark, then some other Oh, please do that.
I would really look carefully at the 3D image as well as steam or solid coating to photovoltaic precision. This seems to be that there is only one entry and one exit.
Yeah.
But the entry seems to be very large compared to the exit. And the neck, I mean, the part of the artery feeding it seems to be short. So I would consider a sand graft, but not easy.
Sand graft, yeah. So I will show you. So what is something?
I agree with what Mark said. The proximal segment that part is too short by the proper seed with the telegraph. I would probably consider this base center instead of the coiling of the aneurysm.
How about you?
Yeah, that's what I was looking at. Probably I would back up what Mark said and say it's a really good 3D to understand best angle that opens it up.
So you see, from that aneurysm, I can categorize the aneurysm to the outflow. And so you can see very well where is the outflow of that aneurysm and where is the inflow. So we decided to go for air-stem assisted embolization. Anybody will do it different. Like any idea, other ideas we didn't discuss. Balloon operation and percutaneous functure with equally. Yeah, who will do that, by the way? That is actually a smart way of anybody will do that. Because you have to turn the patient posteriorly and do the different
Raise your hands, how many will do that? Okay, that's a good question.
Okay, so
question is, how much kidney do you sacrifice to the sand graft?
That's what we see. Which is probably one-fourth of the kidney. I don't know exactly, but as I always say, I'm the partisan of saying that much. Now, what Mark said is very important. I think it's very important when you have a risk of when they take this kidney out, they treat it and put it back. So again, if you got my kidney, I would prefer to save it instead of sacrificing it in body. So it's important to think that there are options. Of course, when we have a hammer, it looks like a nail, but we don't want to be like that. So be careful. So what I did actually was a very easy place to stem. You see the stem there, went to the large float 8 probably into the cat, into the aneurysm, put the coils, and you see the stem is in the other vessel, not in the. And we ended up with this image. I think I was satisfied with that, and so you can see the view of the packing and the. So the patient went home with this image and came back a month later for clinical evaluation. Patient was doing good. We did the clinical evaluation, and as a result, the patient went home and started to have pain. It's very normal for cerebral patient to have pain, but this pain was a little bit different. The pain was posterior and the back to the left side, and I'm usually not used to see that. Usually the pain in the spine is higher and higher pain. So we brought the patient back and realized that actually there is an infarction of the spleen, the kidney, a month after. And so what has happened here, I have no explanation. That image. You see that here? So the stent migration in a month later, which is extremely unusual. But the lesson I learned from this is that, well, what was my mistake there? Anybody have a comment there? What was the type of the stent? It was self-external. The length was, I think, 3.8 something. I'm not sure the last check. Let's see. Get the mic, please. You go ahead.
One other thing, this has happened 1 month after splenic embolization.
Yes.
After splenic embolization, you can suddenly have rising platelet count. That may not be.
Yeah, that would be an explanation, but I probably did something wrong to get to this point anyway. Any other comment?
Straight could have been slightly over 6. Over 6 is almost 6.
Well, so I always went with the idea of that study about 11 years ago that we are sending 26 millimeter or above to reduce it below 2 millimeters. In this case was I decided to put a 6 millimeter stent, and that's my mistake. In those cases, you have, especially in the normal vessel, because the rest of the vessels are normal. Young patient normal vessel, you have to oversize your stent. That's my opinion. Anybody comment on that? Yeah. Anybody would think how the how do you what side would you use coagulation or after that? The first month, sir. Yeah, only first month. Yeah. So okay. So for the spleen, I didn't care. No, of course. So for the green set.
I may be wrong. Well, it's easy for me to say right set, but the big one that you use.
But
still we can see big enough for that.
6 millimeters seems to be large.
Yeah, but
was not large enough to go this way.
I'm surprised that you went up to 7 millimeters. It's not actually there any longer.
Yeah, you are afraid of stenosis. So it's something to keep in mind, but I would say there is a risk in a normal person, young patient. So an atherosclerosis patient you don't care, because you know that there is enough resistance sclerosis in the vessel, but the normal vessel you have to be careful. Any comment?
The normal venous is that what those students see that they just go into the life. As we go closer to the life condition, towards the higher, you have to keep in mind that these cells are going to act as a molecular. got it here. I have experience with one or two good diagram. Then it is very loss of mineral paradigm. And we definitely get some requirement.
Kumar, do you have something to that? I see you are looking at it first. No? Wouldn't you use larger SN? So you would have, you probably done the same thing. Alright. So
therefore, one question, if you control a jury to make sure that the set actually migrate, because on the CT, I think it's not so easy to see.
That's a good point. Actually, I have a follow-up CT on this station, but
What would you have done right to start? You did the stage over. Would you balloon assisted filing?
no, I would have done the same thing. Yeah. So this is the follow-up. ID. Yeah. And this is 3 months old. So the majority of the kidney was the area that was thrombosed came back and it was pressed. So any other question or comment? Yes.
Just a comment. You treated the average successfully. Good results. We involved a little bit of kidney, not great, but just not disaster. So good result.
Yeah, I was too guilty. I don't like
Don't be too nice.
Yeah, I think you would decide my heat file because the 6 millimeters thin, it's equally for that, this is sort of the renal arch would be the right size. I think the only other comment that didn't happen in your case is that we should be careful because the renal arch is a real cells. And so if you see cells in the meters with the kinase needs to give some GTL, perhaps the size of the set a little bit bigger. The arch looks smaller. So actually for one discussion for SPK, I used to use always 6 millimeters. Then I talked to some key opinion leaders like Alan Masimoto and Chris and they say they usually go for 7 millimeters in some of those regions. So this discussion between 6 and 7 millimeters for even younger women is very interesting, but I was so scared of when you lost 6 millimeters and you have some people actually think that 6 millimeters is the base or the origin of the, but I totally agree with the different spasm. So what do you think?
I just had a quick question. What was the design of the wire?
The question is, there are wires both perforated error pass and the wire which is led to tender often.
So that's a possibility, but when I placed the stent, there was no problem at that time. The problem started months after I put the signature. So that's it. If it was like the next day, I would say that probably there was some technical problem. But what was really bothering me was the 1 month delay. Because at the time I did the implementation of the sleep, the patient was doing great. Now they're building everything was good. So it happened like post signature. So very
So when you did these screening and evaluation, did you take a check of the renal?
After the second evaluation, I didn't check on it.
Okay, this is a very simple case. I think most of you have done this case already. The 75-year-old woman with diabetes and a cardiac pneumonia present massive hemoptysis, and a CT was performed, and a CT scan shows as a severity a pseudoaneurysm of the superior follicular artery. And what we consider probably most of us do an angiogram and why. So this is the angiogram. Which shows aneurysm, and selective injection does show the aneurysm. It was not easy to select, but again, we got selected. So this is what ultimately aneurysm is here. With all in observed, you can see a small projection into the bronchus there, but there is activity going on. Because the contrast into the trachea going out here.
is actually the contrast going into the drum. So what embolic liquids most of you would use? Coils? Anybody would use glue? There's one guy, 2, 3, 4. Okay, anything else you would use? Any fluid awareness people? No? Stainless steel coil, covered stains.
So let's discuss the flow diverter because I think it's something we need to discuss on last day. How many of you actually, I know that Rob has talked about that, how many of you actually believe on this flow diverter for peripheral? Because we know it's usually 4.5 and above. What is your, who would use flow diverter to actually
I have used one for hepatic arteries, and good can I use one for splenic artery for.
Well, usually when they are smaller, but larger component, it can't be done.
Prototype we use in selected cases. One could be critical normal. If the course of artery is very good, doctors, then we can understand. Second thing is, if there is no active extravasation, then it will become sterile. So many of us, we also do urointervention. The experience we got from urointervention, that's what we do.
Yeah, I think for a smaller vessel, but the other thing is that when you use flow diverter, you use anticoagulotherapy with two different medications. And especially for aneurysm, I have realized that we don't close those aneurysms. So I am actually going only on some smaller hepatic arteries or sometimes in the situation where you have to sacrifice the major vessels. But if they size enough, 5 centimeters, I will do it otherwise. Anybody, I see that table there are a lot of key opinion leaders. Any comment on that? Rob or Philip or? Yeah, that's for Rob. We don't use it for Rob.
I mean, I've tried it a few times and I noticed that I'm still confused. We have to develop also find the cost. You know, they're much more expensive than a few detachable coils.
Given that this is rupture, would that make a big difference in selection of the embolic material? Would you still use glue to instead of glue? If I wasn't strong enough to use glue here, so I said okay, use coil.
You could use you really could use VO, which is what we go. And we go for video from others because it's very easy, it's straightforward. You don't really care about sacrificing or sacrificing one or two additional branches, and it's fast. The only thing is that you need to prep for that ahead of time because you need to shape it. So I mean, when you bring the case from the CT, you have time to prep, right? Prep everything, then what we'll do. I think the one thing which is very difficult in that case is finding the appropriate parallels. And usually you use 3D engineering, but it's sometimes very tricky. I saw that it's really difficult. You can comment on that as well.
So I went ahead and filed it, as you see that file analysis, file installation, file processing. So that my intention is to reanalyze the third vessel. I want to interact both profitability to back number. So this is a post injection, and I thought I did a good job. I'm going to agree that I did a good job here. I think you did an excellent job. Thank you. So I'm going to have to follow this thing down. Okay, so like you guys follow, I follow this statement. And 3 days later, this is how it looks. Go back to the previous. And go to the next one. Go to the next one. It's a very good compact oil here. It's a very nice compact. The next thing you can see is no longer compact. What oil did you use? You want to know? Yeah. It's a non-fiber Peninsula hard packing. It should be very close and hard packing, packed in the sack, approximately a regular liquid foil that you use.
You will do repeat angio. And if you do repeat angio, you will go back and follow that. Okay. How many will you do that? 100 people. So this state, remember, is in fact a 12,000.
How was it for you while you are at your comment?
I would first ask what is the iteration of this sugar? Is it an absence? Is it tuberculosis? Have an idea of the reason for this?
So this patient has pneumonia, so the infection is here. So there's not positive for tuberculosis, probably mostly amazing.
So Rob and Sham, then ours.
So the cause moves, but the patient's not bleeding anymore. So we would obviously treat patients like this.
Great comment. Sham.
And so this is actually a majority of it. But even if the patient is not bleeding, we have to practice it. Okay, we will see what has been seen in front of them to understand it more faster.
The basic concept of the life test usually consider cell life proper life there. So looking at the second ill part, I will not break it left long.
I think it will be concerned about this. If you've got just pulmonary mortality, very serious disease, and theoretically might not complete your treatment. So it's a picture.
You would intervene, right? You would not.
You would intervene.
So the problem with intervention is that the vessel that is supplying the aneurysm is completely embolized. You see this picture up to the level of the main pulmonary artery. We already caught. There's no pressure for it to go back into that arm. And this is already caught. So whether we can do a stent graft or a surgeon go and check the lobe, that's another great. But it's a good thought. If there is a state, for example, go to the angio, right? Probe it, if the microbiome is not able to get it, panic out.
As Rob said, the patient is asymptomatic. I understand what you're saying, but certainly I will not go back to the character, but our chances of going alongside is quite small. Asymptomatic patient, I go ahead and CT to reduce my artifact, and since if there is any risk, I feel that the aneurysm is still in place and is enlarged, then I will go towards this.
That's exactly what we did. We thought getting back into the aneurysm stack is very tricky. We got a CT scan. We did not see contrast in that area. I don't know if it's the result is still completely blocked on an study, and we thought, okay, we'll stop it, we'll not take it. After a week later, we got another suspect, and this is how it looks now. So now what do we do?
Shams, you have a comment. You know the thing. Okay.
No, don't tell. Go ahead, Shams.
The patient is fantastic.
Yeah. So she's not bleeding, but the point is in the tract around the tree.
Yeah. You want to go?
Yeah, very nice. So the question is, would you retrieve the coil, go put a catheter into the bronchi and retrieve the coil, or would you ask the bronchoscopist, go and retrieve the coil, or what else would you do?
My question here is, what we think has happened? You're saying on one side it is totally troubled. There is no lead. Now why is it moving?
So I think what has happened is, you see this picture, there is active contrast stabilization from the pulmonary artery to the bronchial. So the right fistula, pulmonary bronchial fistula is still. Even though I packed it, the fistula gave away and the coil just migrated into the bronchus from there. They're not filled with blood because coil spread distally, so the blood is not coming. But each time you breathe in, breathe out, side spread, and the coils are migrated back into the tract. state standby, it's bleeds, I can go back and embolize again. We talked set the current on the surface, okay, if she bleeds, it will connect me here now, there's not much I can do there. So those are considerations. And likely, all you need was just try this one, take a file out, this file remained as it didn't have a very after that.
So, Sanjeeva, one question. Have you thought about something like this? You know, the first thing I told you to talk about is, have you put a same graph, or would you put a same graph in not an infectious, but in general, a rupture in a bronchial.
So I think in this case, regarding myocarditis, I will not do the cover stent, but I have used peptide stents in the pulmonary circulation to treat untreatable pulmonary AVM, the very short neck and AVM. So losing entire artery, I have like 6 cases that I put the stent graft, and they remain indicated even after a couple of years of follow-up with it. So we have done that.
Anybody? Yeah, go ahead. Can you give your mic?
Hi, so this actually happened to me before, but my causes cancer, and the patient coughed out with the coils a few years later. We tried to send the pulmonary artery after that. It was a horrible idea, and it's really because the configuration of pulmonary artery is conical. The send might be this, so I don't think that from the pulmonary artery is this.
So one consideration could have been, I could have asked the brown house to put a stent graft in the brown house to keep the coils so they don't come back.
I had a similar experience. It was, we completed this case, not for this, it was a research variant with ongoing workflow. It was aneurysm was one of the we took a big coil, and the aneurysm was taken care of. He presented on the follow-up that aneurysm and that segment was reduced to one small cyst, but we had a coil sticking into the, migrating into the trachea. The mistake that we did after that, like you were telling that I asked the doctors to try and do it. We just kept elongating. Finally, we just had to leave it. Patient systematic is doing well, but exactly that people.
I had a similar case, but not in the chest, actually in DRMD, and I think if you go post DRMD, most patients you can see the coil. If you happen by accident to pack the aneurysm, so that most of the like case like this at the University of Iowa, when I coil, patient was doing well. The next day they did a scope. They called me and showed me the picture of the coil into the stomach and said, "Can I remove it?" I said, "Please don't touch it." So those type of lesions need to be covered with normal gastric wall. So we had that follow up that patient was good. So this can happen if you do anything.
Why it's also in the forward with the last section. So you have to have this where coronary valve was broken for a few years back, and that work is straight to the level of the right. And she does that with sugar instead of the slide. And the next set of life stage of natural. I think I have a prediction. So these things will happen. In similar case, we actually asked the bronchoscopists to deal with it through bronchoscopy. And apparently they are just going to say. Very compounds.
Very good, second.
Maybe not in the state, but in TB, you see that a lot of times the bronchial artery is also supplied by the system. So when you see these vascular lines, many times also the bronchial artery is supplied. So maybe most of the time, 10 minutes, when the embolize also the bronchial artery, starting to make sure that what are the cases that are support? One of those, what is the problem of the whole thing about body coordination? In the airway, because they are very touchable, even having small objects, they don't cause infections. So what are the I think in this case, they're better than more than five. Or the problem.
So just a final question on that case, great case. I think you feel rightly honest. Because I think the only solid is vibration, we face in 1 second, and we also are saving. Then in that case, economically going to have pretty limited. the time, real time, to achieve this reduction of the grade from 3, 12 to 18.
Mark, this statement has a Peninsula and a finally target in the broadcast. Would you be worried about Onyx going into the broadcast?
No, I don't think how small equals the broadcast and everything they think.
Especially because
Yeah, maybe, but I think it's a life-saving thing, and I think we can maybe I'm wrong. We've done a lot of these cases, but not in my memory, not is a fistula, as you said. But if there is no fistula, directly go to the center. If there is, I would do that with maybe a little.
the only problem with fistula is that the patient will smell blood for the rest of it.
They do smell.
That's a big problem. All right, Shaks.
Yeah. So Mark, you mentioned about Onyx. I think an example of similar Onyx regulation plays in the liver, not in exploration. However, it's pretty similar because the movement is zero mentioning. Every movement is zero. And you are alluding to the fact that possibly the movement will deploy rather than without. And Onyx will not. But we had a vision of this really neat and we can try to identify like coils came out and try we tried Onyx and Onyx made the same thing. So Onyx also after hardening it created much like coils. So I think Onyx will take the same fate like these coils. Yeah, the only advantage is like you not see the X-ray, but when it pops out, it's X-ray. You have to go in and view the coil.
After that discussion, I want to know how many people now would use glue? Yeah, because I think that's a very good thing. I think sometimes we need that as we do the survey of people before the case and then the survey after. And I think that's one case where glue may come to the glue deduction.
Okay, so another case. So it's an 8-year-old man, history of prostate cancer. We need to do this carefully to spread from the story. So prostate cancer by radiation therapy and surgery, very serious surgery to help with regeneration, precancer diagnosis, left tracheostomy, left double chamber stents, and left coloscopy. Comes to the emergency department with a left bleeding from the stomach because he had some teeth. Massive hematuria, needle tracheostomy, the patient. So we do another CT scan with and without contrast, and there's no activity. But we find pneumodigestive fistula. So the patient is referred for urgently for surgical revision or specialized advice. This is where we are. Unfortunately, the next line, hemorrhagic shock, is severe bleeding, 6 and 94. So they call us and do the emergency again, 95. So this is the left kidney where you can see that there is a double G stent, which we have right here. Here. And this is contrast. And these are blood clots all over the base of the kidney cavities. So you see there is severe hematuria. We go for analysis of the CT angio. We don't see active bleeding. We see this image. We go further. We try to understand what's happening. And we see here there is potentially a pseudoaneurysm here around this. So we for pseudoaneurysm, we find pseudoaneurysm. The left of the country in contact with the return, which does explain the urinary bleeding. So suspicion of left arterial fistula. So these are other projection of the CT with the blood and kidney, and here fluids in place from the blood which across the artery. Isvir resin, which is actually the place for really fatty. And you can see exactly the junction between the artery and the left where it was WG set. So we put a set graph. So what can we do? Surgery, consultation, that was certainly all of this discussion. Surgery is an option because of the very complex medical situation. So we try to cover this, we try to do something else.
So stent graft. Who would do a stent graft here? Majority. Who would do a stent where the stent has to go in? Why not cheaper? Why is it one? Okay. So how many people would you do? What did you do? Any comment? Any other technique you would recommend that we didn't think of?
I think that's the limit of normal tissue because I think most people will choose stem graft unless you really want to. I think the limit is tissue. The patient was bleeding, they would get dropping, she was completely paid. Some of my colleagues did an angiogram, nothing. CTA, nothing. Angiogram, nothing. Significantly, fluorous here, very called. Another CTA, maybe something showed up, nothing. Other angiogram, nothing. Then I really want to do something. I think the angiogram instead of call the neurologist to pull the stand up. And the more you do this, you're going to solve it. Otherwise, you'll have nothing to see them in the whole universe. You just didn't grab it. Is it like 6 years? She's still really well. She's getting out of the costume, she's getting 18 months in a year. I don't make this up follow.
Yeah, I think at the point sometimes the leverages and make the ceiling for some hours to reopen. So my next question, you guys are going to understand about this, but the question is which size?
I think somebody has another idea.
Yeah, I think some scenarios, especially in cancer, some came with the direction. So there is a focus all the time. So it turned out that this has that risk of being infected. So it's because we haven't bought before, we try to exclude surgery. If it's not possible, then we might do some oil ionization toxicologists and at least try to exclude the disease part. Surgery is probably a better option if you can. Next, there's course can be tried, but we always need to have a very low threshold to be prepared for the emergency situation, especially when we say communication with your gut or the tract.
testing me. Mic testing me.
Check. Hello.
Hello. It's working.
Good afternoon. Hello. Hello. There's no.
Good afternoon. We'll be starting miscellaneous IR session in Peninsula, working with thyroid, hemoptysis, uterine fibroid, PPH, and pre-op tumors. For that, I would like to call upon the chairpersons, Dr. Harish, Dr. Robert, Dr. Gaurav Gangwani, and Dr. Manish on the stage. Yes. Thank you. So, we'd like to start the session with a presentation on thyroid ablation, how we do it, by Dr. Ajit Yadav.
Hello. So I think we don't need any introduction for Dr. Ajit, and let's directly hear from him.
Thank you, chairpersons. Good afternoon to all of you. My name is Dr. Ajit Yadav, and thyroid ablation is one of my favorite topic. We started thyroid ablation in 2018, and we have completed approximately 1,000 cases till date. So I have nothing to disclose. So whenever we take the patient, we always take a history, the age, signs, symptoms, blood investigations, imaging, and FNAC or biopsy from the nodule. Always take the clinical photo of the patient in AP and lateral view, because that is going to, we can show them that how much regression is cosmetically we can see. And always do an FNAC, at least 1 or 2 FNAC depending on the thyroid staging of the thyroid nodule, and that FNAC should come out to be Bethesda 2. If it is Bethesda 2, then only we can do the ablation. Pre-procedure evaluation is, first we do the benign thyroid nodule ultrasound. Then in ultrasound we always assess the nodule volume, cosmetic score, symptom score, lab test like T3, T4, TSH, PT-INR and CBC. CT is needed in very less cases if it is retrosternal thyroid, then sometimes we need CT or MRI. Why 2 FNAC or biopsy is needed in these cases? So thyroid nodule, if there is thyroids 3 or 4, then we need at least 2 FNAC. If it is thyroids 2, then only 1 FNAC is enough. Now come to the method of ablation. So we have chemical ablation, that is ethanol. In thermal ablation, we have radio frequency, microwave and laser ablation. So what is ethanol ablation? So whenever any nodule that is more than 50% cystic and 50% solid, we always go for the ethanol ablation of the cystic part. And how we do that? In this patient, we always aspirate the fluid from the thyroid cystic part and inject the 50% of the volume, total calculated volume. If let's say 10 ml is we aspirated, 5 ml of alcohol, absolute alcohol, we have to inject, keep it for 5 minutes and then re-aspirate. After the aspiration, if the solid part is there, then you can do the microwave or RF ablation of the solid part. So that is easier one. You just have to aspirate, wait for 5 minutes, re-aspirate the alcohol, wait for the solid part, and then routinely what we do, take your microwave antenna in the deepest part of the nodule and ablate the solid part of whole of the nodule. So you can do, if it is a large nodule also, in the single session you can ablate with the chemical plus alcohol ablation plus microwave ablation. So according to the criteria, if it is 50%, if it is less than 50% solid part, means if it is 90% cystic, we can go ahead with the ethanol only. But whenever it's more than 10% of the solid part, if it is less than, let's say if 80% is cystic but 20% still is the solid one, we have to combine both of the modality. If it is completely cystic nodule, alcohol ablation is enough. But whenever the solid part or mural nodule is there, then we have to mix with the thermal ablation. So consensus and recommendations is less than 10% solid part, ethanol should be the first line treatment. If it is more than 50% solid component is there, thermal ablation is preferred modality. So cystic part, if it less is only the 30% is the cystic part and rest of the solid part of the nodule, definitely then you don't need any alcohol aspiration, just aspirate the fluid and do the microablation of the whole of the nodule. Now come to the contrast ultrasound. Contrast ultrasound is one of the modality that you should have before you start your ablation, because that is going to tell you how much of nodule is left and we can treat if there is any residual lesion is still there, so we can ablate in the same session. If you don't have in your machine, sometimes the B mode, on the B flow mode you can see the vascularity, but it's good to have contrast ultrasound. If you are starting your practice just now, is better whenever you buying the machine, tell the vendor that I need contrast ultrasound capability in the machine. Like in this patient, you can see the nodule, and after the nodule you can see I'm going to show the video. So contrast, you can see the whole of nodule, there is very high flow is seen within the nodule. You can see the enhancement is there, and after the ablation there will be some air bubbles, so you have to compare with the B mode, and you can see this black hole. So what we call it as a black hole in the full of nodule. If anything left in the periphery or in the central part and that is not the air bubble, then you have to ablate that again. Hardware, what we need for hardware, we need a microwave machine, we need antenna. Antenna now comes in 17 gauge, 18 gauge or 19 gauge, in 7 centimeter also, in 10 centimeter also, in 15 centimeter also. We need ice cooled normal saline or dextrose if we are using RFA. We need foot pedal. Antenna is coming in the different active tip, so we mostly use the 3 mm active tip for this. 10 centimeter the standard antenna used for all cases. For short neck sometimes we use 7 centimeter. If it is the thick patient, then we can have the 15 centimeter also. So ablation setup, first we need definitely a patient needed for that, then an IR, then we need microwave antenna, cooling tubes, and then we need a helping hand and an ultrasound machine. A good ultrasound machine is always needed whenever you start. Make sure the best machine in the department should be used for the thyroid ablation. Ablation setup, ice cooled 0.9 normal saline, and tubing should be connected and it should be running. So make sure before doing in the patient ablation, always check the antenna before. Make sure the tubings is correctly working. If you are reusing the antenna, it's must to check, because the new antenna always work well, but whenever sometimes we reuse the antenna in the same patient, always check the cooling is going on, and always touch the antenna. Whenever you do the ablation, your finger should touch the antenna rod whenever it's starting. That is going to tell you whether it's going to be some burning is there or not. Otherwise, it can happen that skin burn or skin tattooing can happen. Position of the physician, so that is the most of the physicians will do like this, but yeah, definitely you can do the ablation from the right side of the patient, but it's my preferred position is always sit on the head side of the patient. And if you are doing RFA, then there should be the grounding pad should be there. If you are using microwave, then the no need of ground pad. And it's reverse position for us as a ultrasonologist, is a reverse position for us, but you are going to be like, if you do 2-3 cases, you are going to get accommodated with this position. So if you want to start your practice, better do all FNAC like this, and then you are going to be like, you can see your ultrasound image by your probe and your position of your hand. Hydrodissection. So before doing the ablation, we always do the hydrodissection to prevent the heat injury to the adjacent organ. How to do hydrodissection? I am going to show this. Take a extension tube, fill a syringe, normal saline, 20 ml. It should be at least room temperature or the cool. And take the needle, just go near the capsule of the thyroid and start dissecting it. You don't have to keep like needle, you just keep near the capsule, sometimes entry into the capsule and then coming back. Whenever we inject the fluid, it's going to spread the fascia. You don't have to make ideal hydrodissection, that's not needed. Sometimes you see that it's going into the multiple fascia, into the fat, that's okay, because that is going to be, now it's a recommended, you do interfacial plane hydrodissection. That is going to give you the more time to absorb by the body. So take your needle inside, slowly inject the fluid till it keep on reaching up to the danger triangle. So take needle inside, injecting, keep on injecting. If some fluid go inside the nodule also, don't worry about that. It's not going to harm the patient. Take your needle, reach up to the danger triangle, inject at least 20 ml of saline near the danger triangle. So up to 60 ml. In one go, you can inject up to 60 ml of normal saline. Patient can complain of pain near the ear or maybe in the neck region. She can complain or he can complain about the fullness. Sometimes because of the cold saline, pseudopalsy of the recurrent laryngeal happen, but that usually resolve within 15 minutes. For the hydrodissection, I'm going to show the first video. Whenever we start the hydrodissection, make sure your needle visualization should be in ultrasound field. Never ever inject the fluid without seeing the tip of the needle. So it's a rule, whenever you see the needle tip, then only inject the saline. So you can just ask your nurse or your helping hand, now inject, stop, now inject or stop. So that is the rule, because if you don't see the tip, never inject the fluid. Going into the nodule, take the antenna, go into that artery, ablate that artery first. That is going to reduce the supply of the large part of the nodule, and that will be more ischemic, and that area is going to burn within seconds. So that is increase the enhancement of the ablation. The second one is the venous ablation. After doing the ablation, you have to peripheral, there is a large peripheral vein is going around the nodule. You have to ablate that vein also, because that is going to reduce the heat sink effect while doing the ablation, and that enhance the ablation capacity.
Time is up.
Yes. No. So ablation is like a cautery. So whenever you go into the artery, this is going to clot that only. So any artery that going into the nodule, if it is less than 1 or 2 mm, then no need. But if it is more than 2 mm, definitely you have to take antenna, go inside that and ablate that. Ablation is like a cautery that is going to stop the bleeding, not is going to increase the bleeding.
I'm going to interrupt, so conserve some time. Dr. Ajit is already available here for more questions. So we'll like to thank you, sir, for the great talk. And I'd like to call Dr. Anubhav for the next call for thyroid ablation. Where do we stand? Thank you.
Yeah, hi, good afternoon. So, my talk is not going to be as glamorous as the previous one. It's more on the data and evidence that we have and what's the current role of ablation. So, we have moved on from our initial understanding of the advantage of ablation. And contrary to what was earlier thought, that the biggest advantage is that it's a scarless treatment for thyroid nodule. It's not, because these are two images, one with conventional surgery and one with robotic endoscopic surgery. Both patients treated by surgery, and you can see it's absolutely scarless surgery. So surgeons have moved to that. And just to have a background, thyroidectomy has been known to mankind for over 1,000 years. However, the procedure has evolved over several years. And this is mainly because of the contribution from great surgeons like Theodore Cocker, who made substantial advancements and making thyroid surgery safer and more effective. Over the years, there have been several advancements, and thyroidectomy has gone from big, scary scar surgery to almost scarless surgery. And surgical treatment has been offering definitive treatment with predictable results, creating high benchmark for any alternative approach to take over. So we have to understand that thyroidectomy has given patients absolutely disease-free survival. So we have to match up to that. And if surgery is so good, why are we talking about ablation? So it's because in spite of all these advancements, surgical treatment has failed to preserve thyroid gland. They've been unable to remove the thyroid nodule from the thyroid gland, leave the thyroid gland back into the patient, and have the thyroid function properly. That's the limitation of that. And treatment with ablation has been revolutionary in giving new hope to these patients in preserving the thyroid while getting treated for benign and even malignant lesions now. So the onus is on us, the intervention radiologists, that when we are choosing our patients, we choose them wisely. We give them the results what thyroidectomy has been giving to these patients. And it's very important that we do the ablation for the right people in the right way. So initially what started as a treatment for benign nodules, euthyroid nodules to hyperfunctioning thyroid nodules, now the treatment has expanded its role to the malignant lesions for the recurrent thyroid cancers and as well as primary thyroid malignancy. And this is all based on robust data, extensive studies, and the guidelines based on that data. So if we look at the guidelines, it's just a glimpse that I'm going to give you. So it started from 2009 when Korean guidelines came in. They were the first guidelines which actually were very extensive. They told us the indications, the kind of patients we have to choose, what we have to do to define if the patient has malignant disease or a benign disease, and everything, even the technique and everything. And then from there on, everybody started imbibing those guidelines and doing cases and making their own guidelines. The 2009 guidelines again got improvised in 2012, where they extended the role of ablation for the malignant recurrent thyroid cancers as well as autonomously functioning thyroid nodules. 2015, we saw the Italian paper, the first Italian consensus coming in. 2016, we had American Endocrinology Society giving us their guidelines for use of ablation for benign nodules. 2017, we had yet another guidelines from Korea, again improvising the results and saying that we can still use it for all the previous indications and extend the role into the primary malignant cancers. 2019, we had guidelines from Austria. 2020, we had guidelines from minimally invasive treatment group from Italy. Then we had 2020 European guidelines. 2022, we had another American Association guidelines. And 2022, we also saw guidelines coming from surgical society. So this was an international consensus, which was multidisciplinary team, which had surgeons from across the world. There were Europeans, there were British, there were Asians. So everybody was there, and not even a single intervention radiologist on that. So these guidelines actually talked about ablation for thyroid lesions. And 23, we had American Thyroid Association giving out their paper, their guidelines saying that benign nodules should be treated with ablation unless patient is desiring a surgery. That's what they said. So this is what the world has been waiting for. Would American Thyroid Association start talking about it? And that's, yes, they did it. In November 23, they released this paper. So that was all about the guidelines that have been from all across the world, almost published every year from 2009. So if we look at the Korean guidelines, as I said, so they are the most robust guidelines. 2009, they said it can be used for benign thyroid nodules. 2012, they said it can be extended to autonomously functioning and recurrent thyroid cancers. And 2017, they extended the role of ablation for even primary malignant disease. As Ajit had already mentioned, you need to prove them by using FNA. The only thing is that you have to do FNA twice, except if the lesion is a TIRADS 1, purely cystic lesion, you may get away without even doing a FNA. Second is a TIRADS 2, but a classical spongiform nodule. Not every TIRADS 2 would require one, but if it's a classic spongiform nodule, then yes, you can just get away with one FNA, proving it to be benign. Or if it's a autonomously functioning thyroid nodule, it's a hyper-functioning thyroid nodule, one FNA is enough. If it says it's a benign nodule, you can go ahead and give ablative treatment for that. Looking at the results, now we have a 10-year data on it, a follow-up data. This is coming from Professor Beck from Korea, and he published this last year. And the 10-year results were 94% volume rate reduction, which was the best that we've seen so far. However, he said that there was issues of regrowth, and overall regrowth was noted in 12% of patients. So we have to be wary about this. We have to be having these patients coming for follow-up, even if the symptoms have resolved, even if the cosmetic effects have gone. We have to call these patients for follow-up to see if there is any regrowth which is happening and tackle that at that time. Regarding the autonomously functioning nodules, ablation has been advised only as a second-line treatment and also for nodules which are less than 12 mm. It's not that for larger nodules it is not effective. The reason is that when the nodule gets larger, you are more likely to miss the margins. And because it's a hyper-functioning nodule, this will come back and it will regrow. So that's why if a nodule is less than 12 millimeters, it's more likely that you'll be able to ablate it completely and not have a regrowth or a residual lesion to cause symptoms to the patient. Coming to the ablation for malignant disease, now it can be offered for recurrent thyroid cancers which come in post-operative patients. So it comes either it's in post-operative bed or it's in adjacent structures like trachea, esophagus, or skin, or it's a nodal metastasis. And it can also be offered for low-risk papillary thyroid microcarcinomas. So let's look at recurrent thyroid cancers. So recurrent thyroid cancer rate is almost 20 to 59%, varying according to the risk of recurrence. And the standard form of treatment is either surgical or radioactive iodine. Now, the choice depends on the site of recurrence. If it's a surgically friendly site, then surgery remains the best option. Otherwise, radioactive iodine is one which has to be given. However, RAI has not shown great results. It's only effective in 50% of patients. And that's why it's always a one that we can, if we can do surgery, then we should go ahead and take the patient for surgical treatment. However, there remains critical issues with reoperating the already operated side, and there may be technical difficulty with that. Patient can be of high surgical risk, or even in situations where patient is not wanting to undergo surgery. Then ultrasound guided ablation is a good alternative treatment for these patients. But there are guidelines for that. And that is that if we look at 2017 guidelines from Korea, then they say that you can treat these lesions if they happen to be less than 3 in number and each lesion being less than 2 centimeters. If we look at the international multidisciplinary consensus, which came out in 21, they have given the concept of ablation either being curative or being palliative. So if the lesion is less than 2 centimeters as described in Korean guidelines, then it is curative. But if the lesion is more than 2 centimeters, it's more likely to be a debulking procedure and more likely to be a palliative treatment. There are also recent guidelines which published in 2025 from Korea regarding treatment for recurrent thyroid cancers, again emphasizing what was described in the multidisciplinary consensus. And it also says that either it can be curative or palliative, again the same thing, less than 3 lesions, each lesion being less than 2 centimeters in size, and there should be no lesion outside the neck. We can offer curative treatment just like surgery for these patients. If we look at the results, we don't have a long-term results for these patients for treatment of recurrent thyroid cancers. However, the short-term results have been very promising, and the complete disappearance rates have been almost up to 93%. And if we compare the results with surgery, they've not been a head-to-head trial, but the retrospective analysis and propensity match scores actually show that 1, 3, and 6 year survival, recurrence-free survival rates have been comparable to what has always been offered with surgical treatment. So all in all, RFA is a good treatment as an alternative to surgery for recurrent thyroid cancers, considering that we keep RFA reserved for patients who have smaller lesions. Coming to the primary thyroid cancers, now the thing is that lately there have been more and more smaller lesions which are being detected, and it's probably because a lot of patients are undergoing health checks and they get their ultrasound done, and more and more of these smaller lesions are getting detected. So most of these cases, which are malignant and small, less than 1 centimeter in size, are very slow growing and they rarely spread, raising the question as how these cancers should be treated, because they are seen not to affect survival of the patient. It is more likely that the patient will die with thyroid cancer rather than dying because of thyroid cancer. So that's why there's always been a question whether these patients should be subjected to any treatment. And surgery was historically the treatment of choice for these thyroid cancers. While surgery is always curative, it is unclear whether surgery is needed. And that's why American Thyroid Association says that any lesion which is less than 1 centimeter in size, papillary thyroid carcinoma, those patients should be put for surveillance, active surveillance. Every 6 months, every year, they have to get an ultrasound done to see that the lesion is stable. Now what happens is that, and they say that there's no need for surgery for these patients. Now, the thing is that once patient knows that he has or she has thyroid cancer, it's very difficult for them to just be on surveillance, and there's a lot of anxiety regarding that. In that scenario, ablation can help. Ablation can be selected for these patients and can be shown to keep the lesion. At least they have this thing in mind that, okay, something has been done for me, and they can avoid surgery for these patients. Now, this is only true for low risk papillary thyroid microcarcinoma. So we have to know what are these low risk lesions. So this is any lesion which is less than 1 centimeter in size, is unifocal, is confirmed on FNAC or biopsy to be a malignant, and also of a less aggressive subtype, and there is no evidence of any extrathyroidal extension or any nodal mets. So these are the lesions which can be subjected to ablation upfront as a first line. And if we look at the long-term results, we do have a 10-year follow-up on these patients, again coming from Korea. And this is actually showing evaluation of the long-term results on 60 patients. However, there were 20 patients who required repeat ablation, but all those patients in whom the ablation was completed, none of the patients had regrowth of these lesions. There were 7% of patients who had newer lesions other than those which were ablated. But as far as the effect of ablation is concerned, they were able to achieve complete ablation for these lesions with a complete volume rate reduction. So just to summarize, as to today, what's the ideal situation to consider RFA for these patients? So no guidelines suggest RFA as a first line treatment for primary thyroid cancer. It can be complementary to active surveillance and can only be done for low risk papillary thyroid microcarcinomas. For recurrent thyroid carcinomas, it's again a second choice, only if surgery is not possible. And one important thing that I want to make is that we have to understand that the fundamental clinical context differs entirely for benign nodule treatment that from the malignant. The goal is cure, and it's not symptom palliation or debulking as it is for benign nodules. And complete ablation with adequate margin is mandatory in these patients. Any residual viable tumor represents treatment failure. And we would never be able to match the surgical benchmark that is there, because surgical benchmark is absolute cure for these nodules. So we have to have ablation to that extent. Margins are critical and must extend beyond the visible tumor to account for possible microscopic extension. And long-term oncologic outcomes, disease-free survival, cancer-specific mortality are relevant endpoints and not the volume reduction percentages. Thank you.
Any questions from the audience? You may have mentioned it, but microwave is not useful for this? Microwave ablation as opposed to RFA?
The difference?
Yeah, do you use microwave for these lesions?
So, no, sir, are you asking what is the difference between?
No, I'm asking you whether microwave is a useful treatment for these lesions as opposed to RFA.
Yeah, so I think there's enough data now saying that microwave ablation is equally good as radiofrequency ablation. The only thing is that in long-term results, they've seen that when they compared results for 10 years and 4 years data, then they've shown that the volume rate reduction was slightly better with radiofrequency ablation than microwave.
Thank you.
So, any questions from the audience? So I have the another just because most of all of us are the intervention radiologists, and it's difficult to get the referral from the surgeon for the thyroid ablation. So what can be done to get the more referrals? And this is related to some different, but this is what practically we are usually face during the practice.
Frankly speaking, I just feel it's a matter of time. I think it's just a matter of time. Another 5 to 10 years, surgery will be out for thyroid benign nodules at least. And I think all those patients will be sent to us by everyone. If you look at the guidelines, these guidelines are not coming from IR. This is coming from endocrinology. It is coming from surgery. It's coming from all clinical groups.
Last 2 minutes.
It's just a matter of time. I think the want is that they want to learn ablation now. Yeah. That's what is there.
Yeah. So initially they deny that this is not useful, or this is surgery versus this, and then after that they will start their own, they will take thing in their own hands. So I think the social media awareness is the most important thing to get especially for the thyroid and the uterine things. Thank you. Thank you, Dr. Amnu.
May I please invite the other speaker who was part of the session for a quick group picture? Dr. Ajit Yadav, can I have you on the stage? Ladies and gentlemen, give them a nice big round of applause. That was a fabulous, detailed session. Thank you very much. Continuing with this theme, I invite the chairpersons for the following session. Dr. Dheeraj Tiwari, Dr. Monish P. Can I please have you on the dais? And the moderator for this session, ladies and gentlemen, is Dr. Soumya Chitra. Can we welcome them with a nice big round of applause?
Hello, good afternoon, everybody. I would like to call Dr. Kalpana Radhakrishnan for her talk on bronchial artery embolization.
Good morning, everybody. So this will be a little bit basic about bronchial artery embolization mainly for the beginners. So before, we should know that hemoptysis is a very potentially serious and life-threatening condition, and it definitely warrants an urgent investigation. So initially, we have to be clinicians and decide that this hemoptysis is actually originating from the lung, and you have to differentiate it from hematemesis, epistaxis, or any other nasopharyngeal bleeding. So for this, the way the patient says whether he coughs the blood or vomits the blood, and all those history will help you decide and that it is actually hemoptysis. So when do we call it life-threatening? Previously, there were a lot of data saying if it was less than 50 ml, it is mild, or 200 ml in 24 hours, it is more severe. But now, of lately, it is more clinical definition where it is 100 ml in 24 hours, and it causes respiratory failure, or the patient needs intubation, or there is hemodynamic instability. Initially, all these hemoptysis resulted in 75% mortality, but with advanced surgical and endovascular management, we have brought it down to 13 to 17%. So we all know that the lung has got a pulmonary circulation, which is a low pressure circulation, and only 5% of massive hemoptysis are due to pulmonary artery circulation problems. While the bronchial circulation is high pressure equal to the systemic pressure, and it causes more than 90% of the hemoptysis. We all know there are a lot of varied reasons why the patient can present with hemoptysis. It may be within the lung, like tuberculosis or aspergilloma, which is what we most commonly see in India. It may be rarely be to trauma or lung cancer. And we also have to differentiate pulmonary embolus, which could be the cause of the hemoptysis. Apart from that, you have to also be aware of systemic causes like Goodpasture syndrome, anticoagulants history, and also be aware that aortic aneurysm could also present as hemoptysis. So here we have a female who is 45 years old with life-threatening hemoptysis. The CT chest showed volume reduction of the left lung and gross cystic changes. So when this patient is referred, any patient is referred for bronchial artery embolization, first we have to get the medical history, whether the patient has any other comorbidities, whether the patient is on antibiotics, and the next we have to plan what to do for this patient. So first, when we are deciding on the bronchial artery embolization, we have to work up for blood investigations like the PT-INR and also the pulse oximetry and the platelet count, which has to be within normal limits, or you can give blood coagulants if necessary to up the platelets before your bronchial artery embolization. You also have to go into the CT chest or the CT pulmonary or whatever is available to decide on the site and the cause of the hemoptysis before you plan for the bronchial artery embolization. And whenever you have extensive disease, you please look for extra bronchial supply in your CT chest. Sometimes even a plain CT chest without a contrast is enough for a bronchial artery embolization. You don't necessarily need a contrast study unless there is something on the CT chest which says that it could be a pulmonary AVM or a really vascular malformation. Now, the indications according to CIRSE is any life-threatening hemoptysis where the pathological arteries are observed on CT. It is also when you have a sentinel or an index bleed where patient is having mild blood streak sputum for a few days and then suddenly has an extra bout of hemoptysis. So these patients necessitate bronchial artery embolization. The only absolute contraindication is when you see a branch which is supplying the heart, the brain, or the spinal cord. And the relative contraindication is when the patient has a pulmonary artery stenosis and this hypertrophied bronchial artery may be the only source of or the major supply to the lung, then you think twice before you embolize these bronchial arteries. On CT, what are we looking for before we take the patient for the bronchial artery embolization? So you can look at the parenchyma, the airways, the systemic arteries, and the pulmonary arteries for the source of the bleed. So the parenchyma will let you localize whether it's on the right side, left side, upper lobe or lower lobe, whether there's bronchiectasis, aspergilloma or infections. Sometimes there may be just ground glass opacity, which is the result of the hemoptysis and not the cause of the hemoptysis. In the airways, look for tumors and foreign bodies, which may be the source of the hemoptysis, and look at the systemic arteries, the bronchial and the non-bronchial arteries, systemic arteries like the intercostal, the internal mammary, and the other arteries, whether they are dilated, tortuous. Also look for subpleural, if there is pleural thickening, any dilated arteries in the pleural thickening. Also look at the pulmonary arteries, whether there is any bronchopulmonary anastomosis or infarct, which is the cause of hemoptysis. So what do we need? A basic kit for bronchial artery embolization. You need the Seldinger needle, which is a single puncture needle. You need a short sheath or 5F sheath. You need a Cobra, any 4F catheter, which is a Cobra, a JR, or a SIM. SIM is needed for some difficult cannulations. Otherwise, you can go with a Cobra or a JR catheter. If you have a hydrophilic catheter, it is easier because it can enter the dilated intercostal or the bronchial artery with the 4F catheter, and you may not need a microcatheter. You need PVA particles, and if you want to go distal, you need a prograde microcatheter which comes with its own wire. You also need drugs for the local anesthetic for the femoral puncture and heparin also when you put the sheath in, and depending on the how long the study is prolonged, you have to give 1,000 units per hour. A little bit about, since we are all radiologists, just look at the DSA machine. You can choose the frame rate for the lung, set it in the lung sitting at 3 frames per second, and also try to keep the fluoro to a low level. And remember that time distance is where you reduce the radiation not only to the patient but also to yourself while you're doing the study. And I'm sure all of you all know the femoral puncture. You can palpate the femoral artery over the femoral neck of the femur. The puncture should be in the medial upper half of the femoral head, where it is easiest to compress post-procedure. If your puncture is too high into the iliac, then you do not have a bone underneath to press the femoral artery and compress it, and it could lead to a pelvic hematoma. So you can use your ultrasound guidance for this puncture, or you can do a fluoroscope. You can mark where you think you feel the maximum pulsations with the metallic object like an artery forceps. Do a quick screen to see whether it overlaps on the femoral head when you are initially beginning your femoral artery punctures. We can all look up the anatomy. Usually the right is intercostobronchial. You may have 2 left, 2 right, 2 left. There are a lot of variations of the bronchial artery, which you should be familiar with while doing the bronchial artery embolization. Mostly they arise from T5 to T6, but you have ectopic bronchial arteries which could arise from other vessels like the internal mammary, the subclavian, or the pericardiophrenac or thyrocervical branches. Embolic material, we use the PVA particles. These are a little bit of, or you can use the embospheres, which are more spherical and more round, but necessarily you have to use more than 300 mm because this is the size of the bronchopulmonary anastomosis and you don't want an embolic manifestation. You can, gel foam is also used only after the PVA is done, maybe to block the major feeding artery, and coils are rarely used in bronchial artery embolization, especially in our setup, because these patients usually are tuberculous and the they may come back with recurrent hemoptysis, and if you have blocked the feeding artery, then it's difficult to access the bleeding site again when the patients come back with rebleed. So these coils can, however, be used in bronchial artery aneurysms. So here is a chest fluoroscopy. Then you look at the carina level. So even in a blind, you don't need an aortic run to look for a bronchial artery origin, because the run is so fast, and it is very difficult to pick up a bronchial artery opacification in an aortic run. So you know by anatomy that this is where the bronchus, the left main bronchus is there. So just you can go directly blind there and search for your bronchial artery. So you move it up and down till you feel that it is clicked into the ostium of the bronchial artery, and you can do your bronchial angiogram at the site of the parenchymal abnormality. So once you have done it, you can embolize. If you are in a good position where there is no reflex, you can embolize your PVA particles right from here, and you can, it is usually a pulsatile slow injection, and let it not reflex back into the main aorta. So post embolization, always do a check angiogram to see whether the main hypertrophied or the abnormal arteries have been addressed. So what are we looking for? We're looking for either tortuous arteries or parenchymal blush when we are doing an abnormal bronchial artery. And this is the post-embolization angiogram, which is a must for all these patients. Okay.
Time is up.
Okay, I'm just sorry. I think it's, I've got a lot more. So this is a right intercostal bronchial angiogram. So when you taking this, you also look for, this is got a normal intercostal component and an abnormal bronchial component. So you can, if you inject from here, you are going to address both these studies. So preferably you go selectively into past the intercostal bronchial, and then you do a selective injection of the PVA particles. So when you search for extra bronchial supply, whenever there is pleural thickening here with prominent arteries, you search for a extra bronchial supply. Here is an intercostal with supplying the lung parenchyma, diseased lung parenchyma. Whenever you have lesions in the apex or the base of the lung, try to take a subclavian run or an inferior phrenic run, which will show the abnormal supply to the lung parenchyma. Here's a patient with destroyed lung. So here you can see the internal mammary artery, which is also supplying the diseased part of the lung, and the lateral thoracic, which has also got a shunting. So you can do a post, and you can go selectively into the internal mammary and then do an embolization. So when you have a pulmonary artery shunting from these vessels, you can see the pulmonary artery shunting. You choose a higher or 700 to 800 micron for your bronchial artery embolization. If you have a difficult access from a femoral, you can always choose a radial artery technique to hook the difficult to approach arteries. Post-procedure, you do a manual compression, or you can use any of your vascular devices, compression devices. You have to give the antibiotics, continue the tuberculous drugs, and warn the patient for the post-embolization syndrome. This is a patient with an aspergilloma, and you can see the leash of vessels around the aspergilloma cavity. Sometimes some things are very funny here. This is a patient with just a mild fibrosis, which is what I thought, but on bronchial, you can see such a dilated bronchial artery. Another patient, 16 years, just 2 minutes. Another patient, just 16 years old, he just came with hemoptysis, and you can see he just had ground glass opacity, but the vessels were really tortuous. And so when I was thinking of vasculitis, we embolized the bronchial artery. He was okay for 10 years, and then 10 years again he came, and you can see the mildly tortuous bronchial arteries, which are, pulmonary arteries, which are extending to the intercostal vessels, and he had ground glass opacities. On bronchial, again, you can see the blush on both sides, and we also did a pulmonary angiogram, and you can see that the vessels were really extremely abnormal with a multiple small aneurysms in the pulmonary artery. We still do not know the cause for this patient. The 60-year-old last case, he came with an infective foci in the left upper lobe, and when we did the CT angio, we also picked up a small aneurysm on the same side in the aortic aneurysm. So we were wondering whether the cause of the hemoptysis is aneurysm, but we also made out a lot of prominent vessels in the infective foci. So we said, well, let's go ahead first with the bronchial artery embolization. Anyway, we took the aortic run with a pigtail to look for whether there was any fistula to the bronchus, or which may be the cause of hemoptysis. When we ruled that out, we went ahead and did the bronchial artery embolization. So just a word about the complications in bronchial artery. You can have slight back pain, chest pain, dysphagia, and also vascular injuries to the access site or while manipulating the bronchial artery. But the most dreaded complication is a spinal cord infarct, because if you find the bronchial spinal supply from your bronchial artery, you have to be very cautious. So here is a right intercostal angiogram, and when we took it, we saw that there was a spinal radicular artery. So if you embolize from here, you're going to embolize the spinal artery. So there are two options. You can either go use higher particles, 700 to 800, which is supposed not to go into the spinal artery, or you take your catheter distal to the spinal artery and then embolize this. But there is a word of caution: when there is a spinal artery seen, it is better to avoid the vessel unless it is a major supply and you are experienced, and it's better to go right distal to it using a prograde and use a larger particles and make sure it doesn't reflex. But if it is just giving a mild supply, then it is better to avoid these so that the patient can be better. So these, in a nutshell, life-threatening hemoptysis, you have a better outcome to the patient with bronchial artery embolization, and in CT, look for the extra bronchial supply and have a basic armamentarium, which is just 4 or 5 things, which is ready, and you are good to go with bronchial artery embolization. So I really thank my postgraduates and who helped me with this study. Thank you.
Thank you, Dr. Kalpana, for your excellent presentation. I have a question. What's your opinion about embolizing with glue versus PBA particles?
We rarely use glue, sir. We only use PVA and gel foam for the main arteries. So.
And the second thing is, you said that about, although you explained it later, that main catheter can be used. Are you worried about inadvertent reflux into the interspinal if we are using the?
Yeah, see, main catheter, this in the animation we show it, it's from the orifice, but usually we don't do it from the orifice. If the bronchial artery or the intercostal artery, they're usually sometimes dilated more than 4 or 5 mm. You can take the 4F catheter itself distal to the ostia, and then you can use the main thing. But if the main catheter is not able to go into the feeding artery, then we necessarily use a microcatheter.
Any questions from the audiences? I guess there is no question. Thank you so much for your presentation, ma'am.
So we'll go to the next speaker. I would like to call Dr. Pavan Kumar Garg for pre-operative tumor embolization. When, what, and how?
Thank you, Chairperson, and good afternoon all. So I will be talking about the preoperative tumor embolization. So basically, when we talk about the preoperative tumor embolization, what does it mean? It is not moving.
Call somebody from the audio-visual team.
Oh,
it's working. Working.
Slightly lag. Okay. Okay, so basically preoperative tumor embolization, meaning embolization of the tumor. There is some issue with the.
We get somebody from the audio-visual team, please. The slides are not working properly.
There is difference in the slide here and the projection. This is first one. There is inside.
लैपटॉप लॉक हो गया ಅದು LED ನ ಈ ಸೈಜ್
It's not projecting actually.
ಇದು ಔಟ್ಪುಟ್ ಸ್ವಿಚ್ பண்ணுங்க
It is moving here, but projection is not.
இந்த பொடியை மாத்திட்டாங்க அந்த அவுட்புட் ஸ்விட்ச் பண்ணுங்க
So let me over. Okay, sorry for the
timing.
Okay, sir. Sorry for the inconvenience. So basically pre-operative tumor
sir,
embolization.
Can
Yeah.
we restart your timer?
Yeah.
Can we restart the timer, please?
So basically pre-operative tumor embolization, when we talk about the tumor embolization, what does it mean? Basically we are trying to reduce the blood supply, or we trying to block the blood supply of the tumor, which is required, and it is useful mainly in the highly vascular tumor, and usually it is required in a complex anatomical region which require complex surgery, complex dissection, usually where the critical structures are lying very close to the tumor. So these are the common tumor which in which we can offer the preoperative tumor embolization. The most common which we are doing in a head and neck tumor, followed by various vertebral tumor including hemangioma, spinal metastasis from the vascular tumor, the bone tumors including osteosarcoma, GCT. Other tumors like liver tumor and the renal tumor can also be, we do preoperative embolization. So what is the advantage of doing a preoperative tumor embolization? It will help in the reduction of blood loss during surgery, and by reduction of blood loss, the surgeon will have a better surgical field to operate or to dissect in or around the tumor. It will also help to reduce the tumor size. It will indirectly help in the radical clearance of the tumor. And literature is showing that with the preoperative embolization, the chances of recurrence of tumor is reduced, and it will help in the downstaging of tumor also. So what are the different techniques? So we can, as we all are IR, we can do either transarterial approach, we can, in some of the tumor, we can do directly percutaneous approach, or combined approach can be used to embolize the tumor. Usually the duration of preoperative embolization is variable. It may range from 1 day to 7 days. It again depends upon the size, location, and the type of the tumor. And mostly we usually do preoperative tumor embolization 1 day before, or sometime when tumor is it is located very close to the some vital structure where the edema can cause compressive effect, especially in the intracranial setting, we can do just before the surgery. The embolizing agent, we can use a mixture of embolizing agent ranging from PVA particle, embosphere, glue, onyx, coils, or combination of these agents. So starting with the case, this is a 17-year-old boy who has a left-sided juvenile nasopharyngeal angiofibroma. This is the tumor which is highly vascular and usually referred to us for preoperative embolization by ENT surgeon. So what is important here, in all cases of JNA, we should do bilateral ECA, bilateral ICA, as well as vertebral angiogram to look for the supply. Mostly it is supplied by the ECA branches of the same side, but sometimes there may be cross supply from the opposite ECA, and there may be supply from the ICA on the same side or opposite side also. So first we have to do angiogram to look for what are the potential supply of the tumor. Once we are sure that the tumor is primarily feeding through the branches mainly from the ECA, we should target all the ECA branches which is supplying that tumor. Like here in this case, it is the predominantly supplied by the left sided ECA, and it is through the internal maxillary artery which is supplying the tumor. We have used a microcatheter as distal as possible, and then we have taken super selective angiogram, and then we have injected our PVA particle. And this is the post embolization angiogram showing complete disappearance of the tumor blast. So we should be very careful whenever we are doing a pre-operative embolization, especially in the head and neck region, because there are a lot of ECA, ICA danger anastomosis is there. There may be variant anatomy in that particular case. There may be some ECA branches which are supplying the cranial nerve. If we are not careful, it may lead to inadvertent embolization, may lead to stroke or cranial palsy. Then again, the choice and the size of embolizing agent is important, because if we are choosing very small size particle or we are using liquid embolizing agent, there may be chances that it may lead to non-target embolization. Then if a tumor is supplied by the lingual or facial artery, we should be very, very careful, because if we are doing a total embolization, it may lead to skin necrosis. So like in this case, we can see there is a ECA angiogram, and from this middle meningeal artery, we can see retrograde filling of the ophthalmic artery. So we should be very careful to check for any possible danger anastomosis. Like in this case, the occipital artery angiogram in ECA can show filling of the vertebral artery. Sometimes tumor is also supplied by the ascending pharyngeal artery, which is supply to the lower cranial nerve. So we should be very careful before embolizing ascending pharyngeal artery, which is supplying a tumor. So what precaution we should take? We should first do a complete angiogram. We should do all 6 vessel angiogram to see what are the likely supply to that particular tumor. We should check each and every angiogram, whether it is supplying or not supplying. We should try to see all the angiogram carefully. We should take a forceful run before starting embolization to check any possible collateral channel which can be seen on the initial stage. Whenever there is any vaso-occlusive disease, like suppose there is a carotid artery stenosis, carotid artery occlusion of the same side, or if there is a vertebral artery occlusion, there may be high chances that those danger anastomosis may open. So we should be very careful whenever there is a pre-existing vaso-occlusive disease. We should always check choroidal blast, whether it is coming from ICA or ECA. Sometimes it may come from ECA and it may be inadvertently embolized. We should always avoid a wedge catheter position, because during wedging, if we inject anything, it will go more into collateral branches rather than going forward. We need to be very careful whenever we are reaching to the later stage or the final stage of embolization, because most of the collateral will open in the later stage of the embolization. And whenever we are using liquid embolic agent, we should be very, very careful. How to prevent non-target embolization? First, the size of particle. We should usually target a larger size particle, whether it is a PVA or a embosphere. We usually target 200 to 300 micron particle. Careful whenever we are using liquid embolic agent. Sometimes simple proximal mechanical blockage of the collateral branches. If we can see any collateral branch which is supplying some area which is we don't want to embolize, we can put a coil or a large particle before starting embolization. Or sometimes flow reversal method, we can do proximal balloon occlusion and we can do reversal of the flow, and that will be helpful in the prevention of the non-target embolization. Going to another case, he is a 19-year-old presented with the left-sided carotid body tumor. Here we have taken angiogram from left CCA. We can see there is a classical appearance of the tumor which is located between the ECA and ICA, and it is supplied primarily from the ascending pharyngeal artery. Here what we have done, we have gone selectively into the branch which is supplying the tumor, and we have done a tumor embolization using a onyx. So here it is very important, we should not do embolization from the proximal part of the ascending pharyngeal artery. We should target and go into selective branch which is supplying the tumor, because ascending pharyngeal artery is supplied to the lower cranial nerve, which can lead to a palsy. So what are the literature is suggesting for the preoperative embolization? So lot of systemic review and meta-analysis is there, and most of the review literature is saying that preoperative tumor embolization will lead to reduction in the blood loss during surgery. It will reduce the duration of surgery, and also it will help in the reduction in the recurrence of the tumor. So coming to the next case, a 68-year female who has a left-sided cerebellar hemangioblastoma, and surgeon was like asking for any preoperative embolization we can do to reduce the blood loss. So what we have done, we have gone inside the feeder, which is primary from the vertebral artery branches. We have gone and we have embolized using the onyx, and they have done the surgery, which has significant reduction in the blood loss. Coming to the one interesting case, a 32-year-old female patient who is pregnant, presented in 8th month of pregnancy with weakness and paresthesia to bilateral lower limb, more on left side, less on the right side. And on imaging, we diagnosed that she is having a D3 level aggressive vertebral hemangioma. So after delivery of the baby by cesarean section, we have planned preoperative tumor embolization. We have done transarterial embolization of the major feeder, which is from the intercostal arteries from both bilaterally. After that, there is a partial improvement in the power. So what we have done, rather than directly sending for surgery, we have also done the percutaneous alcohol injection because the main tumor bulk is on the left side. So we have done the left-sided percutaneous approach. We have entered into the pedicle and we have done the embolization using the absolute alcohol. So by combining transarterial as well as percutaneous, it will further reduce the vascularity of the tumor and it will help in the further better outcome. Coming to the last case, a 20-year-old female patient who presented with a pain in the back and difficulty in voiding and defecation. We can see there is a large cystic expansile lesion from the lower sacrum with multiple fluid level. So diagnosis of a GCT, but because of extensive nature of tumor, the surgeon don't want to do upfront surgery. So he has sent the patient to us for any role of preoperative embolization. So what we did the preoperative transarterial embolization from the bilateral lateral sacral arteries. After that, we have done the percutaneous embolization like previous case. Here what we have used the mixture of doxycycline as well as albumin, and similar to sclerotherapy what we have done in this case. And on follow-up, there is a significant reduction of tumor size, although they have not yet operated this patient. So my take-home message is that preoperative tumor embolization is useful in the reduction of blood loss as well as it will lead to reduction in the surgical duration. The knowledge of arterial anatomy and the densest anastomosis is very important, especially if you are dealing in a head and neck region. Careful selection of the embolizing agent is very essential for better clinical outcome and as well as to avoid any complication and non-target embolization. Thank you very much.
Thank you, Dr. Pavan, for your presentation. We are running little, behind the schedule, 20 to 30 minutes. So questions can be asked to Dr. Pavan individually.
Thank you. Thank you, sir.
Thank you so much.
Thank you, Chairperson.
Time is up.
And Dr. Soumya for the session. And thank you, the presenters. For the next session, we would like to call upon stage for the Chairperson, Dr. Anil Kumar Singh, Dr. Santosh Babu, Dr. C. Dev Prakash Sharma, Dr. Vikas S. Chennu. And for the presentation, I'd like to invite Professor Raghunandan Prasad, sir, for the role of ablation for uterine fibroids.
Should I start?
The first talk is on role of ablation for uterine fibroids. Dr. Raghunandan Prasad, sir, will be speaking on this topic. Sir, please.
Thank you, chairpersons, and good evening, one and all. So I'll be speaking on role of ablation for uterine fibroids. And we all know that uterine fibroids are the most common benign gynecological tumor in reproductive age group women. This FIGO classification is very important because a lot of symptoms and a lot of treatment depend upon the location of the fibroid. And we all know the symptoms: menorrhagia, pelvic pressure symptoms, infertility are the most common presentations for these patients. So watchful waiting, medications, hysterectomy, myomectomy has remained most common conventional treatment for these patients. Also, we have some uterine sparing minimally invasive therapies like uterine artery or uterine fibroid embolization and ablation. So, pioneered by Merland and Ravina in 1919, uterine artery embolization is a quite well accepted, minimally invasive treatment for symptomatic fibroids. However, since uterine artery blocks the blood supply to large section or all of the uterus and fibroid indiscriminately, and due to potential risk of non-target embolization of ovarian arteries, a lot of patients have actually many concerns related with early menopause or fertility related issues. Again, post-embolization syndrome is another problem which actually bothers for many of these patients. Just the real world scenario, 32-year-old female with severe dysmenorrhea and primary infertility, large intramural fibroid in the posterior myometrium, fibroid reaching almost 7 centimeter. Most of these patients are quite literate. They already come after a lot of Googling to you. And another similar 48-year-old unmarried Indian based in UK. So she consulted there in UK for, but doesn't want to undergo uterine artery embolization for those fears. She was living with the pelvic pressure symptoms. Third, another case, 38-year-old married female, bulky uterus with multiple large fibroid with pelvic pressure symptoms. She was also a case of endometriosis, underwent in the past underwent for the endometric cyst rupture, laparotomy, then laparotomy related complication, incisional hernia, etc. Another 28-year female, unmarried, huge, you can see entire abdomen is occupied by the enlarged uterus, multiple fibroid, causing severe pelvic pressure symptoms. She was surviving by self-catheterization but not willing to go uterine artery fibroid embolization or surgery because he was unmarried and etc. So what we can offer to them, uterine fibroid ablation is a minimally invasive treatment option. So this bridges the gap between the uterine artery embolization and the myomectomy. So just like a myomectomy, it takes care of fibroid tissue only, does not affect normal uterus, and also it is a very less daycare procedure, less procedure pain. So first history date back to 1990. Just if you remember, I just told that Merlina and Ravino, uterine artery embolization was also discovered by them at the same time. So this uterine fibroid embolization was also started at the same time, but because of the availability of poor technology at that time, mainly it was done with the help of bipolar cautery or laser. Rate of complication was quite high, so it was not that not that widespreadly used at that time. With the introduction of new ablation system that allowed control energy delivery to the fibroid tissue, and also the real-time guidance under the ultrasound or MRI, these uterine fibroid ablation has recently emerged as another popular minimally invasive treatment option for symptomatic uterine fibroids. So if we talk about currently available modalities, ablation modality, we can group in them thermal and non-thermal. Most common are the thermal ones. So in thermal, we have a radio frequency, microwave, MR guided HIFU. Also ultrasound guided HIFU is also available, but most common is the MR guided HIFU, laser and cryo. They have a limited role. In non-thermal, we have this IRE. We all know it's a very quite expensive, not available widely, so it still have a very limited role. So radio frequency and microwave ablation are the most commonly one which are used. So radio frequency ablation was first done by Bruce Lee in 2002. So it surprisingly it was a laparoscopic ultrasound guided fibroid ablation done by a surgeon. So for most of the time this RFA was done by the surgeons by the laparoscopic guidance. Later on, new system was approved by the FDA in 2008. That was for trans-cervical route. So again, it also requires because cervical dilatation. So most of time again it was also done by the surgeons. So these laparoscopic trans-cervical and then trans-vaginal also came into the picture. Key advantage, offer outpatient treatment, predictable and safe volumetric ablation leading to minimal damage to the myometrium and better fertility preservation. Low intervention rates and faster recovery are the other advantages of this RFA. So if we talk about the evidence, there is a lot of evidence available in the literature, but most of the evidence is because this technique mainly was used by the surgeons while laparoscopic and transcervical. So for each kind of thermal modality ability, we have a evidence. For percutaneous, we don't have that much evidence. So here this fast European trial where which have shown 12 months 65 to 70% volume reduction, significant improvement in symptom severity and quality of life, low intervention rate at 3 and 5. So RFA versus myomectomy, also comparative studies outcomes are available. So randomized comparison has been done and equivalent symptom relief at 12 months. Another Sonata pivotal trial, transcervical, this is mainly for the transcervical, both short-term, long-term, 3 months, 6 months, 12 month data available, and data is favorable and showing durable symptom and control beyond 3 years. We also have a comparative data which is comparing RFA versus UAE versus HIFU, and RFA demonstrates the most significant reduction in fibroid volume. But the problem with the radiofrequency, this is again, I'll just quickly, American Association on Gynecology and a large preoperative meta-analysis, almost every data is in favor of this RFA. But the limitation with the RFA is it is mostly effective for the small sized myomas. For fibroid of more than 75 cc, there has been reported repeat intervention rates are high and lower satisfaction. So then in 2001, Zhang et al. Demonstrated the applicability of ultrasound guided percutaneous microwave ablation for treating these symptomatic adenomyosis. MWA is potentially more efficient for larger fibroids as compared to RFA for the simple region, because it heating rate is very faster. It reaches 60 to 100 in very less time, and because more heat, it penetration is also deeper with the, and also there is less heat sink effect, which is a very common problem in the RFA. So for these regions, this microwave ablation, and for the percutaneous applicability, although RFA also can be done percutaneous. So microwave ablation has emerged another
Last 2
very
minutes.
good treatment. So technical consideration, this requires GA sedation, and for a large tumor, for a technical difficult location, creation of ascites can help you achieve the lesion. Selecting the patient is any patient, any number, any size can be selected depending upon the location by creating these ascites. And another important point is because for most of the large tumor, we are doing large volume of myolysis, so renal protection is important. Sweden clinical trial, long-term data, and everything, meta-analysis, we have all this. So this, the first case which I have just shown you, you can see the complete 1 month post-ablation MR showing complete response. And this second patient, because he was already 48 years, so my aim was just to treat it partially, and you can see around 33% reduction in volume just after the 1 month. This patient, again, you can see the significant amount of volume reduction post-ablation. So for larger tumor, again, this is a very recent paper, which is efficacy, this MWA can be combined with the percutaneous chemical ablation, like absolute alcohol can also be injected simultaneously, which further increases the faster volume resolution in these patients. So this was that lady, and I don't have MR follow-up but symptomatically she improved a lot, and after I came to know 1 year she got married also, but I don't know because she lost to follow-up. Again, MWA versus UAE, similar symptom control, shorter hospital stay with MWA, faster return to work. So this is a comparable result with the UAE as well. A few words on the MR and USG guided HIFU. It is a non-invasive, very good, but the problem with this is positional dependent, posteriorly located fibroid, they don't respond well. But other advantage is this is the only modality which has been applied in patient with an early stage pregnancy with a safe result. So effective uterine reduction has been noted. Repeat session may be required, limited by fibroid location, size, and anatomical barrier, etc. So impact of fertility, RFA, MWA, both are showing encouraging result, but still the data is evolving. We don't have very huge volume of data because of this. Ablation So to conclude, ablation is an effective uterine sparing treatment option for symptomatic fibroid. Both RF and microwave ablation has a strong evidence for symptoms sustained relief. Although fertility data is encouraging with both the microwave as well with the RFA, but still this data is evolving and we need to a larger studies and to conclude safely. Thank you.
Thank you, Dr. Raghunandan. As we are short of time, we'll move on to the next talk and we can have the questions at the end, I guess. So the next topic is on bilateral iliac artery ballooning by Dr. Prashant Sardar.
Good evening, everybody. So, and respected chairpersons and all the colleagues there. So this topic is an important topic, though it's a very simple intervention, but however, this topic carries a lot of pressure from both the gynecological side and the patient maternal side, because this is a very common entity which we miss and actually ends up in the death of the patient, female. So we'll go on the bilateral internal iliac artery balloon placement for placenta accreta. Just a short about placenta accreta. So it's a spectrum of abnormal placentation, placental implantation and firm adherence, which are classified based on the depth of invasion in the uterus. So this is a normal placental attachment to the uterus. In accreta, it enters into the endometrium. In creta, it goes into the myometrium, and percreta crosses the serosa into the urinary bladder or anywhere. So this abnormal placentation, and what is the pathophysiology of this? So this decidua bacillus, that is the lining of the uterus, usually placenta has got a fibrinoid layer normally, and which actually helps for the placenta to come out after delivery. But sometimes this fibrinoid layer is defective, or there is a defect in the biological function of the trophoblast, which cause invasion, like a malignant invasion of the myometrium. So these two things actually results in deeper penetration of the placenta, be it into the myometrium, be it even crossing the serosa. The vessels go across, and these placentas, if not detected in time, when they come out after the surgery, they do not come out completely. They bleed heavily. Heavily means super heavily, like liters of blood, and it's life-threatening. So risk factors. So in a simple word, it is said that the placenta accreta is actually a iatrogenic 20th century disorder. Why? Because of the rampant prevalence of the cesarean sections. The females, the surgeries which they undergo, the closing of the uterine incision, this and all this, along with the avoiding vigorous curettage, and postpartum endometritis, which is not well treated, and these all factors actually causing the epidemic of placenta accreta in some way or the other. So these are the risk factors. Most common that we come across are the placenta previa or LSCS, or sometimes the vigorous multiple curettage. So these are the most common things. Even uterine artery embolization is one of a risk factor. So how do we diagnose it? So patient comes, patient has a history of previous cesarean sections. We always should have it in mind that it can be a placenta accreta or a placental abnormal implantation. So we do a TVS. If it is TVS is more appropriate for a 20th week gestation. So on grayscale, what we see is this is a normal placenta. So there is a retroplacental zone which is hypoechoic, bright, and there is a hypoechoic area. So this is a normal placenta. In placenta accreta or in creta or percreta, this normal line or hypoechoic line is lost, and so there will be abnormal infiltration of the placenta that can be seen. This line is gone. Abnormal vessels are seen, multiple abnormal vessels, and some, if it is percreta, we can see the placenta encroaching into the urinary bladder. So the time of detection, the first is best. Like if we can detect a cesarean scar pregnancy in the first trimester, then we can end up this
placenta accreta on the very first day. Like we can simply go for an intrasec methotrexate, we can reduce it, because this ultimately at caesarean scar pregnancy will ultimately lead into the placenta accreta of some sort. So what we can do is we can simply do a first trimester ultrasound, we see a caesarean scar, reduce it. We just have to instill a methotrexate 6 to 8 weeks. If it is a larger, like 8 weeks or something, even 10 weeks we do it. So we'll have to do a KCL injection into the cardiac and sac methotrexate into the sac after aspiration. So this can end the story at the very beginning and will not lead for the later complications. But many a time patient comes at the later stages of pregnancy, and where we can see this loss of retroplacental sonolucent zone and infiltration of the placenta. So we do a color Doppler imaging. There is hypervascularity, diffuse or focal lacuna flow, or vascular lax and turbulent flow, markedly dilated vessels in the periphery, and abnormal presentation we can find out. 3D Dopplers, power Dopplers can also be used for seeing the nature of presentation. And once we think towards the placenta accreta or abnormal presentation, we can take help of the MRI to confirm the diagnosis. So in MRI, what we see is this is a normal presentation, homogeneous T2 intermediate signal intensities of the placenta, subtle, thin, regularly shaped placental septi, triple layered pattern. So this is a normal presentation. Even with the placenta previa, this is a normal presentation. If there is any abnormality, like there are dark intraplacental bands on T2 weighted images, abnormal disorganized placental vascularity, focal interruption of the myometrial wall or extension through the myometrium with invasion into the serosa, then these cases we have a strong possibility of placental accreta. And if there is any doubt about placental accreta, like we even the findings are equivocal, it can be accreta, not be accreta, still we take it as a accreta, because we don't want accreta diagnosis on the OT table. So we always have to go forward and do a balloon placement, so that even if it doesn't come out to be accreta, patient is safe. So MRI is useful in the parametrial extension also, which is many a time missed on the ultrasound. Like this is a placenta previa, normal, seems normal on the ultrasound, but we can see there is a encroachment into the parametrium. So this has to be taken as a accreta. So these are few of the accreta cases where we can see the placenta which is going deeper into the up to the abdominal wall, and there is a loss of layers, triple layer patterns. So previa with accreta. So here we can see the abnormal presentation up to the abdominal wall. So this is the percreta. So what we do, patient, whenever the patient is planned, it's always patient has to be planned properly. So the gynae team is ready in the OT. What we do is we call the patient in the morning. Patient comes. After all scrubbing and everything, we place in 2 7FR sheets in bilateral femoral arteries, cross from right side towards the left internal iliac artery, and from the left side towards the right internal iliac artery, using JR diagnostic catheters or whichever catheter you are comfortable with. 2 sheaths 7FR. The question is, like, the balloons are usually compliant with the 6FR sheath also. Why we use a 7FR? Because this sheaths have to stay in the place for almost the time when the surgery is to be finished. So they have to be properly flushed. So once we have a balloon catheter also there, the flushing of the sheaths will be difficult, and I don't want any post-operative thrombosis of the femoral arteries, because so we always use one sheath higher. So 7FR sheath we place in the balloons. Usually we use semi-compliant balloons. These are usually either we are using Merrill balloons or Mustang. So these are the semi-compliant balloons that we use. 8 mm, 9 mm, depending on the size. We take small runs, angiographic runs, so that usually most commonly that we use are the 8 mm balloons. 8 4 centimeter or 8 6 centimeter. Usually 8 4 is suffice. So from right femoral puncture, we are entering into the left internal iliac artery, placing a balloon. And from the left, we are crossing over to the right, placing a balloon, not inflating, just place the balloon in place. Then what we'll do is we'll take shots, check shots. We are not using much of contrast, not needed also, but we'll check shots that our placement is all correct. And after that, the most important step is we'll suture the sheath to the skin, balloon catheters to the sheath, and everything has to be rechecked that balloons are in place, because now the patient will be shifted to the OT for the hybrid procedure, So a patient is sent to the OT, the gynae team is always ready with the surgery, and once they have taken out the baby, they will start for the inflation, depending on the situation. If it really comes out to be accreta, we'll start with the inflation of the balloon. So many a times, initial inflation, the nominal pressures are around 8 to 10 mmHg. So we'll always start with the nominal pressures. So there will be two of our assistants which will be there with the surgeons. We'll be inflating the balloons with the inflation device. And both the sheaths have to be regularly flushed. So one of the sheaths we connect to the arterial BP, and that is the importance of using a 7FR sheath. It gives a space even after the balloon. So we inflate with the nominal pressure, and many a times the gynec panic, and so they want more and more inflation. Like they want the balloon to be inflated up to the burst pressure, but we go slowly, and our aim is just to reduce the blood supply to the area. It's not like we cannot completely stop the blood supply. There always will be backflow or somewhere flow, but at least reduce it to a large extent. And once they are done with the surgeries, placentas and all are out, we'll remove the balloon. So,
last 2 minutes.
Yeah. So I already told that like we use a larger sheath so that flushing of the sheaths are all proper. So once the surgeon is done with the surgery, whether they have done a hysterectomy or they have saved the uterus, depends on their chances. So what we do is we deflate the balloons, and after deflation the surgeon checks that there is no abnormal bleeding or leakage in the operative site. Once they are satisfied, then we remove the balloons, keep the sheath, shift the patient to the ICU or ward, wherever they want to shift them, and remove the sheath in the later part. Till that we are doing the flushings. So this is a simple way. This is a balloon from as I told you, right to left, left to right. And these are two cases with the simple balloon placements. So this these we have done maybe around 77 cases till now, and this actually has reduced the death rate to a great extent, with the accreta becoming more and more common, some form of accreta. So blood loss used to be very heavy, 1 to 2 liters and like that. So now the blood loss is hardly sometimes 50 ml, 100 ml is reduced grossly. So even the placenta previa, many a times surgeon wants if we can place in a balloon so that they are on the safer side. So, being a very minimally invasive procedure, it always carries a very low risk, hardly any complications, and patient can safeguard a big life-threatening situation. So, many studies have been there. Now, question is whether we can simply place an aortic balloon and prevent the uses of internal iliac balloons. But yeah, we are using straightforward doing the internal iliac ballooning, because placing a large balloon in the aorta, and still there will be the backflow from the other arteries, so the effectiveness may be reduced. So we go for it. And so simple in one word, accreta is a deadly disease. Like it should be delayed referrals, delayed cesareans, delayed decision of hysterectomy. So accreta, if any doubt, go for an internal iliac balloon placement rather than having some massacre there at the table. Thank you.
Thank you, Dr. Prasant, for a brief and comprehensive overview of the topic. One point I want to just curious regarding use of balloon. So you are using PTA balloon in all cases. What about occlusion balloons? Because at our centers we use Swan-Ganj catheters for this purpose, and the result is good.
Yeah, so we are using, in all our cases, either we are using the Mustang balloons or say Merrill balloons. So those semi-compliant balloons, they work very well, and we are happy with the cases. Like very rarely we saw any vessel injury. So we can use any type of balloon, and every balloon is indicated, but our experience goes mostly with these type of balloons. So these balloons, even they have like Mustang balloons, so they have like higher burst pressures. So we can increase the burst.
Here we don't need that thing actually.
What?
Here we don't need high pressure actually.
We don't need it. High pressure means Mustang are semi-compliant. They are not a high pressure balloons, high profile balloons, but they can not like others, the rated burst pressure is less. So more in the Mustang balloons and Merrill balloons. So any PTA balloons are good enough and reduces the blood flow to a lot.
My point is occlusion balloons are also good enough to be used in such cases. They are safer also. Yeah, that is.
We can use, no issues with that.
Thank you.
Thank you.
Next speaker will speak on single center experience of pain management in uterine fibroid embolization, and he is Dr. Dheeraj Shyam.
A very good evening, everyone. Today I'm going to share my experience in our institution, how we started out with the fibroid program and how we went about tackling it. So we started a fibroid embolization program. We did a good number of procedures starting from scratch. We did around 130, 140 procedures in the last 2 years. And I think when we started out, it was, finding it difficult to convince the patients. What we observed whenever we're trying to convince the patients for UFE procedures, when you try to say it's a small procedure, you just need a day of hospitalization. I think with the upskilling of surgeons, they do robotic hysterectomies in a day. The patient goes back home, and the next day they do laparoscopic hysterectomies. The patient goes back home in 1 or 2 days. So the ways to convince the patients slightly changed with when I started talking to patients more. But whenever the patients come to us, they would already met 1 or 2 gynecologists before, and the biggest scare they put in their mind is about the pain during the fibroid embolization procedure. So among the patients who came to us, we did a small study, and the apprehensions of the patients was mostly about the pain involved during and after the procedure. In about 92% of the patients, they had great concerns regarding the pain. The fertility concerns, the problems about early menopause, but not that much when compared to the pain during the procedure. So that's when I realized the surgeons, the gynecologists, they are not the enemy. The enemy is the pain. So which is the most feared among all patients, and that is where we had to control. If you win pain among these patients, you tend to do more number of cases, and the patient compliance becomes much better. So just to know a little bit of background upon why the pain is so much in UFE procedures is because of the ischemia of the fibroid tissue and the inflammatory response which happens once you get to the embolization of this. It causes tissue ischemia, necrosis, an inflammatory cascade reaction develops with more uterine contractions, myometal ischemia contributing to most of this. How is the typical onset of pain? It starts about 2 hours after the procedure. That's when the patient starts complaining about, the maximum intensity of pains. And it tends to extend over, towards the evening and towards the night. And also there is a sort of dull aching kind of pain which still persists about 2 to 7 days after the procedure, which is mostly because of the post-embolization syndrome with a vague kind of fever, pain, lower abdominal pains. Most of the patients get back to their daily activities within 10 to 14 days. When I say daily activities, they start going back to their offices and everything. But then, sometimes the post-embolization syndrome can even persist for about 2 to 3 weeks also. So this is our institute protocol when we are trying to handle a patient for fibroid embolization. So when he came up, there's a good counseling which happens, during the time of OPD. And then they're sent to the pre-anesthetic check where we come up with a solution for what kind of anesthesia. We give usually options for, sedation with PCA or with an epidural anesthesia. So, and then admission happens with relevant blood investigations. And there are a few pre-medications involved with antibiotics. There are some analgesics which we give, like Jonax suppositories, prior to the procedure itself. During the procedure, we manage with sedation plus PCA or with epidural itself. And almost in most of the procedures, I always try to finish the procedure with a closure device, either perclose. And then usually post the procedure, we always try to drain the bladder immediately once after the procedure is done. And then again, give a good cover of antibiotics, and then a couple of antiemetics and a couple of painkillers as well. So epidural top-up if required, we continue the next day of the procedure, we have the epidural catheter in situ, and then send home with some standard discharge medications. So why is pre-procedural counseling is important? When you're trying to counsel the patients, I think they read up on Google, they read up everywhere on AI, they know that it's a very painful procedure. So it's a walking on thin ice when you're trying to explain to the patient that there is going to be pain, but we are going to manage adequate. It's not going to be the worst pain of your life. We are here, we are managing this very well. So it's a thin line we have to walk when you're trying to convince the patients. Coming to the access involved, in our cases, whenever we try to do with the radial artery access, the patients are more compliant. They tend to be ambulatory very quickly, and the pain due to compression, the discomfort due to compression is avoided with radial artery access. Femoral access, it is easier. The advantage being, one, you can finish the procedure much easily with a Voltman's loop. You can finish both procedures with the same access, and within 1.5 hours, the patient is out. But again, without a closure device, with femoral access, the patient has to be immobilized for the next 6 to 8 hours, compression given again for the next 15-20 minutes. So these are some discomforts which are being described with the patient. So that's why we switch to closure devices for almost all our patients. They can be ambulated with closure devices within 1 to 2 hours after the procedure. So this gave much more comfort to the patient, even though if they're not able to walk, the idea that they can, get out of the bed, they can use the restroom whenever they're uncomfortable, it gave more confidence with the patient. So compared to the pain impact, again, radial access is the best access when you're trying to avoid pain, but femoral artery access with closure devices provided great comfort as well. Coming to the procedural anesthesia involved, right now what we are trying to follow is with an epidural, combined epidural and spinal technique. What we do is the patient is given about 0.5% hyperbaric bupivacaine, which usually lasts for about 3 to 4 hours. It takes excellent control of the pain. And about 1 milligram morphine is given with an epidural catheter. The pain usually is taken care for the next 24 hours with this. And then, if required, there can also be a top-up given after 24 hours. That usually is managed with either bupivacaine infusion or another dose of morphine itself. If you're trying to give it sedation and PCA, we usually manage with midazolam, fentanyl, and with additional drugs such as ketamine and dexmedetomidine. But most of the patients, if we do under sedation, we always keep them on patient-controlled analgesia. With patient-controlled analgesia, I think most of them know there's a 20-20-20 rule. For the dosage, you start with the basal infusion of 20 micrograms and the bolus dose of 20 micrograms with a lockout interval of 20 minutes. The only adverse effect which we noticed mostly with PCA was vomiting. There used to be severe vomiting involved whenever you were trying to give, during the intra-procedural, you give some medication post-procedure along with PCA. So many opioids involved. The major side effect used to be with vomiting and nausea. Discharge analgesia, we had a set of drugs. I mean, most of the institutes follow the same practices. They give a set of NSAIDs, common antibiotics. But something different which we did was we started, we spoke to the pain medication, pain physicians, and we came to know that, along with the pain aspect involved, the patient had a very restless day after the procedure. They didn't have proper adequate sleep that day. So once we spoke to the pain physician, we started a pregabalin 75 milligram, on the day of the procedure at around 7-8 p.m. in the night. And this was continued for about 5 days, every day a tablet. The sleep quality improved, the pain response improved, and there was a significant difference when we spoke to the patient post our procedures. And to avoid constipation, which is the most common complication or side effect with epidural, we always send the patient with some sort of stool softeners. These are other pain management options which are available. You have the SHNB blocks. You have intraarterial Xylocard, which can also be used. Some centers also use steroids as a regular one. But these are options available, but we don't really use this in our institute. Some adjunct therapy, some patients try to use, for abdominal cramping, hot water bottles. They give some comfort to them, and which is, left out to the patient. Sometimes it helps, sometimes it's not, but it's mostly works with the patient mentality. So we tried to, have 2 cohorts, one with the patient with PCA and one with the patient with epidural. And we had a questionnaire prepared for them when they came up for follow-up about 1 week and again 1 month after the procedure. So the assessment was done on, a number of questions asked due Google Forms regarding the overall hospital stay, the pain, and the post-procedure evaluation. So this was the cohort which included, the predominant age group category was around 35 to 45 age group patients. And the first question we asked was any previous interaction with, prior anesthesia with either epidural or PCA. So patients who had some experience always tend to handle pain better. They handle procedures better. Even epidural or spinal, they handle much better. And patients who had sedation before or during LSCS procedures prior, even they had what to expect during the procedure. The overall experience during PCA, when we asked, most of the patients were comfortable with epidural. I think some patients had reservations about putting a needle in the epidural bag, but most of them were comfortable. We asked for a visual analog scale, how do you rate the pain of the procedure? We saw that the patients with PCA plus sedation, they had more incidences of very severe and severe pain post the procedure, which much better pain management with epidural group. And pain embolizations with, we usually have a standard of 500 to 700 embolization material size, but sometimes when to achieve necrosis, we give one vial of 300 to 500. Patients with these particles tend to have more pain than the rest of them. And this was an interesting question we asked to most of the patients, that how do you compare it with previous pain? When we compared it to labor pain, dysmenorrhea, most of them with the epidural group, they could relate it to the dysmenorrhea group, but patients with PCA group, they told that some patients have very severe pain as much as the labor pain itself. And always a closure device was placed. And did the counseling help? Definitely counseling helped. With the epidural group, they told that the patient pain was almost the same or less than expected as compared to the counseling done during the procedure. So any side effects? The most common side effect with epidural was constipation. With PCA was severe intractable nausea and vomiting, and some patients were observed. Immobilization, again, due to closure device placement, most of the patients were mobilized very quickly within 3 to 4 hours after the procedure. So again, this helped a lot in bringing down the pain levels in the patient. So this is an important question we asked: would you recommend embolization to your friends and other family members? The epidural group, most of them agreed that they had a good time, they had a good stay in the hospital, they recommend the procedure, and almost 95% compiled with that. So this is the last one, just to compare with epidural analgesia and PCA in a hospital. We saw that patient satisfaction, the willingness to recommend PCA, and the overall pain control was much better with PCA, was much better with epidural compared to the PCA group. So takeaway message with this is, there is no single solution fits all for this uterine fibroid embolization procedure. Each institute has to come up with its own protocol depending upon what your anesthetists are comfortable with. So this is what we planned, and this is how it is working for us. And each hospital can have a different protocol which works better for them. So tailored strategies are required for all the patients. And most of the things, along with what helped was, when a patient tells 1 week or on the day of the procedure, if it's paining, we show absolutely no judgment in this. As doctors, and especially as men, who are we to judge when a patient complains of pain? So this are some of the points which I wanted to share it. Thank you for your time.
One question I have, like PVA versus embosphere, which one you use and why?
Sir, when you're viewing PVA particles, most of the patients had PVA particles, but compared to embo, when I was trying to do with embospheres, I try to upsize the embospheres particles by the next size. For example, if you're doing with 500, 700 PVA particles, contour is what we commonly use. But then if you have to use embosphere, even from the industry standard, they even recommended that, use 700 to 900 embospheres for the same procedures.
I have a question. One more point just. Just you have shown, even with spinal or epidural anesthesia, you have to use that IV fentanyl in how many cases? What percentage?
IV fentanyl, I mean, with the PCA or?
With PCA.
Sir, with all the patients on sedation, we give PCA for sure, sir.
Those who undergo a procedure under spinal or epidural?
No, sir. Patients who undergo only epidural plus spinal, they are never given PCA or IV fentanyl, sir. We only manage with epidural catheter, that's it.
Only with epidural?
Only with epidural catheter, sir. If they have still pain, usually the 1 milligram morphine, it lasts for 24 hours, sir. Before that, nothing is given. Post 24 hours, if the patient is still having pain, they can give other drugs, and even some top-up of morphine can be given after 24 hours, sir.
What is your experience with using this transdermal fentanyl patches?
Fentanyl patches we have used with, along with sedation. So when we are sending home, we have sent it out with, but overdoing with PCA plus fentanyl, I think this leads to more vomiting. If we are not giving PCA, we have tried with fentanyl patches, along with,
PCA you can use We just use this NSAIDs, fentanyl patch, and tramadol.
Yes, sir. We have tried Dynapar, we have used
Most of the
tramadol.
cases we manage with this. So all at all places the facility of spinal in periphery might not be available with all doctors.
True, sir.
So even with limited facilities, we can manage the pain.
Just to add to this one, many times if you do a plexus block, hypogastric, you can avoid most of this epidural.
Yes, sir.
So different ways to Bellacat, whatever suits your practice.
Can I have a small question? So it's here. So if you're doing a spinal epidural, are you doing a procedure under heparin or you don't give heparin?
Usually,
do you do heparin during a fibroid ablation or you don't heparinize the patient?
Routinely, I don't give heparin if it's going to finish, but with radial, I think we give a bit of heparin.
Then if we are doing by radial and if a spinal epidural is planned, so how do you manage the heparin part? Usually we don't give heparin
when we're planning epidural.
So if all patients have spinal epidural, only femoral, so that's a way to go, or what is your suggestions on that?
We have used heparin, sir. We've used about 2000 heparin during the procedure, and it has been done safely. I know there's a chance of epidural bleeding which happens with
because it's a benign procedure, and if the epidural hematoma happens, it's a the chance, the theoretical risk is there, so I just want to share.
There is a theoretical risk, sir, but not commonly seen.
Even the anesthetist are concerned. The anesthetists don't agree with it. They will never agree, so. Even then.
Once the catheter is in situ, then when we can give heparin, that shouldn't be a problem.
But most of the anesthetists is very. When the catheter is in situ, they don't want the heparin. That is my experience at least. So that is the simplest thing is to do under femoral so that we can avoid heparin. I think that was my thought process.
Most of the cases were done under femoral only, sir.
I think because in radial, without doing heparin,
it takes definitely longer than the femoral routes.
And
usually we give epidural on the table only. In the cath lab, it takes about 15-20 minutes for them to prep and do, and prior to the procedure we can start off.
Thank you. Nice experience. Thank you.
Thank you, everyone.
So we'll move on to the next one. Dr. Reddy, he'll be speaking on consensus guidelines for UFE and adenomyosis.
Good afternoon, everyone. I am Dr. Reddy Prasad. I chair Interventional Radiology Department for the Manipal Group of Hospitals. There were drums going off next door. That's an indication that we don't have much time. We'll see if we can do our best to get through the talks. This is a very important topic. We're trying to write up national consensus guidelines on fibroids and adenomyosis. This talk over the next 10 minutes will help us lay the foundation for the paper, and then we will have a panel discussion over the next 20 minutes after my talk. I will not repeat what other presenters have already done. It's been, fibroid embolization unfortunately is still felt by a lot of general physicians and the patients to be still a new procedure. So there has been experience for over 3 decades. A 30-year-old is old, as in, it's an old procedure. Well-established evidence is there. The symptoms are menorrhagia, pressure symptoms and pain and infertility. All these put together reduce the quality of life. Fibroids are very, very common. Imaging, gynecologists love their transvaginal ultrasound. Radiologists love MRI. But we have to write about all the imaging modalities on the guidelines paper. But MRI is considered to be the standard of care from imaging point of view. FIGO classification forms the basis of treatment for both the gynecologists and interventional radiologists. There are other classifications as well from European classification and all that, but FIGO is the most widely followed. Management, once the patient comes to the gynecologist, they see the patient and if they are suitable for their treatments, they might go ahead. However, in an ideal scenario, the patient should be given the option of speaking to an interventional radiologist. Then we put forward both the treatments. That's a comprehensive management by both the gynecologist and interventional radiologist. That is also going to be forming the part of guidelines. Now, we have a variety of options. During the panel discussion, again, we will be discussing what are the treatment options for fibroids and adenomyosis. A typical patient, because this is going to be part of the guidelines, I'm just taking you through the investigations and procedure. However, other things like pain management have been already dealt with. The procedure after informed consent is performed in the cath lab, most commonly through a femoral access and more commonly through a unilateral femoral access than bilateral. However, some places do that. Very simple kit that is required, a 5 French or a 6 French sheath, a cobra catheter or a dedicated uterine artery catheter if one would like, and a microcatheter and your particles. Most commonly used are 500 to 700 micron size particles, and then you upsize. However, there can be variations in the usage. This is the typical anatomy. Even a medical student, when we show, once seen, never forgotten, that long tortuous artery is the uterine artery. I'm not going to take you through the procedure because we are short of time, but I'm going to talk to you more about the evidence. However, end point of embolization is very important. That also we are going to define in the guidelines. We are looking for, there are at least 3 different definitions, but we are looking for absolute stasis. At least in my practice, absolute stasis, no forward flow in the uterine artery. Post-procedure care has already been dealt with from pain management point of view, but there is a whole host of things which is all symptomatic management. In my practice, I don't routinely use a urinary catheter. Complications, these are all listed. You can call them minor complications, major complications, SIR classification, or adverse events. One of the things that could be a surprise to the patient is fibroid expulsion. Premature menopause is not that common because our techniques have gotten better and we are very carefully doing. We quote about 1% in a young patient, 1% risk of premature menopause as an ovarian failure. And if someone is over 45, it's in the region of about 5%. And then we look for fibroid infarction in a 6-month follow-up MRI scan. I'll skip that. Indications, at least in the, let us say in UK, the first one is enough, symptomatic fibroids. If someone has symptomatic fibroids, you can go ahead with embolization. The lay of land is in India is quite different. So if you have to be a good friend of a gynecologist, these are all the things you have to be presenting to them in their conferences to get your patients and have a good friendly rapport with the gynecologist. Who is an ideal patient? Someone who has symptomatic fibroids, completed family, who wishes to retain uterus and wants a minimally invasive procedure. Why isn't UAE yet popular in India? It is probably a popular procedure, but why hasn't it really picked up? This picture is relevant when I present in the gynae conferences. It's just me this side and gynecologist that side. But you can see the proportion of IR versus gynae. Now, this is the most important thing from guidelines point of view. Are we doing a evidence-based procedure? That's the most important question that's going to form for the guidelines. See, how we do it, technique, and is it unilateral puncture, bilateral puncture, all those things are part of the technique. Whereas embolic particles, what do you use, and size of particles, all these things are going to be from evidence. Do we have, this is evidence-based pyramid, do we have enough evidence? Uterine fibroid embolization research has been done to dust. We have level 1 evidence saying that it is a safe and effective procedure and an excellent alternative, a minimally invasive alternative to myomectomy certainly. These are all the outcome measures. I'm not going to go into too much covered. UK-based Cochrane review has been published initially in 2018 and more recently in 22 it has been updated. Systematic review and meta-analysis have been done by the EMI group from Netherlands. Several trials have happened over the last 3 decades, Pinto, EMI, REST, MARA, FUMI, and most recent is FEMI trial. REST trial happened in Glasgow, where my professor was the lead investigator, John Moss. Registries have been there, UK and USA fibroid registries, and a cohort study which is hopeful. This is the trial summary. It's a busy slide, but we don't have time to go through all that. The most recent trial is FEMI trial. That will answer the question, some of the questions I suppose during the panel discussion. Why FEMI trial? We did not have enough data for patients who wanted to conceive, which means in nullipara we did not have enough information. 127 versus 127 were randomized, and this slide the gynecologist will not like it because embolization group had more pregnancies and more live births. But does that mean embolization is better in FEMI trial? We have to take it with a pinch of salt. This is the only trial that shows a slightly better, but the overall data still says that myomectomy should be still the first option in a nullipara. Then we have a lot of quality improvement guidelines from CERSI with regard to UAE, and our FOGC also has published their own guidelines. There are guidelines together between the Royal College of Obstetricians and Royal College of Radiologists UK, and there is guidance from American OBG. What have I contributed towards the evidence? To my knowledge, this is the only book, Radiological Interventions in OBG. We have summarized the clinical results of fibroid embolization. All the trials and registries we have summarized in that. In Granger and Allison, in Granger and Allison Diagnostic Textbook of Radiology, we have written a book chapter on genitourinary urinary interventions in which we have touched upon the fibroid embolization. This was my research project when I was in Glasgow, comparing different types of embolic materials, gel foam versus embospheres. What are the real advantages of embolization compared to a myomectomy? It's pinhole versus keyhole or open. There's no scar. There's no blood loss apart from the 2 drops initially. Early recovery, they get back to work soon, and much lesser risk of infection. These things we'll be covering during the panel discussion. And the way forward, it has to be comprehensive care between the gynecologists and interventional radiologists, and maybe the general physicians who are also taking care of the patients. It has to be teamwork. We have to give both the options or all the options to the patient and allow the patient to choose. By the time the patient gets out of your clinic, that's or a decision. Inadequate information is unfortunate. As you all know, July is the Fibroid Awareness Month, and we do our best to save the uterus. And with saving the uterus, uterine artery embolization is one of the procedures along with myomectomy. So as I mentioned, the way forward is going to be comprehensive fibroid clinics along with your gynecologists. Thank you. I'll stop there, and then next we'll move on to the panel discussion.
Time is up.
I think your treatment gamut is not like that. Myomectomy and UAE, I just saw in my
Mike.
Fibroid ablation is also equally open and quite well published. So you should actually include that as well. UAE around
Thank you, Raghunandan.
Any other questions from the audience? Not, we'll close the session and move on to the next one. Yeah. Panel discussion. I'll request Reddy to take over for the next session then.
Oh, so for panel discussion, Dr. Reddy Prasad Yadav sir will be the moderator, and the panelists I'd like to call Dr. Bhavna Dev, Dr. Mala Raj, Dr. Priya Jagya, Dr. Santosh Babu, Dr. Akash Bansal. Sorry. Dr. Shura Roy Chaudhary, Dr. Korabi Zade, and Dr. Divya Sharana. Thank you, previous session chairpersons, Dr. Anil sir, Dr. Santosh sir, Dr. Dev Prakash, and Dr. Vikas sir.
we will get started without any delay. I'm sorry I put the wrong picture. I said there were not enough interventional radiologists, so I have to reverse the image. I have to reverse the image. There are 2 gynecologists on the panel, and 5 interventional radiologists here. So welcome to the panel. So this discussion is going to be on case-based discussion. See, we are never going to be completely be able to discuss different scenarios. I'm taking this opportunity to discuss some outliers, maybe 1 or 2 cases that are straightforward because we have the advantage of having gynecologists here. In the interest of time, we'll get started and maybe see if we have any questions from the floor as well later. So first is a 35-year-old lady with menorrhagia, P2L2, full-term normal vaginal deliveries. Last childbirth was 8 years ago and hemoglobin of 10.2. So she's symptomatic and has basically symptomatic fibroids. I'll start off with Dr. Mala Raj. How would you assess this patient? I have to say all the information might not be there on every slide, but if you had any clinical question, I'll be able to answer that. And they have had transvaginal ultrasound and everything, but for all the cases, I have put in the MRIs. So what would be your treatment protocol to start off with, Dr. Mala?
Yeah, so this particular lady, 31-year-old lady with menorrhagia, first I need to rule out the cause for menorrhagia, for which I would go by the algorithm of palm coin, wherein I have to find out whether there is any organic lesions which is causing the menorrhagia or any other factors like endocrines and other bleeding disorders. So apart from pertaining to fibroid, in fact, for this particular, conference, what I feel is like I have to do a proper 3D ultrasound for this patient to find out whether there is any kind of organic lesions like fibroid or adenomyosis, after ruling out all other factors which I mentioned, which are pertaining to the palm coin. So if it is fibroid or adenomyosis, then based on that, I would decide my plan of management.
I think one of the messages here is we should always work very closely with a gynecologist. Their thought process clinically is going to be definitely different. See, Dr. Mala mentioned, is there some hormonal issue? Is there some other thyroid issue or whatever that could be causing menorrhagia? I did not mention, we have the MRI there, which shows that this patient has multiple fibroids, mostly intramural, but that whatever you mentioned, the initial evaluation is going to be extremely useful. Hence, one of the reasons of comprehensive assessment and evaluation. And in a fibroid clinic, it should be offered definitely by gynecologists. I would never want to manage these patients alone. So this patient, the MRI shows a few intramural fibroids. The subserosal ones are really small at the top, the subserosal one. And it's a pretty straightforward anatomy. So what would be your treatment option?
Yeah, so obviously this patient, I would prefer to do a laparoscopic myomectomy because she has a very clear cut intramural and the subserosal fibroids, and I want complete clearance. So I would definitely, and being a laparoscopic surgeon, so I will definitely go in only for lap myomectomy.
We know you are a very popular and expert laparoscopic surgeon, but what if I said we can have 100% clearance with embolization?
But with embolization, I think the chance of recurrence is also going to be still there.
So I'll share my thoughts because this is just a debate and this is just a discussion. One of the advantages of embolization is that even the peanut size, the smallest of the fibroids, is going to infarct. There are no wide studies, there are no hard fast research about recurrence of fibroids post myomectomy versus embolization, but it is intuitive to say that you will infarct all the fibroids post embolization, so it's equally effective from recurrence point of view. Shura has something to add.
Would strongly contradict that statement both by yourself and Mala. There is actually some evidence coming out now. I can quote you some papers But most importantly, there is some very good data coming out of Europe about the recurrence rate after myomectomy. The recurrence rate about open versus laparoscopic myomectomy, there is a randomized trial. And if you look at both the recurrence rate at 5 years, one is 47% and one is 56%. I can quote you my own data, 10-year data of, over 200 fibroid embolization. My recurrence rate at 10 years is 7.1%. Just to say that this is not a one-off, like you said, it's a very popular misconception that fibroid embolization does not infarct the fibroid completely. A well-performed fibroid embolization, of course, a well-performed fibroid embolization will, on an average, infarct 90%, 95% plus. Our own data is 97%. So to be honest, both of those statements are incorrect. That there is a higher chance of recurrence, no. There is incomplete infarction, no. And there is actually a paper now that talks about higher recurrence at myomectomy than uterine artery embolization. Now, of course, there is no randomized data to suggest
So I
that.
think I'll have to stop you there. I mentioned there is no randomization between the two groups, so there is no contradiction. Okay. So I think for this particular case, you will not go wrong whether you did myomectomy or whether you did embolization. I think we'll have to move on to the next case. Yeah. So all I'm trying to say is a straightforward, simple case that is suitable for both procedures. Which one would you go for? Gynecologist would go for myomectomy. Interventional radiologist will offer embolization because there is no contraindication. Next patient, this lady, fast forward the same patient 8 years later, there is recurrence of fibroids. Patient has had a previous myomectomy. She had gone to Dr. Malaraj and she did her myomectomy. Now there is recurrence of fibroids. You can't help it. As long as there are female hormones going through the blood, it will happen. Recurrence of fibroids is going to happen, and that is what we should counsel the patient during the first procedure, whatever the procedure be. So now, Dr. Divya, a patient with previous myomectomy, what should we offer now? So MRI has confirmed multiple fibroids.
Even I will go with repeat myomectomy surgery to relieve the pressure symptoms immediately, sir.
So it's a beauty to work with expert gynecologists, because someone who is really good at myomectomy, they can shell out as many fibroids as possible. They can. That's the confidence level. Of course, I agree that it is going to take time for the pressure symptoms to improve. Menorrhagia will improve sooner with regard to embolization. Again, this case, based on the skill level, gynecologists will go for repeat myomectomy. They're not bothered about the scar, adhesions, all those things. Second surgery, you might still be willing to go. But would you go open or laparoscopic? You're comfortable going laparoscopic?
Both laparoscopic or robotic, both is fine.
Okay, sure. But if I ask the same question to interventional radiologists, they'll say we'll all do embolization. That's okay. That's absolutely fine, and we'll move on to the next case. Yeah.
So this particular case, in fact, just to add on, apart from doing a laparoscopic myomectomy, I will also like to give her some other support to prevent recurrence. Now we know that she has a tendency to recur. I will put her on a Mirena, intrauterine levonorgestrel device, so that the chance of recurrence would be less for her. Because she is almost 43 now, so another few years of menopause is going to help over.
Sorry, ready? 1 second.
No, Raghunandan, we'll have to continue. Later questions, only to the panel for now. Yeah. So, sorry, anything?
Yeah, that's it.
Okay, so we'll move on. I'm sorry, we will not take questions from the floor right now. We'll just get the panel's expert opinion. So, I think that's very important and very useful. Mirena, never forget. Even post-embolization, someone has some bleed. Let us say you chose someone with a little bit more than 50% of submucosal extension, and the patient still bleeds. Then you can send to the gynecologist. Mirena will still help.
My only concern in such embolization, apart from all other things, ovarian insufficiency and stuff. So here, when you are doing a myomectomy, we are having a tissue biopsy. How about inadvertently embolizing a leiomyosarcoma?
Yeah, that's a beautiful point. This will come up every time. We cannot rule out a leiomyosarcoma in a fibroid, is what you say, is what the gynecologists say. I'm not contesting that, but the larger the fibroid, there is a risk of that. But the thing is, you started the myomectomy. I'm being a friend and friendly discussion, that's all. You started the myomectomy that this is benign disease. You only know that leiomyosarcoma is after the histopathology. Whereas if it was a malignancy, yours would have been a radical treatment. You would look for the sentinel lymph nodes, you would look for other features of malignancy. However, you started off as benign, we started off as benign. And during follow-up only we will know. But having said that, the treatment algorithm for benign disease should be as benign disease. That's what we should do. Yeah? Yeah, please.
So, valid point about myomectomy. So, LDH.
Yeah, that's the point.
The amount of necrosis, diffusion weighted imaging, and area of restriction. Should I go? So LDH, diffusion weighted imaging, degree of T2 necrosis should warn you towards a lyo. A. B is post embolization. Follow up is very important. If you are suspicious and there is recurrence of growth earlier than what you would anticipate, please do consider hysterectomy, myomectomy, send for appropriate thing. Lastly, the incidence is less, very less, very, very less, 1 in 500. So therefore, all of this should be taken into context. If you have a suspicious MRI and you just blindly embolize and forget that patient, that is wrong.
I don't think we are going into the point of suspicious MRIs at all. We are only talking about, so the way we are building up is only benign. You know, on MRI, once you see that it is suspicious features, obviously you're not going to offer embolization. No, very valid point. Very valid point. I'll
So
come back
even
to the
same way,
gynecologist.
even we are not going to do myomectomy, we are going to do a radical.
Completely agreed. I'm just going to come back to the gynecologist because you mentioned LDH, sensitivity, specificity. Is there anything that markers, I had heard of some other blood tests, any markers that you would use to see if there could be a leiomyosarcoma that could be harbored in a large fibroid?
Yeah, only a LDH isoenzyme 3. That is one thing we have to look for. But then most of the centers do not have LDH isoenzyme 3 assay and analysis also. So it takes a lot of time. And of course, CA125 also to some extent we can rule out. And the most important thing is even endometrial biopsy we have to definitely do it for all these patients before we take them up.
That's one of the points that's going to come up. That's very useful. Thank you. So moving on to the next scenario, young patient, 26-year-old, has no symptoms at all, has a fibroid, 2 fibroids, nullipara, had recurrent abortions, but regular menstrual cycles, trying to conceive for the last 3 years. These are the appearances. This is a post-contrast scan which shows 2 fibroids. One is a large intramural and then there is one subserosal superiorly. I think the question to, Dr. Priya, what do you think we should do?
See, this subserosal one may not respond so well to the embolization. So I don't think my gynae would send this patient to me. I would love to do this for the other fibroid, but yes, and this is a large one again. I think this is a better off with her. But thing is, she's a nullipara.
Yeah.
She would like to preserve her uterus. So all those things again have to be kept in mind. So probably surgical would be a better option in this patient.
I'll pick Dr. Shouro's brain here, who would be happy to summarize the FEMI trial for us. This is the reason for FEMI trial. Nullipara has not had kids, obviously. What do we do?
So to me, in my practice, this is clear cut. This is not an embolization candidate because very large, asymptomatic, possibly bulk, nulliparous. I am not stopping bleeding here. So to me, and the surgeon is going to remove one large fibroid and there's going to be a massive change in the patient's symptoms. Whereas we embolize the amount of shrinkage 60% at 12 months is not going to make a big deal to this patient. So to me, this is 100 times myomectomy, this particular patient. There's a very important point about FEMI trial that you raise, that what people don't read between the lines. FEMI trial only randomized patients that were equivocal. Patients who were clear-cut myomectomy, let's say this case, or 8 fibroids in a 35-year or 40-year-old with 2 kids, clear embolization. FEMI trial did not randomize those. FEMI trial only randomized the equivocal cases. So to me, this is sort of not FEMI. This will go to myomectomy in most places.
So we have the answer there, and both the
Very
gynecologists.
clear-cut case for myomectomy. I don't think
completely
so.
agree.
There's any other way out.
I completely agree. So,
What did she say?
Clear-cut case for myomectomy, sir. There's no other way out for this particular laparoscopic myomectomy.
Yeah, we are all in agreement. I think the message that we are driving here is be careful with nullipara. Discuss extensively and get your gynecologist's thoughts. And we should not necessarily be offering uterine artery embolization as the first option. I would offer only if the gynecologist said, this patient I cannot do myomectomy for whatever reason. There might be indications. Okay, then I would offer embolization. There is a role in nullipara. Moving
Going
on to the
compromise on the ovarian reserve, though.
Madam, I have to qualify that. The incidence of the incidence of ovarian failure post embolization is extremely, extremely, extremely rare. You can forget it. Extremely. I was going to say I'm being honest, but I'm being led by the evidence base. So we don't have to worry about it.
So there is a Brand Lucas paper that talks about no different age match control.
Yeah.
No difference.
AMH levels, all those things, so there is no concern about ovarian failure at all.
So does it matter with the emboli that you use for?
So I think the important
most
point.
of the interventional radiologists, they are taking into account this vascular supply from the ovaries also, and we make sure that the ovarian is left intact. So that is one of the your interventional radiologist has also to be well trained to so with newer techniques and more advanced knowledge, and if you are well aware of all this complication, you can avoid. So the ovarian failure is no longer an issue.
Of course, there are some concerns in nullipara. What are the concerns? Endometrial atrophy, higher incidence of recurrent abortions, embryo might not implant if there is endometrial atrophy, premature
Placental disorders,
abnormal placentation, and premature IUGR, premature delivery are all quoted. Those are more higher concerns than just, in addition to ovarian failure. So we'll move on. A 38-year-old lady, symptomatic fibroids, P2L2, has a large fibroid uterus, alarmingly large, but wants to conserve the uterus. This is well coming to the xiphisternum. That question is, how big is really big for embolization? I would like to answer, I would like to ask Dr. Kaurabi, where do we stop?
Look, so we all know that there is no clear data on very large fibroids. Like all the papers and all the trials are going up to 10, 12. So eyeballing this picture, it is around 14, 15 or maybe 16 centimeter. Still, now this patient has completed her family and didn't wanted to no hysterectomy, right? So still we can give an offer for embolization, but with pinch of salt, because such a big fibroid, we all know that there will be severe post-operative ischemic pain. And actually we have done this kind of cases with due counseling, and SOS may require surgical removal. With all these things in mind, we can definitely offer treatment, and we ourselves have a data of around 10 patients with more than 15 centimeter fibroid. We have undergone fibroid embolization and 6-month follow-up with good shrinkage, maybe more than 50%. And this is basically for symptomatic relief rather than fibroid to disappear completely.
Dr. Mala, what are your thoughts?
Yeah, no way anything else apart from laparoscopic myomectomy, because we can comfortably remove these fibroids. If you are not very proficient in doing, you can at least shrink the fibroids by giving leupride analogs for a couple of months and then proceed. But ideally, in such situations, I will proceed with lap myomectomy.
Okay, yeah, sure. Dr. Divya would agree with that. Yeah. Okay, thank you. So large fibroids, be careful. You have to, I think 10 plus, 12, 10 to 12, then you are spreading your limits. We have to obviously discuss with the gynecologists, unless, let us say, there is a contraindication for surgery. unless there are multiple abdominal surgeries or pelvic surgeries, patient has high BMI, anesthesia risk, etc., etc., etc. If gynecologist says no, even then, very large fibroids, I would be concerned about significant post-embolization syndrome, DVT. What is mentioned in the literature is one leads to the other, and they will have problem, increased sepsis. So we have to be careful there. One question: would you consider the third point, which is role of preoperative embolization in a patient like this? Would you send the patient for pre-op embolization just that morning? Because the amount of myomectomy you have to do in that large fibroid uterus, there will be a lot of blood loss. We can help you here. We do pre-op embolization in the morning, and can you do laparoscopic myomectomy later under the same anesthesia?
We are doing that, sir. In our hospital, we are doing in same sitting. Patient will be embolized and then shifted to OT. In our OT, we proceed with the myomectomies. It has given us very late blood loss.
Okay, can I add something? Can I add something?
I'll probably take 2 more minutes to cover because this is important. Yeah.
Yeah, just for hemostasis, I don't think so. I will proceed with embolization because during the procedure, there are lots of other measures by which we can maintain hemostasis. Of course, one among them is vasopressin, and the second is uterine artery ligation at origin. So you ligate the uterine artery and give vasopressin, your procedure is going to be completely...
We will do that for you before your surgery.
Pardon?
We will do that for you internally before the surgery.
I will do it myself.
Okay.
And also for combined subserosal fibroids, to avoid parasitic fibroids, we are doing many cases combined procedures, sir.
Wonderful. Oh, who is your IR?
Deepashri, ma'am.
Oh, wow. Okay. Sure. There you go. Right. So now, unusual location of fibroids. This is a cervical fibroid. In the interest of time, I'll jump through. Dr. Akash, your thoughts?
So this is a cervical fibroid which is extending into the subserosal space as well. So I think surgery would be a better option, myomectomy, because it is quite an unusual location and
okay. I think I saw all of you nodding the head, so we are in agreement and we move on.
Yeah. Only thing is, in surgery, we have to be careful about the ureter. So just follow those techniques of keeping the ureter away from the surgical site. Recently, I removed almost 5 to 6 cervical fibroids. In that small little space, there was a bunch of cervical fibroids, very comfortably laparoscopically.
Okay, thank you. I'm going to pick Dr. Priya Jagia's brain on embolization in adenomyosis. Because apart from hysterectomy, there isn't a great option, I suppose, from gynae point of view.
Yeah,
So
yeah.
What's your experience?
Yeah, again, medical treatment is the first way to go, and we are offering embolization to patients who have not responded to medical treatment. So again, there is an issue. You again have to look for, whether they want a child or not, and all those things have to be kept in mind. So medical treatment first, and then adenomyosis.
Time is up.
And we did a study with actually 20 patients, and at 2 years, the result was very good. However, those patients who had associated large fibroids, they fared poorly actually. But otherwise, there was a marked reduction in the junctional zone. Symptom-wise also, the menorrhagia, the pain, etc., everything, was, so the technical success was 100%, but clinical success was, like I said, we had 4 patients who had large fibroids. So in them, the results were slightly suboptimal, but it's a good way to go whenever you have, and from what our gynecologists at AIMS tell us, there are a huge number of patients with adenomyosis who actually are refractory to medical treatment. So this is something we have started new. Yeah.
So thank you, Dr. Akash. 10 seconds. Yeah.
Ma'am, I would just like to disagree with you because the data says that when adenomyosis is associated with fibroids, it has. Yes, ma'am.
It is in contradiction
Yeah.
to what is
in the publications, it is written better. Yes.
Okay.
So these cases, we will do laparoscopic adenomyomectomy because gone are the days when we do have to do a hysterectomy or anything. These medical managements, I think maybe lupride will help to some extent, but
Otherwise, I think even if you remove some amount of the adenomyotic tissues, the patient will have tremendous pain relief. Otherwise, the dysmenorrhea will never respond to any of these things. You have to remove that adenomyotic tissues. And of course, she being only 36, I will prefer to do a laparoscopic adenomyomectomy. And various techniques are available during the surgery to preserve the uterus and to maintain hemostasis and other things.
A focal adenomyoma is okay, but diffuse adenomyosis, can you
Yeah,
still do
in
that?
diffuse adenomyosis also, we can give them lupride injections for a couple of months, reduce it, and then remove the mass.
Okay,
Yeah.
okay, done. Thank you. So I'm gonna skip the ablation, and will be the last case. A 40-year-old with symptomatic fibroids. Shuvro, this question is to you. Right uterine artery is very well visualized. Left side angiogram does not show the, what next? What should we do?
Okay, so firstly, in today's practice, if you have a cone beam CT, you could do the cone beam CT from the right injection and check whether the whole of the fibroid and the affected uterus is covered from one side, because you can have unilateral uterine artery covering the fibroid. But suppose if you see a defect, a gap, even either on DSA or on cone beam, then I will hunt for the artery. So hunting for the artery, routinely I will not do a aortic run with a pigtail, but in this case I will do an aortic run at the level of the ovarian L2, L3 and check whether there is an ovarian supply. That will also cover an IMA supply. So we do an AP and an oblique run just to make sure that IMA and ovarian is covered. And very rarely, only seen it once in my life, is a supply from the external. So those three things
Could
we
we
will cover.
do ovarian, looking for a flush aortogram or ovarian angiogram before a cone beam CT because it reduces radiation? Can we do that?
Okay, this practice has changed after cone beam CT for me, is because if I see that I'm embolizing the whole of the fibroid from one side, then I will not chase it so much. I mean, I can see that beautiful picture of yours, but you have to remember that that is not easy to do. That
It is.
technically is not easy to do.
At the same time, it's not difficult to do either. So on that humorous note, I think we'll have to stop there. Endometrial biopsy will obviously be speaking to the gynecologist and doing what is the age cutoff and all that should we do, should we not do. But thank you to the whole panel, more so to the gynecologists and all my colleague interventional radiologists. Great discussion. We're going to initiate the consensus guidelines and have the initial draft over the next 3 months and then take it from there. And hopefully by next meeting, we should be able to submit our guidance. Yeah. Thank you, one and all. I don't know if we have time for the questions. So the organizers are already looking at me angrily. So I don't know, we might have to close the session. Yeah.
Yes, sir.
Yeah, thank you. Thanks a lot. Yeah. Okay.
Okay, thank you, everybody. So we'll continue with our last talk would be industry symposium, coils in combination. For that, the moderator, I would like to invite Dr. Gerard Go, along with the speakers, Dr. Amar Mukund, Dr. Gerard Go, and Dr. Karthikeyan Damodaran.
Well, thank you everyone for attending this last session of the day. I can promise it's going to be a very informative and interesting session. So it's my pleasure to share the podium with Dr. Amar Mukund, as well as Dr. Karthikeyan Damodaran. So without further ado, I'd like to thank Cook for putting on this symposium, and I invite Amar, please start us on this session. Thank you.
So I would request AV people to kindly, yeah, right. I think somebody is doing. So good evening all. So welcome to this symposium. So this is a industry symposium where we'll be talking about fibered coils. So my talk is on the fibered coils, and let us understand how it makes a difference. Well, indeed, thank you. So ready to go. So the topic given to me was role of fiber structure in enhancing the embolization coil efficacy. So let us understand. So why do we need such things, or what they help in? So metallic coils are one of the most widely used embolic devices, and everybody knows that it works by mechanical blockade, thrombogenic scaffold, and vessel wall reaction. But over a period of time, in last decade, it has evolved, and there are different metals which is being used, like stainless steel. We have moved to platinum, and different designs and configurations are there for precise placement and better occlusion. So these are certain new things which are happening. Then let us discuss some of the factors which determine the thrombus formation, and that mostly includes adequate sizing or oversizing. Maybe depends which vessels are you targeting, so which one would you like, whether it is the same size or maybe slightly oversized. The density of the packing, how much packing is required. And finally, do we need to have coil enhancements? Like, we don't have any coil enhancement on neuro side, but yes, on most of the body interventions, we do need coil enhancements, and there comes the role of fibered coils. And synthetic fibers over a coil significantly increases the surface area and promotes the faster clot formation, thus provides enhanced thrombogenicity as compared to non-fibered coils. And this is how it has been further proven in a animal study which was published in JVIR in 2019. And here in this image, you can see the difference, how it looks. So one is the fibered, the first one is the fibered, the second one is a non-fibered coil. And when they compared the data in this animal study, they found that the number of coils required for the fibers were much lesser as compared to the non-fibered. So this mean number of fibered coil needed to achieve occlusion was significantly less. So statistically, that was less than the number of non-fibered coil, and we can see the p-value, it is less than 0.001. So actually quite significant. So I'll simply share in different circumstances how it turns out to be. So first, let us focus on end artery embolization. That's one of the common indication which we see. So this is one of the patient with lupus nephritis presenting with hematuria post biopsy, and then we know that such patients do develop aneurysms, and this was an aneurysm, and we know that renal arteries are true end arteries, and these are the most simple one. In the most simple one, here you can see my microcatheter reaching, and just a single coil. You can see only a single coil giving a complete embolization. So if you are using a fibered coil, just place one coil, probably couple of coils made. So even if it is not a densely packed coil, you can see the density is not much, but still we have received. So end arteries are a beautiful areas to work upon, and with fibered, you don't need multiple coils. But then let us talk about end arteries which are not true end arteries, like embolizing interconnecting arteries. And if we say interconnecting arteries, then maybe in liver, they are considered an end artery, but they do have interconnecting arteries. So this is a case of a 64-year-old male presented with cholangitis and melena after ERCP. And then you can see this ERCP stent, and thereafter probably maybe due to the wire which has been placed while doing a ERCP, there would have been some perforation of the vessel and leading to a large aneurysm over here. You can see this aneurysm lying here. And again, so as I said, these are interconnecting arteries. You need to do a sandwich embolization. Here, just putting a single coil is not going to help. So even in liver, like you do in many areas, you have to do sandwich embolization where you go beyond this structure and then you embolize both the ends, getting you a beautiful result and salvaging all the arteries. So here you need maybe 2 coils will work, provided your sizing and packing densities are fine. Moving to the next scenario, that is pseudoaneurysm, so trapping the pseudoaneurysm. So we all know that gastroduodenal arteries and pancreatic areas are the areas where there are multiple branches which supply and interconnecting channels. So here we have to trap the aneurysm from both the sides. So this is a case of chronic calcific pancreatitis. You can see here a large aneurysm over here, and it was being supplied by gastroduodenal artery, you can see, and my catheter is actually inside the aneurysm. So here the trick is to go bypass this aneurysm and then go distal to it. In case that's not possible, then probably you'll have to go from SMA side, and then from both the sides you have to coil. But we were fortunate and lucky enough to go beyond it. You can see a nice densely packed coil because of sizing and packing density. Then you can see this aneurysm, and when you go into aneurysm, you can drop a coil which may act as a scaffold and just inject some amount of glue which will stick to the coil and then come back and then over on top. So you can see three things. One coil is here, one coil is floating in the aneurysm along with the glue, and this is the third coil, which is so the back door, the front door, as well as the aneurysm, the whole thing has been taken care. And you can see some glue, and this area is thrombosed, which was nicely seen on the CT scan as well as, and this is the run, what you see, the angiogram, what you get after it, nicely with a good stump, and there is nothing on the liver side. Then there is another scenario. When you do a body intervention, there are many times you find an arterioportal fistula, and sometimes it may be due to interventions like biopsies or any kind of ablations. And here was a case where we did a microwave ablation for a HCC, and then the patient developed hematemesis thereafter after 6 months or so, and there were large varices. And then when CT was done, we could see that there is a large arterioportal fistula. You can see this arterial phase in which the portal vein is fully opacified. And then you go inside, you can see this is an angiogram in which this tortuous artery is seen. You reach exactly the site where the fistula is, go put it, and then this is done. So this is arterioportal fistula. So another scenario is arteriovenous fistula. So it is after GI bleed, post-resection. You can see this is a SMA run with opacification of the SMV branches, and you can go to the different branches, again, do similar kind of technique. So, in any scenario, if you use such kind of fibered coils, they are going to do wonders, reducing the number of the coils and giving you a complete occlusion. And not only this, if you have to do a parent artery embolization, like if you want to do a proximal splenic artery embolization, where you want to embolize the segment of an artery, there again it works very well. In case you can't place a plug, probably a couple of coils like this, and see here, it has taken care. You can see that packing is not good. Still, you see no much contrast going beyond it. So the parent artery embolization works. With glue and coil, again it works, especially this is needed on a venous side, like variceal embolization. You can see the paraduodenal varices, and you see this is the trans tips. We get into it. These are the varices. This is just like anti-grade embolization of the varices. You can see the tortuosity, how we have navigated the microcatheter. These are the bunch of coil. But to be very sure, like all these embolization, we need additional glue placement. That is what we did, and this is how we have totally obliterated. With this, I come to the final slide, that fibered coils show an excellent embolization outcomes in all possible scenarios in body interventions, including arterial aneurysms and pseudoaneurysms, AP and AV fistulas, veins and varices, and a fibered coil achieves a complete embolization and lesser number of coils, and fibered coil traps glue better than non-fibered coils. Thank you so much.
Thank you very much, Amar. We might leave questions to the end, so we'll move on to the next presentation.
Time is up.
Okay, so thank you very much. I'm going to be talking about the advantage of mechanical coils, detachable coils, and why do we actually need them? So speaking about the Cook retractor coil, so this is a platinum fibered coil, and those of you that use coils will know that platinum is very soft, that allows that ease of packing. It's a detachable coil that I'll talk about the detachable mechanism shortly, and it comes in a different range of sizes from 4 to 20 millimeters in two lengths of 7 and 14 centimeters. Now, it is fibered, and we've heard from a previous speaker, Professor Makund, the advantages of fibered coils. Now, the detachment mechanism on the retractor device is using something, what we call like a screw detachment, similar to a light bulb. So on the delivery wire, which is a nitinol wire, there's an inconel junction, and that's a special metallic alloy. And the coil is actually coiled into the last 8 millimeters of the inguinal junction. And so this provides quite a lot of stability. And when you're ready to deploy this coil, what you do is that you unscrew it like you're unscrewing a light bulb. Now, there are lots of different detachment mechanisms of other coils on the market. Some of them are fairly simple. Some companies will have a monkey grip. And one of the challenges with the monkey grip system is that as soon as your coil is out of the catheter, it's gone. And some have an electromagnetic or thermocoupling device where you need to attach a device to deploy the coil. So we can see here that the inguinal junction makes this quite visible. And importantly, because the coil is screwed on, the actual end of the coil is reasonably floppy and not very rigid. So this is a video here we're just going to play of the detachment. And you can see here, so there's an optional TUI Borst attachment here. From here we place our catheter down towards the region of embolization, and then we place the end of the coil just outside the catheter, and using a very straightforward anti-clockwise motion that deploys the coil off. And the next video, which has sound, so hopefully we'll hear some sound, is a case from the Guildford Hospital in the UK of placement of a device. So could we have some sound, please? If not, I can talk you through the case. So here what we can see is that the deployment device is attached to the end of the catheter, and the retractor comes in a single coil in that you can do this as a one-person job if required. What you do is that you advance an alternate wire through, then you can take off the attachment device. And we can see here is that as the coil is advanced, you can see that it's very soft, and then you're able to then adjust the way that it packs, or you can reposition the coil as you like. As you can see here, as the coil is more advanced, it can be withdrawn, and this allows you to really place the coil exactly where you want to, and it allows you also not to accidentally embolize portions of blood vessels or cause non-target embolization. So just a couple of cases, and I know that Dr. Damodaran's going to go through quite a few cases, but this is a case of a pulmonary arteriovenous malformation. We can see the pigtail catheter within the right main pulmonary artery. From here, through that catheter, there's a diagnostic catheter placed, and you can see this little pulmonary AVM at the bottom there, and I'll see if the video plays. An angiogram shows that you can see here the nidus of the AVM and rapid venous washout. Now, as you know, when you place any embolic device, the last thing you want to do is to allow it to embolize through to the arterial circulation, because you can end up embolizing a coil into the brain, for example. And so for this particular case, placement of a detachable coil allows you to have that stability to form that framing portion, and then you're then able to fill that up with pushable coils. This is another case example of an ovarian vein embolization. Amar showed a very similar case where you can see in this particular case quite a rich venous plexus. Here, a pushable coil is placed at the bottom, a detachable coil, and then we place a pushable coil on top. But as we perform the venography, you can see that there are lots of different tributaries. And so this, in my practice, we tend to use polydocanol. So what we want to do is form a plug at the bottom of the ovarian vein. We then fill it up with polydocanol, and then we top off with some pushable coils at the top. This is a more complex case. This is a young patient who had quite a large epicardial AVM. We can see here a catheter placed within the venous drainage, and we can see this rich network of vascular structures around draining into the nominate vein. From here, what we do is that we place an occlusion balloon near the nidus of the AVM, and then we injected some polydocanol. From here, what we don't want the polydocanol to do is to wash out. So here we place initially some pushable coils in the small different tributaries, But then to get the nidus, what we needed to do is to make sure that we don't cause embolization of any material out into the IVC. So in this particular case, we placed a detachable coil to be able to firmly fix it in the position we want. And then we filled it up with some MBCA to cause complete occlusion. And you can see that occlusion there.
Last 2 minutes.
The final case is a type 1B endoleak. And so this patient had a EVAR, and we can see an endoleak coming here. From here, we can see that there's an endoleak coming around from the iliac limb. So in order to treat this, what we need to do is extend the stent down into the external iliac artery, but also embolize the internal iliac trunk. And so this is a very common place that what we want to do is that we want to embolize the internal iliac artery, but ideally preserve some flow between the anterior and posterior divisions to reduce the chance of pelvic ischemia. And so I'll just skip this last case for the interest of time. So in summary, detachable coils really do give you that ability to have a little bit more precise control during deployment. And it's really good when you need to make sure that we want to deploy a coil exactly where we need to, or to form like a scaffolding so that we can use pushable coils afterwards. It also allows us to give us confidence to know that when we push pushable coils in, we're not going to embolize these into other important structures. And so we shouldn't be afraid of using detachable coils, particularly in select scenarios, because I think this helps to give us better outcomes rather than putting in a pushable coil, finding out it embolizes and then regret, oh, now I have to go fish it out, open a snare. So really, I think detachable coils really do have a place in interventional radiology. Thank you very much. So we'll move on to our last speaker. So thank you very much, Katakan, who will show us some cases.
Hello, good evening, everyone. Sorry, it's going to be the last talk of the day. I know you're all tired after the long day, so I will make it very quick. So my talk is on strategic use of combination of both pushable and detachable coils. So we'll move on. So Dr. Amma Mukund clearly explained how coils work. Coils have been around for a long time as an embolization agent, and it causes a mechanical obstruction with thrombus formation around it, and obviously adding fibers to it makes it more thrombogenic, helps it form a better occlusion, and you need lesser coils for it. So why do we need to use a combination of pushable and detachable coils? Clearly, Dr. Gerard showed that when you use detachable coils, you got a very good advantage of safe placement, but there's always a cost constraint, especially in Indian scenario. I'm sure it's abroad as well, because in India, at least, your detachable coils cost at least 4 to 5 times your pushable coils. So, but there are definite distinct advantages to use a detachable coil. As you can see clearly that a detachable coil gives you the main advantage. You can retrieve it if it's not in a good position. You're able to safely retrieve it out and you reposition it, or you can use another coil if you find it's oversized or undersized. Repositioning, as I mentioned, and you can get much precise deployment of these coils compared to a pushable coil. And because we can safely place them and make sure you end up in the right place, the chance of having partially coil deployed and then you find it's not going instead of prolapsing out is very less. So the risk of non-target embolization is very less, because all of us know that if you have a coil prolapse out, then you have a hard job trying to fish out the coil, especially this is going to be in an emergency sitting. Then you're already having a patient who is deteriorating, and then you have to go do an extra procedure to snare that coil out. As I mentioned, the cost is the only factor which would push us to do a combination of pushable and detachable coils. So what about the strategic use? Why would you use where would you use a detachable coil? So as Dr. Go showed as well, you can use it as an initial framing coil, and then you can use that as an anchor to park more pushable coils if it's in a safe place where you need a lot of coils, or you can use it as the last coil where you do a varicose embolization. You want to close off the testicular vein or the ovarian vein after you do it. You don't want the last coil to collapse out into the renal vein, because veins are sometimes very capacious and tend to stretch with breathing as well. So you want to make sure that the coils fit exactly within the vein. So when you can use some pushable coils down and then towards the top end of it, you use a detachable coil, you are rest assured that you know it's not going to come out of you. And last area is where you think you're in an area where your coil may not reach, because sometimes you get a stable catheter position, but when you try to get the coil in the right place, due to the stiffness of the coil, it may not reach that place. So if you're in doubt, if your coil is not going to reach the right place safely, it's a tortuous anatomy or in a critical location where you don't want to drop out, the catheter to drop out, then you can use the detachable coil. So these are the strategies to use it. So where would you use it? I was actually mentioning, so where you have a fast flowing AV malformation, where you want a precise embolization of the feeder vessel, because you want to be as close to the nidus. Of course, you're going to use other liquid embolics, but if you have a single feeder, single connection, you want to use a coil to block it off, then detachable coil definitely has an advantage. Again, arteriovenous fistulas being traumatic or congenital, where you want to exactly get to the fistulous communication. Even for splenic artery and visceral aneurysms, where if you're worried about the coil prolapsing out, then you can actually use a detachable coil either as the first coil to pack it if it's a big one, and frame it, and then you can put detachable, pushable coils inside, or you can use it as the last coil to finally seal off the sac. Again, hemorrhagic control, again, in a trauma case where you have it especially renal arteries and end arteries, you don't want to embolize branches which you don't want to embolize, and you want to get precise positioning, you can use detachable coils. And as I mentioned about tortuous vessel navigation, you're in a very, very tortuous artery, and you're not very sure that the catheter position is very stable, then detachable coils offer you the advantage that you can pull them out if it doesn't deploy properly. And branch vessel occlusion example is, if you want to coil off the GDA, we don't tend to do that much very often now. You can use pushable coils distally as you come proximally towards the hepatic artery. You can use a detachable coil to make sure that it doesn't prolapse out. So I think Dr. Go showed a lot of cases. I'll show you one case. This is again interesting case of pulmonary AVM. This is a young lady. He has hereditary pulmonary AVMs, and her sister actually died of this. This lady was 25. She had hypoxic. She is always hypoxic. So she had multiple pulmonary AVMs. So here's the case of hers. So that's the video showing, actually in this case she has, if you can see close to the thing, she has, I'm trying to get the marker mouse. So actually you can see the aneurysm is bilobe. There are two aneurysms next to each other. I don't know, it plays. So what we did is we used a plug to close off the larger feeder, and then after that you can see the other feeder to the top of it, filling the smaller aneurysm there. So in this case, we used a detachable coil because that vessel size is very small for us to use. We don't have microvascular plugs in India, so we have to use coils. And again, you want to make sure you get as close to the sac as possible to close it. So in this case, we used a detachable coil. This is a detachable coil from another company, just to show you. So what we have done is actually we passed the microcatheter into the feeding vessel, and actually you can see a little bit of coil looped inside the aneurysm sac itself, and we did a run to confirm you're in the good position. And then we slowly start packing the feeding artery there, as you can see. So once you, this is a catheter which has got this clasp mechanism to detach it. So once you tightly pack the feeder artery, then we release the,
Last 2 minutes.
Okay, so once we're happy that it's in the right place, you can even do a run at this place to make sure you have adequate packing, and then you can release it. So this works by the mechanism that once the end of the coil comes out of the thing, it detaches. So you have to make sure that you're in the right place before you do that. So once this was done, she had a few other AVMs as well, because she was very insistent and very anxious because her sister died of this condition. She wanted to get rid of every AVM. We had counseled her and told her that we're not going to get rid of everything. And so we had an angiogram on the left. This is after the embolization of these two. It's settled, and you can also see another smaller one up there, but I don't think that's clinically significant, we told her. So on the left side, again, she had a couple of AVMs as well, not as big as the right side. So in this time, you can see the run. And again, it's a very small one, but we talked to her on the table and told her it's a small one, but she still insisted that she wanted to treat it. So in this case, we used the Cook retractor coil, because we managed to get 4 French catheter all the way down there, because retractor coils come as 035 platforms. So in this case, you can see we tightly pack the coil, and then we unscrew it to detach the coil from the place. So it managed to really pack nicely in this place. And then we do a run. Is it playing? Oops. Now you can see that AVM is shut down, but you start seeing another tiny one, but we stopped it there. We told her that we will keep her under close follow-up. So as you can see, detachable coils definitely have a role in our embolization armamentarium for us to allow a safe practice when we think when it's a critical position or we want a very high precise positioning. These do have a role, but of course you can be using in combination with pushable coils to get good density coil packing and strategically use it to save on cost and achieve good results. Thank you.
Thank you very much for some very interesting talk. Just to end off the session, we've got a couple of minutes, so if you've got any questions, feel free to ask. But I might start with the first question that I think is a very common question with all detachable coils, is cost. Now, obviously in many markets, including India and Australia, a detachable coil is much more expensive than a pushable coil. So could you talk to the audience why it's important that we can still use detachable coils even though they cost more?
As I was mentioning in my talk, in India at least, even the Cook coils, the Cook detachable coil at least costs roughly 5 times the cost of a pushable coil, the Nesta coil. So again, you have to be very cost conscious because sometimes you have to deploy multiple coils, but definitely, as I said, you definitely have an advantage, the safety margin of precise positioning and comfort in doing the case rather than worrying about the coil prolapsing out, because you're trying to put a very long coil and half of it's packed and then it starts prolapsing out, then you're struggling with it. So it definitely makes a difference in practice.
That's interesting, but apart from it, there are two things. So one is precision, and one is actually dense packing. So wherever you feel that packing has some role to play, and you need to put multiple coils. And I'll give you an example. Like, I try to cover most of the scenarios, and then there are certain scenarios where you do need to do a parent artery embolization, where the number of coils needed would be much high, but you have to secure it at a particular position which is very precise. You can't go beyond it. You can't keep it proximal to it. So those are the areas which can be covered up nicely. Second is the venous side of embolization, because if you go into the portal hypertension side, so there are a huge the use of coils for the venous embolization. And wherever you talk about venous embolization, these small pushable coils, 1 or 2, actually makes no difference. You put a coil and you find that it is just a piece of metal hanging there doing nothing. But there you can create a good scaffold at the location what you want, probably the most narrow part, and couple it with NBCA glue and have a better result. So there are different scenarios as well where you can use it, apart from the precision and the dense packing which we need.
Yeah, I agree. I think that particularly when we're performing embolization, I've had so many times in my early career where you think, okay, I'm going to use a pushable coil. So you put a 5 centimeter coil in. Okay, we need to pack it some more. Put another 5 centimeter coil. Oh, it's not quite right. Look, I don't want to prolapse too much. I'll put in a 3 centimeter coil. And before you know it, you've used 3 pushable coils. Whereas actually now with the detachable coils, you have that confidence to use a 14 centimeter coil to achieve the same packing density. And I think that, this has been proven in a lot of published papers out there, the cost advantage of detachable coils over pushable coils. So I really think that we shouldn't be afraid to use them. And in fact, with the detachable coils, I always think it's always about using the correct tools for the right procedure. I think, we wouldn't go to try to fix our garage if we've got a nail and you're trying to use a screwdriver to fix it. Sure, you could get the nail in slightly, but I think it's important that we choose the right device for the right procedure. And we shouldn't think too much about the fact that it costs a little bit more. And so, Amar, can I also ask, now fibered coils, you gave a great presentation about the advantages of having fibers. Do you think that there's also some cases where having too much fibers is not good? Or, if there are a few fibers, can we have a little bit of fibers? Do you think there's any difference?
So if you ask me, so most of the location we would want to have a very tight packing. But having said that, especially when you are placing a coil at bifurcations where you don't want your thrombus to hang down. So those are the locations where you have to be very, very precise. Maybe if the landing zone is less, then you will prefer a less fibered versus a more fibered, because more fibers, there will be some loose fibers hanging down, along with it some of thrombus hanging down, which may protrude on the contralateral side. And so any kind of bifurcations, what a Y-shaped of bifurcation or a trifurcation, and you have to put a coil over there, maybe less fibered, maybe a better idea. But you again, it depends like how do you place it. But with detachable coils, there comes a difference. If you have a detachable coil, you can precisely place, and whenever you feel probably it is coming down, you can pull it back and reposition it. So those are other advantage when we talk about fibered versus less fibered. So is there any chance of using a retractable coil and prevent non-target embolization of any other artery, any branch artery?
Yeah, I agree. I think there's a balance between too many fibers and not enough fibers. I think we've seen good evidence to show that fibers increase the thrombogenicity of coils, but particularly for detachable coils, what we don't want is too much fibers. And I'll use the example of like a toothbrush, because when you put the coil into the patient and you decide, okay, I want to change the position, already on a microscopic level, you're starting to get formation of some thrombus on the fibers. And so what you don't want to do is create a coil with too many fibers, because first of all, one, when you retract the coil, you're going to shave off some thrombus. But more importantly is that if you've got too much thrombus, you might not be able to actually retract the coil. So I think the coil design is extremely important in reaching that nice balance between having too many fibers versus not enough fibers to cause embolization. And I think that also with detachable coils, because you can pack it, you've got that really good ability to really tightly pack it if necessary. You're creating that greater cross-sectional occlusion over your target area. Are there any questions from the audience? Okay, well, we might wrap that up there. So thank you very much for everyone for attending this symposium. Thank you very much to my well-esteemed speakers as well. And thank you very much to Cook Medical for making this session possible. I do encourage you that if you do get a chance, please go to the Cook stand to have a look at the retractor device, because you can actually play with it on the bench top. So thank you everyone, and enjoy the gala dinner tonight.
முடிஞ்சுங்களா? அவ்வளோதான். அங்கே தான்